ultimate goal is really achieving the total health of the patients, not just manage a disease as an episode as currently we are charging this. The trend is going that way. And a very important area is really often neglected actually at least in the American system is really mental health, which become a hidden cost and burden emotionally, financially to the country, which a lot of them is outside hospital wall. And how do we using this smart hospital to improve this large population of relatively less neglected populations? That'll be interesting. Marcy, will be interesting point.
Yeah, so I work in a hospital, and I had to look up the term smart hospital. I don't know how many of you have actually heard of smart hospitals. I hadn't heard of the term. And so it makes a lot of sense. Like from a patient perspective, my sister had open heart surgery. She was in the regular patient room. And if you think of our patient rooms, they haven't really changed all that much. And we have such technology at our hands now. We have AI, we have smart things. One of the things we really did learn from COVID is that the isolation impacted the patient and impacted families, it impacted the world at large. And so concepts like being able to have the ability to have a smart tablet right there, and all of a sudden, your family, your friends, or whoever, you can talk to them, you connect with them. My sister, when she had open heart surgery, she actually had fallen and was on the floor for 20 minutes and had no way of being able to get to the call for the nurse. I have an aunt that was 102 years old, and in her later days, she needed to press that button, and she wasn't strong enough. So, thinking of it from a parent or a patient experience and how we can really use that technology is going to be really important. Myself, my patient experiences, they found a rare brain tumor. It wasn't a cancerous brain tumor, but I needed to have a gamma knife surgery, and it was amazing. It actually was an outpatient proceeding. It lasted about an hour and a half. I went out to breakfast that morning. I went to a show that night, and they had stopped my brain tumor without even cutting my head open. But I had an equally different experience with the neurological parts. I saw 6 different specialists. Nobody could stop the internal tremors. And so I had to really take my health into my own hands. And so being able to have a framework that encapsulates all of this, all of the things that we've gone through in terms of the mental health struggles that we've had, and how do we put AI together with the mental health, with the fatigue that all of the clinicians are feeling. And so I did develop a framework for that. I do have a few pointers for you if you want to take a few notes. I think the main thing is just to ask the question, and this can be done in 2 seconds. How are you, and what do you need? We actually had a supervisor come around at the end of the day and ask all of us clinicians, how are you, and what do you need? So we can do that with our coworkers. We can do that even with our supervisor and administration. We can do that with our patients. We also really need to think about the skills that we need to be honing right now. I mean, we have a little bit of a post-COVID world right now. We know political stuff is coming. We know all these demands. We know financial stuff is coming. Use that time to really build those skills. Deep breathing actually can be as effective as some of the short-term medications for anxiety. So really build your skill set. If you think of observing as if you were in a lighthouse and you're looking at your patient and you're trying to figure out, where is that patient? Are they in the deep water? If they're in the deep water, you're going to need to get mental health in there and involved. I work in an adult partial hospitalization with patients that have either tried to commit suicide and they've been in the hospital and they're on their way out, or else it's a prevention for going into the hospital. And we can get as tech savvy as we want, but you know what? If that patient commits suicide, it doesn't matter. So we have to have mental health at the forefront. So it's worth the time. I started as an integrated behavioral health worker in the setting of the docs and nurses. And so basically how we were able to integrate that is the docs and nurses would ask the question, how are you doing? If you see tears, bring somebody in. Like really talk with your hospitals to see if they can have a mental health person. So I would go in they would be on to their next patient. You only have 10, 15 minutes, right, with your patients. And so I would have a conversation with them about mental health. A lot of them had never stepped inside mental health, and they were, yes, I really want that. So there's some ingenious ways of being able to like combine all of it. It isn't the answer just to say, oh, you need mental health, I'm going to send you somewhere. Like we need to really be implementing that within the same system.
It's a very interesting point about the outpatients, the underlying. As I say, the most you can see a lot of service is actually moving outside the hospital, not just a standalone. You can see more facility being moved outside the whole ecosystem going forward. But having said that, actually, you guys, we are in the healthcare business for a long time. We realize that, the recent trend going on is country dependent, of course. In U.S., the trends toward really a corporatization of hospital, the hospital getting bigger and bigger. And the one who survive are the marquee system of a huge chain. They have the resources to implement this technology to train their staff to be more competitive. So what happened, all these mom and pop small hospitals, well, they're not that small, but compared to this giant, they are small. When they don't have investment, how can they survive? I'm not quite sure this is a trend, good or bad. I mean, but recently, there's because of this new concept of smart hospital, people start thinking about maybe it may not be everything corporatization. Maybe it's a retailization hospital system. You have a whole ecosystem. Hopefully, people partner each other instead of horizontal, instead of vertically integrated. And I don't know if this is happening or not. We still yet to see. But I'd like to hear from Ravi, because you have a lot of experience in Asia, in Europe. I don't know what happened in that area.
I think even in India or even other parts of the developed world, we do see consolidation of hospitals happening. There are sort of greenfield and brownfield hospitals that are either acquired or they sort of start off fresh. More so on the specialty side, that is what we get to see now. So from that perspective, I think there is a ton of investment that is going both from the private side and from the government side in terms of building up infrastructure for the hospital. But having said that, given the norms that we are in the developing world and also in the rural parts of the developed world, the amount of investment that is needed to sort of get the care to the level that we want across the segments of society is almost impossible. And that's where intelligence and AI actually comes into play. Like for example, you talked about the cost, and I will touch that in a minute. Take for example, a ECG machine. A ECG machine today is with a cardiologist. What if I were to sort of make it so cheap that it goes into the hands of a general physician in a village? Now the question that comes up is saying in a rural segment, the general physician may not be qualified enough to read the ECG. Fine. So what I would possibly do is take the ECG, push it up to the cloud or any other server system where I have an algorithm which basically interprets the ECG and gives the result as a first level of diagnosis. Now when you start doing that, that's the way that you are going to decentralize care, and that ECG could be actually given free of cost. We have done economics to say that even if the machine is given free, if you start charging on a per transaction basis, you will still be able to recover much more than what you would have if you had sold the ECG as a CapEx model. So there is a certain amount of transformation, a commercial transformation that is going on hand by hand, side by side, along with the business and the technology that is driving it. So we can sort of come to a point wherein we will be able to sort of drive the level of care that we want with the resources that we have using the technologies of date. What I told you on ECG is basically a hub and spoke model, so to say, which can be sort of decentralized. The same is the case with remote ICUs. Remote ICU is basically, in India, for a population of 1.3 billion, we have got 500 intensivists out there. Indonesia, population of 280 million, we have got only 50 intensivists out there. So these intensivists are the ones who are basically able to drive outcomes into a critical care setting. Now, what if I had a capability by which the data from the remote side comes onto a hub where the intensivist sitting in a tier 3 or a tier 4 hospital is able to look at those data and then draw interpretations and advice on to the doctors, a GP or an anesthetist at the far end, in terms of how to manage the care. So basically what you're now trying to do is to use the capability that exists in the center out in the spoke, and that's certainly possible using technology. And once you start looking at per transaction cost and pay-per-use mode and stuff like that, you are able to drive the cost down, and the volumes will also kick in, which will sort of push the cost to the left. So there are ways and means by which this deployment can be done, and we do get to see this happening in the emerging world for sure.
It's a very interesting point. Actually, I didn't think of it. As I mentioned, about 30 years ago, we have 10,000 hospitals in America. Today, we're about 4,400, something around that number. Our population increased in the last 30 years, definitely more than 30%. So what's that mean? The hospital getting bigger. And it seems like smart hospital is really smart. Maybe we can make it that instead of centralized, we make it more democratic, decentralized. If the technology cheap enough, small guys can also implement those technology effectively and work with the big guy to create a total ecosystem. No one knows everything. A complete vertical integrated system has a pros and cons. And I think healthcare is not a pure business. Healthcare is about humans and about ethics, about human health. And money is not only measurement like the other corporation industry. We need to take care of the mental health issue, depressions, patient feelings. All these are important why we're in healthcare for. And maybe with this smart, cost-effective technology like IoT device, ECT, if we implement effectively, the small hospital clinics can play with the big guy, work together, provide total integrated care.
And also bring in the commercial transformation into it, the business innovation into it, along with the technology innovation, so that the combination of it can make it really effective and drive the costs down, as also pushing up the outcome. So you start meeting all the elements of the quadruple aim, which is basically enhanced patient experience, enhanced caregiver experience, positive outcomes, and lowered cost.
It's very effective, actually, interesting. Actually, I think about it, the IoT device recently make a lot of change in clinical trials. It's starting changing how clinical trial being conducted. I don't, Shia-san, you have any comment on that?
Yes, definitely the IoT device sensor, including the multiple wearable device, is now changing our environment in the biopharmaceutical industry or clinical operation. So as everyone mentioned, that smart hospital means we can say a really data-driven platform based on the hospital, because the data is coming from patient. That means coming from hospital. So such IoT or sensor is now really focused on the patient data, how we can collect the variety of type of data from the patient, not only like daily medication, but also our daily activity or maybe some phenomenon from our body. So now lots of startup companies or investors or industry side are trying to develop such the product to work with technology vendors.
Yeah, Lorena, you have any comment on this since you work on the software support side? Have you seen
Yes. Yes, IoT devices are getting advanced. I'm reminded of some work we did for Walmart, where they wanted to have personally controlled healthcare records for all their employees. And it was an Intel incubated project. And when you get onto a treadmill, there is a device which sends your data on a daily basis, and you can upload it to your EHR. There was also a device which goes onto the weighing scale, and every day you can upload it to the EHR. So IoT devices will play a very major role in smart hospitals, and it will, the only thing is there'll be so many of them, and there'll be trillions and trillions of signals and big data coming in. And again, the problem of analyzing this data comes in. So IoT devices and data would be the key for smart hospitals and also moving healthcare to home. That's my thought.
Yeah, it's a very good point, actually. You mentioned recently a couple of, I'm sitting on some board of the device company. In the clinical trial, in fact, IoT is very popular, but the experience is making minimum, only one endpoint, one IoT. Don't load the patient with tons of it. You're at home environment, patient won't, not like ICU, you load the ICU patient with tons of information. In home environment, most of them just, they experience so far. In the beginning, they loaded the patient with all kind of IoT devices, finds completely useless, not get anything done. So they only measure one thing, your heartbeat, just measure your heartbeat. And measure your sleep, measure, by the way, sleep is very hard to measure at home. I just realized that. I don't know how your sleeping pattern. We flip a lot, we don't know at night. The device don't really measure our sleeping pattern very well. So you try Apple, it's not reliable. At least other clinical trial people told us. And it's very challenging. That's the reason when you have a sleep problem, go to a sleep center. At least make sure they have a device, make sure you correct diagnosis. That's one measurement on this part. In terms of the mental health, I still want to get back to the area. I think because our system, at least US system, we clear ICD-9 code, ICD-10 code, we charge by certain thing. And cancer, all these things, and heart disease, those are charged by procedure. And it's done by hospital. Mental health, yeah, I talk to you, I'll give you a drug, nothing much you can do about it. I just wonder, your experience so far, how the technology and this new big data may help in this area. There's a large population of people out there.
Yeah, I think the main thing is just really keeping that patient experience at the forefront, whether it's just a conversation with the patient or whether it's technology. When the doctor was meeting with my sister, he basically was having a conversation about there's several different valves that we need to try. One of them probably will work, but when your heart stops beating, and he kept going on, and he says, "Are you okay?" And she's like, "No, I'm not okay. You just talked about my heart stopped beating." And he says, "I'm so sorry. I have this discussion with patients all day long." So just really keeping at the forefront what's happening with the patient, what's their experience of what's happening, whether it's AI or whether it's just a conversation with the patient. And just really keeping hope. That's the main thing that you can give that patient at that point in time is hope. And our job really is about self-care for ourselves, for our coworkers, and for administration.
So yeah, I think one thing you realize that our mental state affect our physiological state a lot. We are stressed. We are more susceptible to a lot of diseases, cancer, all these things. Because our body just release things to trigger certain things. A healthy, balanced state, it help make the patient healthier and then recover faster. The wellness, rehabilitation, all these things. In the past, during the pay-by-procedure era, people don't care too much. Now insurance companies say, I cannot pay forever like this. We already hitting 20% of GDP, $4.3 trillion last year alone. And a country cannot keep going this way. And we really find a smart way to make it more cost-effective and effective. And I think the smart hospital is one of the recent movement which move away from the original 2000, which is big corporation, big hospital, incorporate EMR, robotics, all kind of things, only heavy capitalization approach to make the hospital very competitive. I think now going forward is we look at the patient as a total health smart hospital, not just a disease management, but health management, and look at the hospital without wall. And this is more promising. And promising is not altruistic, really driven by payer. Payer say, I can't afford to pay so much forever. You put a Da Vinci machine again, I charge double my price in surgery. I can't afford every time you do that. The outcome is not necessarily good. And also the way we measure outcomes in hospital, we don't measure well. We do midpoint outcomes, we do surrogate outcome. We rarely have total outcome of patient, which is the patient's cure. And very hard to get those data. If we don't have an integrated network, in hospital alone, we don't have it. And that's the way that the smart hospital going to become an ecosystem, incorporate many things. So overall, I mean, this is an exciting movement. Next time people talk about smart hospital, smartness doesn't mean that it's costly, like 2000. It can be like cheap IoT, you're using smart way or integrating together. You can deliver adding values, adding the quality to your service much better. You can partner with other people, not just your own hospital, your small clinic, maybe the nursing home, the other thing. Effectively talk. Now the communication is so cheap, IoT is so cheap, internet is so cheap. It's a way to how to integrate the workflow together besides the one single entity. That's what the smartness. Ultimately, we want the patient at better outcomes. This is the ultimate goal we are here for. And I think all these high-tech, high-tech without high touch is still missing. I think this is the part that people, I think this generation of smart hospital, we are smarter to know that we need to add some high touch back into the business to make it effective. So I think I like, yeah, go ahead.
Yeah, in fact, I just wanted to give a scenario to you here, Stephen, saying that we know that for a radiologist, 15 minutes is spent on looking at the, in talking with the patient, and the balance 45 minutes looking at the image and talking to working with the RIS and stuff like that. This was we actually saw. I walk into a clinic, the doctor keeps a mobile phone besides us, and he keeps talking to you for 20 minutes, okay, which is double the time that he would normally spend with you. The entire record, the phone picks up all of what you're talking about, and by the time he tells you, okay, fine, the diagnosis is already done, I have whatever has to be done, you will find it outside. So you walk to the outside to the room, and a technician hands over the entire prescription to you with all the details in it. So by doing this, what you're actually doing is to double the time of the doctor on the patient, make him a lot more attentive and looking into what your actual needs are than spending the time on the EMR. By doing so, you are able to triple his throughput in terms of what he's actually doing. Like say, in an hour, he now looks at 3 patients, wholly attending to what the patient needs are, but at the same time, not compromising on the quality of the outcomes or the diagnosis that needs to be done. So that's where it is heading. It's not only restricted to the hospital, you also see this percolating down to the diagnostic centers and the physician's office and stuff like that.
Yeah, Ravi, that's a very good point. I like to echo that actually. Nowadays, physicians or nurses are really tight, right? You understand the matrix measurement. And for radiology, time is money, spent with the eyeball. That's how get income from. And the technology can help. In fact, if you look at it, for those of us working in hospital, we realized a lot of nurses and physicians actually doing a lot of mundane screening, standard procedure scoring. And those things can be actually replaced by machines. The final decision can be done by human, but you don't need to tie up a triage list to look at something if AI can do much better. So we have for example, we have a stroke. ER room come to stroke. You know, we miss 50% of stroke in this country. We miss 20% and overdiagnose another 30%, about 50%. Very poor rate. Stroke is very difficult. There are many reasons. And we actually do an AI system to look at video and auto voice, standard protocol, automate, and we compare with the humans, actually better than human. This is not surprising, by the way. AI, when you focus, when you have enough good annotated data, that's very important. Data quality is important, as Ravi say. When you have good annotated data, AI can beat human on a specific disease. This is a very proven many times. Humans are very good at, we have looked at the whole heuristic, we look at the whole spectrum of things. AI so far cannot generalize enough to understand what it is. But at least for the stroke phase, we do a lot of automation of triage, we do automation of imaging, we also do automation of the NIH scoring, which is standard procedure, to monitor the patients. The end of the result is the neurologist is very happy. He said that they spend about 30 minutes to an hour per day just doing this mundane scoring procedure. Right now we help them to spend more time at the bedside, which AI cannot automate. This is the part the machine cannot do, human touch. We need to spend more time, give more time, use the technology, automate the part which is mundane, repetitive, give more time to the caregiver, closer to the patient bedside. That's what patients need them most. I think this is how the healthcare is. I think this totally agree with this part. I think this is smart hospital is also smart in the high touch, as I mentioned this area before. I think this is a very good talk. We have a couple of minutes. I don't know if anyone any burning questions, and happy to ask the panelists, full of a lot of experiences in this area. Anyone? Don't be shy. Yeah, you can use the mic. You can.
So thank you very much for the question. So from my perspective, based on my current activity, we are trying to implement GPT-4 or federated learning technology to collect such qualified data from hospitals, like a system. So that's one of our challenge.
Or maybe I can go for it. In the sense that the handling of data is always a challenge. The question is, if you look, data could be in form of numbers, it could be in the form of images, it could be in the form of cine loops, it could be genetic data. The question that comes up is, how are we going to integrate all this data and come up with a meaningful insights in terms of looking at a object or looking at an organ from a 360-degree perspective. The answer is we have platforms that do all of it today. The answer is no. And with the amount of data that is actually coming up, you really don't know what is valuable and what is garbage. So the industry per se is actually struggling in terms of how to sort of pull all of this together to create a data lake of sort by which you can draw meaningful information as and when needed. So the answer is, we have not solved the problem yet. We are still working on it.
Thank you. You can ask the panelists after the talk if you're interested. Thank you.
Thank you very much.
Thank you.
Thank you.
Huge thank you to our panelists and the experts for this amazing session. If you have any questions for them, you can ask them later in the convention. We're going to take 2 minutes to prepare for our next speaker. Please get some water, get some coffee, stand up, stretch a bit if you need to, and we will be starting the next session momentarily. Brilliant. could have a handheld, walk on the stage, use the podium. Whatever works for you.
Check 1, 2, hey, hey, yep, 1, 2. Check 1, 2, hey, hey, yep, 1, 2, check 1, 2, hey, hey. Check 1, 2, hey, hey.
We will be starting in 30 seconds.
Check 1, 2, hey, hey. Check 1, 2, hey, hey, yeah. Check 1, 2, hey, 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 yep, okay. Check 1, 2, hey, hey, yep. 1, 2, yeah, yeah, hey, hey, yep, yep. All right, hey, hey, yep.
Test, test.
All right, ladies and gentlemen, and alternative identifiers, we are back. Keeping up with the momentum of our day, we're going to move into our next session. Gone are the days where traditional forms of patient care were enough. Today, the use of digital tools such as telemedicine, mobile health apps, and wearable devices have paved the way for an era where patient care goes well beyond the walls of hospitals and clinics. Joining us in this keynote session, our esteemed speaker, Carrie Officer, Vice President, Service Delivery Innovation, Center for Health Delivery Innovation, Nemours Children's Health. She will share her knowledge as she examines the topic of this session, going well beyond medicine through digital engagement. Please put your hands together for our speaker, Carrie Officer.
Thank you. So good morning, and it's a pleasure to be here, and thank you to Health 2.0 for bringing us all together. Hopefully we can make this an engaging experience. I enjoyed the talk earlier, and I'm going to talk a little bit about the humanization of healthcare and where we're headed and kind of blending the technology with the personalization and humanization of healthcare. So looking forward to the dialogue today. A little bit about Nemours Children's Health. We are a pediatric health system. We're based up in the Northeast. We have a freestanding hospital in Wilmington, Delaware. And we are also based down in Florida. We have a freestanding hospital we opened about 11 years ago in Orlando. We service both markets. It makes for interesting deployments because very different regulatory environments and policy between the two. So that keeps us busy. So today's presentation, I'm going to talk a little bit about Nemours Children's Health and how we are deploying technology across the continuum of care to improve patient engagement and outcomes, enhancing care coordination and delivery, and even going well beyond medicine. So you're probably saying, well, what does that mean, going well beyond medicine? We're at Nemours Children's Health, we believe in the whole child and supporting every aspect of the continuum.
That includes emotional, behavioral, economic, and even environmental conditions that impact children's lives and families. So it's really important. You heard a lot earlier about technology. There is a huge buzz around digital technology today, right? You hear about AI, interoperability, all these capabilities that we have at our fingertips, which are truly amazing. I personally am excited to implement them all. But what we cannot lose sight of is that human-centered experience. And so we believe at Nemours, when we're getting ready to deploy any type of technology, we don't start there first. We start with the problem. We pull all the stakeholders in the room. That's patients, that's families, that's consumers, that's healthcare providers and technologists. And we apply human-centered design and really build out the journeys based on what we're trying to accomplish. We use agile methodologies in order to quickly iterate. Sometimes we have to change. Sometimes that hypothesis didn't work. And so we have to deploy and really adjust the way that we're deploying our technology. So the picture of this family here today, this is a Nemours family. And little Kai, who's sitting in the middle, is only a few months old. Before he was even born, he was diagnosed with a congenital heart defect. A few weeks after he was born, and of the months preceding, he had 3 open heart surgeries. It's families like these that help us figure out that we must do something more. And so today, I'm going to walk through a journey with you and illustrate what we're doing at Nemours in order to impact the lives of these families. So this is a busy slide. Down at the bottom is our strategy. We are focused in my team and the whole organization, on deploying improved patient experience through the use of digital technology. Not only are we in an era where consumers, patients, and families are demanding things to be more convenient. They want healthcare to be more like other industries. It's time for us to step up. In addition, we are also seeing burnout from caregivers. They have gone through tremendous pressures through these, during this period of COVID and beyond. A lot of them are retiring. We must begin to address these challenges internally as well and leverage automation to the benefit for not only the patients and families we serve, but also the caregivers that are taking care of these families. So I'm going to take you through a hypothetical journey today of a family. I'm introducing you here to Steph and Jim. And Steph and Jim already have a 2-year-old that you can see here they're playing with. In addition, they're expecting a child. And in a routine ultrasound that they go in, they find out that their child has a heart condition. After some additional tests, they find out that their son has hypoplastic left heart syndrome. Sounds pretty scary, and it is for a family facing this, to even know before your baby is born, you're going to have to go through a pretty hefty medical journey. So as any prudent parent would do, once you hear this news, they go onto Google and they search. Fortunately, Nemours is invested in education, Nemours Kids Health. You can go to kidshealth.org. We built this website back in 1995 and have been investing in it ever since. It is the world's renowned source for health education for parents, kids, and teens. And so we bubble up on the top of the page and teach Steph and Jim all about the condition that they're willing to face, or they're going to have to face. So they fill out a little form once they have, they fill out a little form when they're on the page to learn a little bit about Nemours. And they're entered into a nurturing campaign. And this is an example of that. So for several of our top subspecialties, we actually have parents go to these forms. They can fill out information and are entered into a nurturing campaign where they're sent emails and then also followed up with from clinical care teams. So one of the emails that they receive from the nurturing campaign, they are sent to nemours.org. So at nemours.org, they have an opportunity to learn more about our clinicians to learn about our clinical care teams, to learn about their bios, their research, and most importantly, their outcomes for these types of conditions. Jim and Steph are starting to build confidence and educating themselves on this journey on how they're going to be able to pick their care team. So fortunately, since they enrolled in the campaign, they receive a call from the cardiac care team. And they talk to them a little bit about their questions, what concerns do you have, and through that conversation, they're offered a consultation. So as a part of the consultation, actually Jim and Steph don't live very close to Nemours. They're about 2 hours away. So having that opportunity to transport and go have an appointment and just have a conversation seemed a little overwhelming. And so the care provider offered them a telehealth consultation. They loved it. They said, absolutely, we'd love to do that. And as a part of that, they had never really experienced telehealth before. And so they were put into an automated chatbot. And they received information on how to prepare and get ready for their telehealth visit. This was very reassuring to Steph and to Jim as they then prepared for their telehealth visit. So we are utilizing telehealth chatbots in a number of different use cases. One is for the telehealth chat, and at Nemours, we actually saw a reduction of 50% in no-shows, which was pretty surprising to us that this type of automated communication could reduce no-show rates. So that really opened up the door to ensure that our clinicians were staying productive with their time and that, wanted spots didn't go wasted. The automated chat program, conversations unfold automatically. They provide highly personalized guidance to help keep patients on track and truly serve as an extension of the care team. So this is a chart, and at the bottom of it, it lists the use cases that we have deployed in relations to this automated chatbot. So in addition to telehealth, we also applied it towards appendectomies, tonsillectomies, and you can see the number of other use cases below. The blue bar is the satisfaction rate, which was significantly high across really all the use cases. Parents liked it. The engagement rate was really dependent upon the use case. So you can see the care deliveries around appendectomies and tonsillectomy, the engagement rate is significantly high. In fact, right now, we're doing some research around tonsillectomies, and we are seeing a statistically significant, I should say, impact on ER bounce back utilization. So these chats are working, they're engaging, parents like them, they provide our education, they provide extensions to the care teams should they need our help. In addition, our care teams are really finding a lot of value. Now they're monitoring the dashboards and they're reaching out to those parents who need them, not making unwanted calls, but truly connecting and helping those patients in need. So Jim and Steph proceed with their telehealth consultation. They find it easy and convenient. They were well prepared through the chat to be able to have that. And not only do they have the opportunity to leverage the telehealth visit to meet with a cardiologist, the cardiac thoracic surgeon, and also the prenatal perinatal team, they could do that all in one sitting. They didn't have to do separate visits, so it made it really convenient for them. And they decided that they wanted to move forward with Nemours to take care of their child. So a few weeks before Steph is due and the baby is born, they actually need to move a little bit closer so they can take care of various tests, appointments, and get ready to have their baby. And Steph is a little concerned. They live 2 hours away. She works full time. She's not going to be able to work during this period. They're on a budget. They don't have good equitable transportation, and they're concerned about lodging. And so one of the care coordinators reaches out proactively and asks Steph if they need help with these things. She's overwhelmed and a little bit wowed. I can't believe a healthcare system is concerned about how I'm going to get to you and then where I'm going to stay when I deliver my baby and then also post-delivery as well. Steph remembers filling out a questionnaire. And Nemours was asking her about some of these social determinants of health. So as part of the intake process at Nemours, we ask our families to fill out social determinant of health questionnaires and screeners within the Nemours app. That information is then tagged, and if activated, the care team members proactively reach out to connect the families to other community programs that we built relationships with. Now, the success of this program is truly dependent upon those relationships that we're building in the communities that we serve. It's really important, and you can see a list of some of those here. We even are using technology to try to advance some of those connections. So for example, the Data Access for Student Health, or the DASH program as we have called it, we have built a database with the schools in the communities we serve. And when a child is absent more than 3 days, we proactively reach out to see if they have any health concerns or issues. Again, it's about seeing what's happening, being proactive, and then leveraging technology to our advantage and to the parents' advantage. So a few weeks, as I had mentioned, Steph and Jim come to the local area. They have several appointments and tests that need to be conducted before Steph has the baby. And they're impressed when they go in and meet with the physicians in person. They spend a lot of time with them. They're not typing on a computer at the same time. And they felt like they had more time with the clinicians, answering their questions and calming their concerns. So we have a small team at Nemours who, on a part-time basis, really focuses in on physician burnout and the amount of time that physicians within our health system are spending in the electronic health record after hours. They monitor it. And they're always looking for ways to be able to improve clinician workflows and reduce the amount of time that they're spending within the electronic health record. We implemented a system called DAX, Dragon Ambient Experience. And this system is AI enabled. Its whole focus is to improve the patient experience between the physician and the provider and completely reduce the amount of time that providers are spending in the electronic health record. It's been super successful. We did a pilot with about 25, 30 physicians. We not only heard from the clinicians that they love it, they feel like they have more time to be able to focus in on the patient care and not worried about building or documenting within the electronic health record. The ambient software actually listens in and takes that full conversation, creates a full note, and then the physician can review it and sign the note at a later point in time. Parents love it because they feel like the doctors are more focused in on them and not typing away in the middle of the visit, which is somewhat distracting to parents. You know, a lot of things that we have heard from parents, what are you typing about me? What's happening there? And so those are really important aspects of the whole care delivery. And so that's one use of technology that really can benefit not only the patient-family experience, but also the clinician burnout factor and the amount of time that clinicians are spent documenting in the electronic health record. So Steph and Jim have their baby, and a couple weeks after delivery, their baby goes into surgery, is doing wonderful, comes out, has quite a lengthy inpatient stay at the hospital. And we've really focused in here with the cardiac team spending a lot of time with the parents getting ready for them to go home. What do they need to learn? What do we need to teach them? And we leverage our educational material that we've developed through videos. They can watch it on the inpatient TVs. We leverage our patient instructions, which are written in the 4th grade reading level and have illustrations. Those are at their fingertips within the Nemours app when they go home. So a lot of work, in addition to healing, is educating the whole entire family when they're in the health system. Another thing that they learned, and is a little bit unique to the Nemours health system, we developed this about 11 years ago when we opened our hospital down in Orlando, Florida. This is our Tactical Logistics Center. This was built to give a second set of eyes and really focus in on quality and safety within our health system. So this team right here, a group of paramedics, is basically monitoring every single bed in our health system. So the ones in Wilmington, Delaware, the ones in Orlando. And if they have any concerns, we have digital technology within the room. They can remote directly into the room to have conversations, see what's going on. They also have the opportunity to call a rapid response team. So if they see a child deteriorating, they have the opportunity to hop on it, if you will. And so this is great. This is something I think when we think about the quality of care and safety, when patients and families are in our care, this is a critical piece of that continuum. So I talked a lot about education. We have patient instructions, we have videos, we have a lot of content, and a big part of pediatric care is educating. It's educating mom, it's educating dad, it's sometimes educating extended family members who might be a big part of the care at home when some of these kiddos go home. So we try to take our content and really deliver it across multiple platforms that are easily digestible and engaging for parents and families. So that could be TVs in hospital rooms. We've created the Nemours app, which pulls together all of our legacy systems. So parents have this just-in-time information at their fingertips, and even leveraging it within the automated chat box that I was talking about earlier. So when Steph and Jim go home, thank goodness that they have this Nemours app. It's the one place they can go to do everything Nemours. They can message their caregivers, they can communicate back and forth, they can set up appointments, which I'll talk a little bit about in a minute. The cardiac team also, before they go home, with this specific child and this specific condition, prepare them and educate them on how they're going to communicate about their child's health. So we've developed a remote patient monitoring tracker for the parents. It's quite low tech, right? Parents are going to be entering the information themselves, and they're very compliant, I can tell you. So they have the opportunity to report on daily oxygen saturation, heart rate, weight gain, and other important vitals that the care team wants to keep up with on a daily basis. They also ask the parents to take a video every day so they can watch the breathing and watch the incision and how it's healing, so they can be more proactive in the care should they see anything before the next in-person visit. In addition, they have the ability to have regular telehealth check-ins. So all this information is automatically streamed to the clinician dashboard. They're monitoring it on a daily basis, keeping up with it, and they even have alerts. So for example, if their heart rate is out of the range that's been projected by that clinician, they get an automatic Volt alert to their phone and automatically reach out to the parent and family. So again, this is really leveraging technology to take an extremely proactive approach in care delivery. We don't want to wait for you to find something wrong. We want to find it out sooner. Talked a little about scheduling visits. So with Steph and Jim, obviously are going to have a lot of appointments back and forth with a clinician. Our parents have the ability to go into the Nemours app and schedule all their appointments. In addition, we have built and released the ability for Steph and Jim to now basically do all their registration virtually, check in, and even arrive themselves, all digitally. So when they get to the health system, they don't have to worry about going to a desk, paying a co-payment, filling out various forms. They basically have the opportunity to walk in and be called back and see what they're there for, right? The physician and care team. And then we're trying to make payments easy at Nemours. And so again, through the Nemours app, we know that most families are focused in on the care and their health and the well-being of their child. Billing, the dollars, the finances can be very frustrating, very confusing for families. And we have developed the capabilities so they can come in and see our financial advisors. We provide them the opportunity to have a phone conversation, a telehealth conversation. They have the ability to pay for co-payments before their visits in the app. In addition, they can even set up payment plans. So if they have an outstanding balance and they can't pay it all at once, they have the ability to automatically set that up within the Nemours app. Again, we're trying to make this super convenient and super easy for families, but then I have the outs, right, with our financial advisors to be able to have those tough conversations and really understand what they're paying for. So one other aspect of Steph and Jim's journey, and we actually just came up with this and released it. We've been working with our research team, and when you find out that your baby has a congenital heart defect, it is stressful. It's going to change your whole dynamic and life outlook. You're really not sure what you're in for. And so our researchers decided to develop an application that is really built for when mom is pregnant, all the way through having a baby, with resources, additional education, outlets with other parents who are going through the same conditions to really bring in that sense of community and support network. So we just deployed, it's called Heart Prep. In 2023, Dr. Erica Sood here, which is mentioned, it's just one little screenshot. We've also done this with 2 other research projects. These are all NIH funded grants. One called MECO that is focused in around obesity, and then a third one called R2D2, which is focused in diabetes. What's so exciting for us in this space is that in the past, research has gone off, done their research, hired other technology companies, and then when the funding runs out and they have what they hypothesized work and we try to bring it to the bedside, we have to build it all over again to integrate with our current system. So it's wasteful, it takes a long time, and when something works, you want to just deploy it quickly. So now we're integrating with this team and actually developing these applications to be a plug and play. So if these work as hypothesized, we flip a switch and then we're ready to go, really saving a lot of time, money, and reducing waste. So I introduced you earlier to a family from Nemours, little Kai here, who's just a few months old. And we've been working really, really hard at Nemours to integrate these care journeys, really starting with the journeys and understanding where we can implement the technology in between to really bring true benefit, better patient experience, better outcomes, more engaging care and delivery. And I want to end today with a short little video that really describes the parents. And this is why I get out of bed every single day and do what I do. And I know a lot of people across Nemours feel the exact same way. And I know many of you are working on similar goals and implementing technology. And I think this is probably the mission and the reason why that we all do what we do. So now we'll play this short little clip.
Well, I found out pretty late in my pregnancy that we were going to have a child with CHD, congenital heart defect. It was a little devastating for a first-time mom. I didn't know what this journey was going to entail. I was 28 weeks, and I had him at 34. So I didn't have a lot of time to actually process what was going on. I prayed for my son to be healthy, and to hear that he was not was very devastating to me.
Kai was born with a complex form of congenital heart disease, which is called double outlet right ventricle, which is basically 2 arteries coming out of one pumping chamber, the right-sided one. That's why it's called right ventricle. This condition certainly is something that would not allow you to live if it's unrepaired. Most patients would not survive to a year of age.
As a father, the main thing you want to do is protect your child. So when you hear that there's nothing you can do, kind of, hurts a little bit.
I don't think I was prepared for what we're about to go into with this journey until I met the people here at Nemours Children's Hospital. And being here has changed my life, has changed our life, and I'm a better person because of it. Crazy to say, but this journey has taught me more than I would have ever imagined.
Our team has developed a program called Heart Prep. The goals of Heart Prep are to help families feel less distressed, less alone, more prepared, and more hopeful after finding out during pregnancy that their baby will be born with a heart condition. And what we found is that 90% of expectant mothers who are offered participation in Heart Prep choose to enroll in this study. And that's remarkable. 90% of families find that this is something that they feel that they need.
It meant a lot that my wife had access to Heart Prep and the psychology team here at Nemours. As a husband, you try your best to have your wife lean on you, and sometimes, she doesn't want to express everything that she feels. So it was really great that she had somebody to talk to.
I don't think I would have been able to get through this difficult time if it wasn't for Heart Prep.
We're doing good. Having Kai home, having my oldest son, finally having his little brother home. Everybody's doing great.
Oh, I love to brag on him because he's doing awesome right now, considering he has had now 3 open heart surgeries, 1 cath procedure. He has crazy. He has, he has suffered from cardiac arrest before. His aorta ruptured, and to see him now where he is today, it is truly a miracle. It is remarkable. I am grateful to be his mother.
So this is why we do what we do. So thank you so much. If anybody has any questions, I'm happy to answer what I can with a couple minutes I have left.
That was amazing. Thank you so much. Just a question about the future of the health records that you collect. Have you thought about how you carry that forward so that the patient might consider that at future states in their life, future health states, so 10 years from now, 20 years from now, and really provide that extra longitudinal data?
Yeah. I mean, the data is always there, but how we begin to make it interoperable and really build that long-term record in history, I think, is a phenomenal challenge. We're starting at the very beginning. So I think it's going to take partnerships. I think we're challenged in healthcare right now. There's a lot of competition, right? And it's hard to play in the same sandbox. And to be able to do these kinds of things, we're going to have to play together better and figure out, because this is humanity. This is what we're all in the mission of healthcare for. I mean, technology's cool. I love it. Don't get me wrong. But at the end of the day, we want people to live healthy, happy lives to their best of their ability. Thanks. Good question. Yes, sir.
How does the work that you're doing at the Nemours level integrate with primary care providers to make care seamless for the people that you're serving?
It's a great question. So we do have primary care, and we also work with a lot of primary care organizations. So up in the Delaware Valley, we have built a clinically integrated network. And I say we, but I truly mean we, with the primary care providers, are all coming together to be able to take care of populations of children. And our goal is to really build communities of the healthiest children, right? Think about sending that and what that could do to the cost curve long term to be able to really impact their lives. So it's a community effort. Thank you for the question. It's something we're pretty passionate about as well. I think I'm getting the no. Let's talk afterwards. Or
yeah.
Yes, no? Yeah, okay, we'll talk afterwards.
Yeah.
Okay.
It's okay.
Sorry about that, everybody. Thank you so much for the time today. I really
Digitized world and a healthcare sector combating global challenges, the timing couldn't be more perfect to delve into digital health adoption. Our panel will dissect into these barriers, seeking solutions to ensure that no one is left behind in this digital health revolution. So please join me in welcoming our moderator, Mark Scrimshire, Chief Interoperability Officer at Onyx Technology LLC, and panelists, D. Katz Shakar, CEO and founder of Bodyholic, Andre Nemours, VP of Corporate Strategy at Intelligent Medical Objects, Igor Zijan, founder and CEO of System of All LLC, and Carlin Fitzpatrick, co-founder and Business Development Director at OnCode Health. Panelists, The stage is all yours. Thank you.
Thanks for that. So since we've done basically brief introductions, one of the things that I think we need to look at here is, I think as we just heard in the previous session, you will all be or have been a patient at some time. And so the question I think that comes out of this when we're talking about breaking down the barriers of digital health adoption is how do we actually engineer this system so that we can be equal partners, or our caregivers can be equal partners in dealing with our health and wellness. And so first I want to ask just a couple of questions. Who in the audience, raise your hand if you've got a health or wellness app on your phone or maybe even on your watch. And just see who we've got out here. Yeah, okay, so of those of you, how many of you have actually shared any of that information with your doctor? So a few, so we're getting somewhere, aren't we? So healthcare is a really broad subject. In the US here, it's 17, 18% of the economy. And so it covers a lot of areas. So for each of my colleagues here on the panel, I'd like you to just basically give us the perspective that you are coming from when we talk about digital health adoption. So maybe just take a minute or two just to give your perspective on where you're coming from. So Di, maybe if you want us to start. Let's test. Let's see if we can get the audio.
One.
Oh, there we go.
Maybe that will work, or we'll switch again. Okay, thank you so much. First of all, I want to say just a word about where I actually come from. I flew over here yesterday from Israel, which is a country that is very, very, the healthcare is very much based on digital healthcare, and it's a very strong HMO system. And from my perspective, and I'm very aware of what's happening in Europe in different spaces and also in the States, and it's very different from what I'm used to and what I see on a regular basis. But the thing that I am concerned about most as a public health promoter and professional is the accessibility, not only for the patient, but also the digital orientation and accessibility for the provider, because not all the doctors are actually comfortable yet with the digital healthcare. So I want to keep it short, and we're going to move on.
Test. Yeah, so my experience, Andre Nemours, VP Corporate Strategy with Intelligent Medical Objects. We've been in the industry working on foundational clinical content for the vast majority of healthcare. So as docs are documenting at the point of care, how do you define a patient's diagnoses or a procedure? And then we keep all that content up to date behind the scenes for 98% of the US healthcare market. So we have a unique understanding of how different software applications and digital software tools that clinicians, coders, billers, payers, plans, CROs, life science organizations use to leverage better insights into patient lives. And I think the big challenges that we see are probably twofold, just to keep this short. One is a preponderance and a focus on what is the minimum viable deployment of a solution to meet a technological need. And a lot of times a minimum viable deployment only adheres to maybe 70%, 80% accuracy to meet the governing requirements of what you're trying to accomplish. And as we all know in healthcare, if you're only 80% accurate, you're probably not doing that for the vast majority of your population. And that's a problem. And then secondly, because a lot of these applications are based upon software engineers working in collaboration with clinicians, it was very interesting on the last panel, you might do everything within a a software ecosystem and our software box, and then as soon as you deploy it into finality with the organization, you have a hard time actually going live because data might be different at an organization to organization. So having that not only minimum viable challenge, but also dealing with clinical viability of its deployment methodologies is a challenge in digital adoption that we see industry-wide.
So, Igor, what's your perspective on this?
Well, I believe that everyone is trying to somehow regulate their information in the best possible manner because we are all facing the same difficulties. We have seen as well, let's say, not only in the healthcare industry, we have seen as well the airlines, the social media platforms everywhere. So, but healthcare is really sensitive. Why? Because we have their really sensitive information about us. It means what exactly is happening with our health, with our state, with our plans, record about the plan, about the health, about everything what we are. Now, if we are taking the entire healthcare system into consideration, so what we are doing, let's say that I introduce myself, my name is Igor Zian, I'm founder and I'm actually creator of the company System of All as well, and we are working in probably one of the biggest high-tech revolutions ever. It means bringing the Brainwave technology to the market. Probably you have all already heard about government conspiracy stories or about devices reading brain, etc. So this was like a big polemic, is this possible or not? So what is happening now, let's say in the last few years, we are bringing those devices to the market in the form of the prosthesis, of gaming consoles, and etc. But you have so less information in the market what this actually means. It means we have let's say we have so-called the prosthesis, arm prosthesis, leg prosthesis, which have implemented the brainwave computers in the models. They're taking data out from our brain, bringing as well data back to our brain, which is showing to us that we can actually segregate the algorithm from show its functionality on the computer, and we read actually what is happening with our brain. Now, the biggest problem is how to protect this data, because of course in 80s this was easier. Why? Because who had computers in 80s? Those were governments. We know if there was something wrong, we somehow blame the government, we somehow deal with these problems. Now today this is a little bit more difficult because we have 8 billion people, population grew to 8 billion, we have all smart devices, we have all smartphones. We have all so capable technology at home that almost everyone can access this technology as well to their home basement, even for entrepreneurship development. Now, how to control it? Of course, we all were relying on the government, we were relying on Interpol, we were relying on Europol, we were relying on CIA, NSA. We somehow rely that if anything happens, that this is somehow, okay, it's a government decision, or we trust the government makes the right decision. Well, it's not anymore so easy because government cannot assure that they can control what 8 billion people does. So somehow we need to bring this knowledge further. We need to bring this knowledge to different ministry, not only to the healthcare, as well to education, as well to the science, and then to the other, I would say, organizations as police, local hospitals, small organizations. So. And why is this so important? Because we are getting now those devices into commercial use. You can already order now. You have on internet, you can buy so-called brainwave consoles. Your children can play video games only with a brain, using brains. Companies are developing so-called brainwave applications. It means typing your messages only with your mind, etc. So this is now coming through technology, but people are still not familiar with it. They're facing extremely big problems. If they use them, they come to hospitals, psychiatrists still treat them as the behavior phenomenon, which is described as schizophrenia, paranoia. And now somehow we are flipping the system, we are turning the system, which is on one side causing big frictions. Of course, we understand there is a lot of gain and a lot of disadvantages in this, but we need supportive system. It means from every local community that they are familiar with this, because it's impossible to control, as I already said, what 8 billion people does in their.
So Igor, I think you're coming very much from the policy and regulatory framework, but How about Carlin? You've come over from the UK. What's your perspective on digital health and what it means to you?
Thanks, Mark. Yes, my name's Carl Fitzpatrick. I'm an orthopedic surgeon by background. Thank you. And also co-founder at Encode Health. So I think for me it's twofold really. It from a very clinical perspective and what digital health means for my daily practice. And actually it was great hearing the previous talk. I think that the work they're doing there is fantastic. I think that's the direction of travel we should be going in, because really what that says to me is that the digital innovation that we're all creating and interested in, certainly as entrepreneurs that we're sort of striving towards, should really be underpinned by, one, augmenting the work that clinicians do on the front line on a daily basis and actually making us better and more effective at our jobs. And secondly, producing products, services, and tools that are meaningful and impactful to our patients. And so that's certainly my interest from a clinical perspective, and also my work with Encode Health. And so to go sort of directly to your question, digital health means to me creating a series of tools, technologies, services that we can deploy effectively into the healthcare market. And what that means is having our doctors seamlessly integrate their current workflows and maybe even adapt and evolve their workflows to meet the new capabilities of digital health, but actually fundamentally do their jobs in a more effective and efficacious way. And for patients, it should be something that is allows healthcare to be delivered to them more effectively, and actually, and hopefully we'll come on to this point a bit later on, perhaps take more interest and responsibility for their own health, using some of these tools that we're now producing, which allow a lot more interaction between patients and the healthcare services that serve them. So really for me, that's what digital health means and is hopefully moving towards.
Thanks, Carlin. So from my perspective, digital health, I really come at this from the interoperability and the standards world. So it's really fascinating. In the previous session, they were saying what's the big challenge is, yes, we can have all of these single point solutions, but how do we scale that to be able to take that across the industry? And so that's where I've been working in trying to define the specifications that allow us to be interoperable and be able to move data, and particularly to try and release that data to us as patients so that we can make use of that. And then the big barrier I think we have to really look at is how do patients start to feed that data back? And if we take Igor's sort of your perspective on really what's the policy and the regulatory frameworks that allow that to happen without us being harmed by it. So there's a lot of initiative here in the US about privacy and concerns about the data that we're sharing. And we need to make sure that we're able to share data where we need to, but without it coming back to bite us. So, Colin, since you started with what does digital health mean to you, how about Di, if you want to just explain what you think digital health really means from your perspective, from that wellness perspective?
Just as a response to what you just said, Mark, and what my colleagues here said, one of the things that also concerns me the most is, this is really a response, who owns the data? And I wonder if it is the patient, the health care provider company, or the tech company that's actually creating the interoperable space. And how do we protect the patient? Because after all, that is who the data is coming from. But the question is, who owns the data? And you might actually be able to answer a little bit more, but from what I know, it's actually up in the air. I threw that right back at you.
I know you really did. And I think, Andre, you can probably pick up on that because the work that you're doing in analytics is actually trying to make use of this data. So really, what do you see from around digital health? What's it really mean to you?
Yeah, and I think what all of our panelists are identifying here too is the different user personas are getting access to data in a lot of disparate ways. And as let's say as an example, as a payer or a plan, A lot of times they're only receiving claims information. So the understanding that they have on a patient might only be in a ICD code or a CPT code methodology. But if you're trying to marry that with clinical information to get a much more robust understanding on your patient information, from your payer's perspective, if your user personas that have been managing data on a regular basis, trying to get access to that clinical information, you know, other disorders of the phosphorus, as an example with a rare genetic type of hyperphosphatasia, does not mean hyperphosphatasia. So as you're trying to bridge the gap between data, as you're trying to better understand data assets yourself for any kind of use case you're trying to achieve, being cognizant that the people that are actually massaging data for any given use case out there can be really underprepared for the tsunami of information that's going to be coming to them at any given point. And if your end goal is trying to achieve patient engagement solutions for care coordination out into the field, or if you're trying to say like, hey, you're Cleveland Clinic and you wanted to spin up a new organization within Australia, but you've now set up a brick and mortar building in the UAE and the UK, as well as in Cleveland Clinic itself, home base in the United States, understanding local dialects, understanding local operations, and bringing that into the whole healthcare ecosystem so you can understand your patient population as a whole and take action on that. Again, it's a different user persona type that's trying to govern that information and make access to that information. And that's always going to be a moving target, right? There's a couple folks in the audience here that are dealing with genomics information. You throw genotypic or phenotypic representation on top of that data, and that's a whole new data asset that user personas really don't have access to. So how do you make that digitized into a format that a software engineer fresh out of college, probably 25, going from UCLA, can actually better understand that, especially when you have a geneticist breathing over their shoulders to make sure that the success of that data is achieving a goal that they're trying to accomplish. It's a moving target. So when you really think about digitization, and get back into the challenge that I've seen in the marketplace, a lot of organizations only adhere to the minimum acceptance criteria of success. And that has been problematic for care, especially in rare disorder types, and especially in pediatric use cases too. But it's an industry-wide problem, and something that I think we first need to be cognizant of, and making sure that we trust the access to that information and trust through some sort of governance or operation, the data ecosystem is dirty, and take action to clean it.
So, there's some great points there. So I was actually on a webinar last week, and one of my colleagues said used the term malicious compliance, which is what, when we were talking about patient access to data, there's been a lot of initiatives in the US, there's been regulations by CMS, where they're basically saying you must release data to your members if you're a health plan. And many plans have done this, but they've not promoted it to their patients. They've not recruited apps to come in and be able to get that data that their members can use. And so I think we've really got to move past this. And I think one of the key things, and it was said in one of the panel sessions yesterday, it's really about trust. When I was working at CMS and building the Blue Button 2 API, trust was job one. And it really worked from a number of perspectives. One is we didn't want to have the administrator having to go and sit in front of Congress to explain why something went wrong. But we also wanted the patients, the beneficiaries, to be able to trust that we were doing the right thing in making the data available and trying to encourage the right sort of apps to come forward that they could choose to use. So, Igor, from that sort of policy perspective, what do you see as, really where we're trying to get to with digital health? What's it mean to you?
So the policy perspective is, I would say, is one of the basics. If we don't have policies, we don't have, I would say, any control. So if you imagine how society was built, one of the basics of society is a law, or if we don't have a law, then we have a mess. So what is the best control in any organization? It's a policy which is following the law, and a policy which is following the regulation. Otherwise, I mean, a lot of things are based on trust, but I think trust is between us, or trust is between organizations, trust is between good clients, but we don't see what is happening external from our environments. We have a lot of people that have different interests. So they can violate those policies. We don't know with what kind of proposals. And we do not care with what kind of proposals. It means once when policy is violated, when crime is done, and that's why we are doing exactly what we are doing. It's easy because, let's say, what is traceable, then we can it's actually happening with this. We can prove things, we can prosecute things, we can, I would say, somehow compare what is happening between us and our competitors, what is happening with our clients. Now, problem is if policies do not exist, because it means that no one is tracing actually what is happening, and this is coming to the mistakes as well in organizations. So let's say our work is more based, I mean, we are working on macro and on micro, I would say, strategies. Our micro are more based on our own internal developments, and which are probably one of the most specific models and examples as well for the external forms, let's say how the policy should work and etc. But we are probably one of the first companies, we are actually the first company on the planet that we actually to move this policy. We successfully actually implemented the law in the United States of America, now recognizing technological abuses, so people are not anymore treated with behavior phenomena. We have obviously new technological policies, we have new regulation, and now we are somehow working behind the companies. We are actually pushing governments forward. We are pushing European Parliament, European Commission, so we are actually working on a big mass. It means we come to your government and we look for mistakes and we literally require demand that they follow the policy, and then they start working on the micro elements with ministry, means Ministry of Health, Ministry of Education, Ministry of Development, and so on. So if you have company, I would just, of course, I mean, I would advise everyone the same. Look the regulatory. You all have ISO, FDA regulators. In the United States, you have FDA. Now they are trying to somehow synchronize them somehow together, follow those policies, have strict policies, follow the rules, and if something is outside, I would say, of scope of these policies, then of course, here are we are then actually taking care that with the governments and the organizations, everything follows on the place.
So,
do you mind if I interject?
Certainly.
Thank you. What you're saying, Igor, is really important, I feel, because the big issue here is that I think policy and regulations don't move as fast as technology. So when you come in and you try to make order out of the mess, is that what you said? Yeah. And I really, exactly. It resonated with me. It's very important. I think policy and regulations have to have people backing it up who are as fast as, if not faster, as the tech companies.
We've seen some really interesting things going on here in the US. So if you take the example of the CMS interoperability and patient access rule, so that was passed a couple of years ago. They're now working on this prior authorization rule. And what's been required is that there's industry groups, so HL7 has been developing implementation guides that say this is how you should do this, in this case prior authorization, because to the point from the previous session, unless we all do it the same way, you do not have interoperability and you cannot share data. You just, everything becomes a point solution, it doesn't scale. So the interesting thing there is how industry groups are having to get together to create those specifications so that the regulators can point at something for you to be able to implement as a technologist. And that's been a really interesting dynamic when you're seeing politicians creating the legislation, the departments then creating the regulations to enforce the legislation, and the technologists like ourselves then actually trying to implement this in a way that we can actually share data. So let's move, since we're going in cycle. Carlin, why don't you pick up the next question? I'm going to ask two questions, right, based on really the title of this session. This next one is really, what do you see as the barriers to digital health adoption. And then we can talk about, we'll do a second, second probably final round of what are we each trying to do to really break down those barriers. So Carla, maybe if you want to take it away with really what you see as the barriers that we're really trying to get. And it's interesting, each of us really bring a different perspective. It's a fascinating panel.
Yeah, I mean, I think coming from that different perspective, firstly, I'm from a UK health system which fundamentally works differently to the way it does here. And so we have a very unique set of barriers to digital health. The first being actually just the way we're resourced and actually the incentives for changing and updating clinical practice. And as you know, the NHS is a fantastic organisation, but really does have its limitations in terms of what it can deliver and the scope of services we can deliver as clinicians. And just to give a bit of background to that, even within orthopedics, our list of procedures covered under the NHS has reduced significantly in the last 10 years. And so when you start talking about bringing in digital health solutions and actually something that's going to require resourcing from a particular trust or from a local government level, you really have to justify that clinically and show the impact you're going to have from that digital solution. So that's, I mean, that's without getting into regulations or any of the other interesting things we've spoken about. There's a real justification issue. So from our perspective at Encode Health, what we're doing is something that has been mandated from a regulatory perspective, and we're tracking and tracing medical devices, which both NDR and HIPAA here in the US have mandated as something that should be done digitally and will improve practice. But then coming to actually implement that into a healthcare system such as the NHS is very difficult, because the stock answer is, well, we already have a tracking system. We've got a paper trail of all the devices we use, and it works, and we've been doing it for years. And you're asking us to invest in a piece of digital software or a technology that, yes, will improve that, but is that really urgent given that we've got so many other pressures? So that's definitely the first barrier that I see on a day-to-day basis. The second actually is a very clinical one, in that I will present my digital solution to my colleagues, and the first question I'll get is, well, how long is this going to take me to interact with? I've got 10 minutes to see a patient, diagnose a patient, make a care plan, do my surgical planning, call theatre scheduling to get the theatre booked, get the devices booked. I've got 15 minutes to do all of that, and now you're telling me I need to use an app as well. So I think that's the second barrier, is actually getting my colleagues to really engage and adopt digital health, and in a way that they feel it's going to improve their daily lives. So those are the two big things that I see. And of course, I think some of my other panelists here are more qualified to talk about the regulatory perspectives and sort of those parts. But from a clinical perspective on the ground, those are really quite practical and large barriers that I see.
So, Di, you come at this from a wellness perspective. So, what do you see? Steve, sorry.
No, it's okay. It's okay. So say it. Sorry.
So you come at this from a wellness perspective. So, what do you see as the barriers that really prevent us from adopting what we're calling digital health, or where you're trying to get us to?
My hands-on experience is the education, where in Israel specifically, there is an entire Ethiopian community. There's a Russian community that doesn't speak Hebrew or English and doesn't have any understanding, not everybody, especially not the young generation or the older generation, the digital health system, and like I said, that's the way the HMO works in Israel, is completely foreign to them. And not only that, digital health can be such an empowering thing for a patient, but for these specific people, it's actually intimidating. So I think in that perspective, and this also applies to the States, and it applies to Europe and everywhere, because socioeconomic status is a big issue here, and there are many, many, many people who just will not deal with their health because the digital health space is intimidating to them, and that's where we are right now. That's what is taking over the healthcare system. And I think education has to be absolutely at the top of our priority, because I feel that it's a matter of life and death. It's teaching people how to work with digital healthcare can save their lives. That's one. And then also from the provider's perspective, like I mentioned before, there are healthcare providers, and mostly from the older generation, who are excellent physicians, don't really want to deal with the digital health space. And also there, it's a matter of education, and they absolutely have the capability, and it's also a matter of empowering these people.
So, Andre, what do you see as the barriers that are preventing achieving what you see as, you know, digital health?
Yeah, and highlighted a few of them earlier already, but when you really think about it, I think what the panelists are getting at too. One is a focus on what is right in front of you. If you're dealing with like CMS's interoperability rules, you have to change your whole back-end data ecosystem to adhere to that regulatory compliance. And obviously that's a priority for a lot of organizations. I have to deal with this, else I'm going to get my hand slapped by CMS or Maccabi or NHS Digital or any of these organizations. So if I'm not adhering to that regulatory environment, then that's my focus as an organization. The second piece in digitalization is, how do I deal with the financial benefit to any type of digital operation that I'm trying to bring to market? And I think the point, Dr. D, you're trying to bring up is, if I'm trying to do change management for my clinical organization, I have to take in the total cost of ownership of what that digital product will be to the organization. And it's not just the underlying license. It's the implementation of that solution as well as the change management to bring that to market. And if that completely overshadows what the value is or what the perceived value is, then the digitalization will not occur. It's almost a math game that a lot of organizations take, and you have to prove that time and time again, not only as a software company, but as a change management organization like an SVP or a VP of an organization trying to move the ball forward even within a health system yourself. And those are all challenges that organizations have to take on a regular basis. So to serve a solution to that kind of area, you have to be cognizant of those market forces that are ever-changing, ever-present, and talk to them on a regular basis.
Can I just quickly jump in? I mean, I think that's a great point, Andre, because I mean, one of the things that we're doing is trying to create a layer between the device suppliers and the healthcare institutions that they serve. And so actually we're saying to device suppliers, we can add value to you, but of course, as an innovative product, it's a conceptual value that we know that we can provide, but of course we can't demonstrate that until it's in play. And so there's a real challenge there, and I take the point of being able to demonstrate the value of your digital solution before it's implemented. And so you're in a case that you're modeling, you're actually virtually modeling the outcomes before you've demonstrated them. And that can be a real challenge as well, actually, to bring your innovation to market, even though you can do fantastic things once you're there.
So, Igor, what do you see as the barriers that we've really got to try and address?
So as you mentioned, it's such a nice dynamic, because we have, I would say, we have like organizational point of view, we have as well from our side, we have legislation point of view. So the biggest challenge is the dynamic actually in the field, because there is so many different models which are developing, or so many great ideas and so many good innovations, and then we need regulatory which can follow all those innovations. And somehow we need to get the right ideas, right proposals at the right time on the market, and that we know, okay, are we going to be fast enough that company is still going to be sufficient with their input, with their investment, and still getting a gain for their own profit, because company needs to survive. And now postponing those processes, that someone invests into his patent and the process, $1 billion, and then he's waiting 10 years on legislation, it's really too long. So the big problem is corruption, because let's say I see exactly what is happening as well around the Senate, around the European Parliament, around the European Commission. People just expect that they will get some kind of benefit before it really happens. And this is a really big problem. It means legislation should happen faster. It means there should be proposals, there should be transparency of the happening in some kind of, I would say, visual data, I would say software, where organizations, or let's say the so-called the government organizations, they can see what changes are happening instantly, and then they can, I would say, update the policies at the right time. And this is missing. It means we are going backwards and forwards and backwards and forwards. And a lot of people miss out of the time as well with their, I would say, with their integrations. They follow integrations. They get innovation, but legislation needs to be then, of course, updated. And we are missing this time. And mostly, I mean, governments are doing a great job, but there is still a big part of the corruption involved, as in Europe, as in the United States. I mean, really good advice is if you have a company, work there where policies are stable. A lot of companies, they try to test themselves in the third-class governments, and a lot of times they fail. And it's a really good experience of a lot of entrepreneurs, a lot of experienced companies. Don't go there where the field is too sensitive. It means if you feel that there is something which is unstable, we are saying something stinky, don't go there. Probably you're not going to do anything better as a lot of people before you did. Or so if policies are not on the place, you will need to waste a lot of money with different kind of, I would say, governmental procedures which are delayed, and probably you're going to be turned over the same process many times.
We're hearing is there needs to be sort of lightweight regulation. There needs to be specifications that we can all work with. But there needs to be trust because without trust, we're not going to want to exchange data with anyone. And you know, I go back to times I spent with health plans, and if you translate that into what's on your smartphone, I'd challenge you to go and look at anybody else's phone and see what apps they have on their front page. Every one of us, I bet, is different, and that's, I think, the secret of where we need to head with digital health. Is it's not one 100% solution. But we are going to each individually pick, maybe 20 or 30 different, 3, 4, 5%, 10% solutions that meet our needs. And we need to have the information that supports that. So from my perspective, what am I doing to try and break down these barriers and really drive things forward? So I'm going to ask each of you what you're doing. My work has been to spend time writing specifications so that the regulators can point to those specifications and say, when I move from one health plan to another, I'll be able to tell my new health plan, go get my data from the last health plan. So I've now got my longitudinal record building constantly. And when I'm going to go see a provider, the provider should be able to go knock on the door of the health plan and tell me, what do you know about my patient? And they'll be able to get the data, because certainly in the US, what we see is the health plan, I describe it as they have the connective tissue of your care journey, because they know where you've been because there've been claims, but they may not know a lot about what went on at each place, whereas the provider has maybe a very deep view of what they've been treating you for, but they don't know everything else that's going on in where you're getting treatment. Particular problems with, like, the Veterans Administration, where there's veterans being treated by the VA, but also out in the private sector, and they don't necessarily know what's going on. So I'm working on interoperability, trying to help providers, payers, be able to create these interfaces so they can share data in a consistent manner. So why don't we run down the panel? So Di, what are you doing to really make this happen?
Like I talked about earlier, that education is more my forte, and my goal is to decrease health disparities. So going to different populations, teaching them how to use, specifically in Israel, the apps, how to reach out. And I think in general, and this is not specifically to my area, but I think in general, education for and empowering the younger generation to actually go and teach their elders is one of the strongest ways to make a difference in that. And the other thing is, and this I'm not doing anything about, but the health disparity issue is the one that is closest to my heart. And the financial barrier is a huge barrier in the digital health space because digital health costs a lot of money. And I think there has to be some kind of subsidy. So I'm just putting that out there as someone who doesn't live in the States.
You're speaking my language. I've for a long time, actually, anybody that listens is, you know, we can go to the doctors and get an annual checkup for free in this country on certain plans. Why can't I also charge for a digital subscription? Because one of the challenges I think we've got in the US here is there's no real business model for third-party consumer apps, health apps, unless you are the product, right? And if you were able to dictate where the money is being spent, you become the customer. And I think that's one of the things we've got to solve. So I'll get off my hobby horse. And Andre, so what are you doing?
Yeah, and I'll give you guys a personal experience here, just me personally, what I'm trying to accomplish. So I had a family member, she had stage 1 estrogen receptor positive breast cancer. For those of you that are in the coding world, that's 3 ICD-10 codes and 4 SNOMED codes. So when you think about how that patient's data is sent downstream, if you're only adhering to the minimum acceptance criteria of that transmission, patient only has breast cancer. So to give you guys a real life experience about what happens here, if that patient, let's say seen at Northwestern or a UNLV over here, gets a referral for a dermatologist for cystic acne, the dermatologist probably doesn't know that they have estrogen receptor status. They probably don't know that they had BRCA positivity because these are secondary codes that are attached to the patient record. Now, in my family member's case, that estrogen receptor status did not come along for the ride, and so they prescribed an estrogen positive ointment to the patient. Medication management rules didn't kick off. The plan successfully reimbursed for that, and that's a problem when you really think about that. And we probably all have stories of family members dealing with oncology use cases where your family member didn't get the appropriate care because of some of these rule operations not getting triggered appropriately behind the scenes. What drives me as a person working in this ecosystem is making sure that that does not happen to this generation and to that next generation. And if we can provide trust into that ecosystem and trust back into that operation, and anything that I can do with my company to help enable that trust in that data, I'll do it to the end of the earth. That's what I'm trying to accomplish.
Awesome. So get your questions ready. If you have a question, if you go to the mic, we will be happy to take questions. But Igor, what are you doing? You've done some really interesting stuff with administrations. So what are you doing to break down these barriers?
It's a good point, yes. It's good as well to understand like why we are doing it. So we are definitely not going to go back, or we are somehow developing humanity, or we are not going to leave our technology development and go back to caves. So we somehow need to realize that it's necessary as well what we are doing, all of us. Now what we are doing, of course, are literally, we are those that are, it means we are bothering government organizations. I would say critical points that they are missing, and we are literally working a lot. We are trying to do this like gentle, politic-wise. We are trying to do this like policy-wise. As achieving, I would say, technology violation legislations. It's probably one of the, I would say, most difficult breakthroughs that we actually succeed to do, but we did it. And now we are not sitting on this. It means we are continuing. Now we are literally bothering our European Commission, European Parliament, entire United Kingdom, I can say, Switzerland.
think your mic is... So, Carlin, why don't you wrap up with what you're doing to address...
Thank you. So yeah, I think for me the key word would be advocacy. So Dee touched on it with the education work that she's doing in Israel, which I think is really, really pertinent because ultimately, again, as Igor just said, that we have to keep the aim of what we're doing in mind, which is to serve patients and to improve healthcare. And actually, from my point of view, it's a case of making sure that there's patient advocacy in place, which is education and allowing patients to have a say in the digital technologies that they interact with. So one of the things that we're doing at ENCODE is that we're engaging with patient groups for each of the parts of our platform. And so we're speaking to patient groups prior to producing functionality and saying, well, does this serve you as a patient group? So we're doing a track and trace system at the moment where we're looking at renal stent recipients. And we've gone to their patient group and said, well, we're about to do a study on this. Would it be useful to your patient group if we had a system that tracked these stents that have a limited life cycle within the interact with our product? And I think those are the sorts of conversations we need to be having. And similarly with with our colleagues professionally saying, well, would it be useful if we had these technologies in place?
Yeah. So, do we have any questions? I see somebody there eager to get to the mic.
So you folks just mentioned that for digital health, people are not willing to pay. So when it comes to the people who are going to pay you, the first question they ask is, what is in it for me? So can you explain to me who are the people you're selling to, digital health, and what is in it for them? B2B versus B2C, whatever.
Yeah, and I think that's a really good point. So I'll make a start. So, I mean, one thing we didn't touch on are the various stakeholders for digital health. It's a great question, and it's definitely a barrier. So for us, we work between health institutions and suppliers. So actually, they're both our customers, and so we've got value propositions for suppliers who want to get to patient data. They want to be able to provide direct value-added services to the patients they serve, but can't hold that data, so they need an intermediary. And equally, everything's competitive, so the device space is very competitive. So companies can't give away price anymore, they have to start giving away value. And so if we are a conduit to giving value to patients, we can charge for that service. Similarly, the data that we've all been talking about has a massive value to both healthcare institutions, governments, and suppliers. So there's an intrinsic value to that data we hold. So there are multiple revenue streams without having to charge the patient themselves, which I agree is an expectation. Patients don't want to pay for these services, which I think is fair. Yeah. But there are multiple revenue streams.
I agree. I mean, in the overall, what is there for you, it's a quality of life. Or it means if we improve legislation, we bring the quality to society. This improves yours, not only your organization. This improves your life quality, your family quality, your health. It means there is a lot of improvements in this. And every model described brings, I will say, some innovation as well to the policies. And policies are readable. They bring out new innovation, new, I will say, new challenge. New challenge brings out new idea. New idea brings out new opportunities, how to improve something. But don't forget, where is a new place for improvement is as well a new place for abusement. So you need both sides. You need smart people, but you need as well precise people. You need as well really strict people. It means technology is so great, it's a great fun, but it's as well really big responsibility.
I think one of the things, when you say we're not willing to pay as patients or consumers, I think in the US we're paying through our healthcare, which we're contributing to our employers' plans or whatever. So we are paying somewhere. The question is, where can we extract the value, and how do we avoid being the product so that our data is being sold and used for value, and we don't really extract the value? I think we've got probably 1 minute before we get the hook, so another question.
Okay, I have one question that I've sort of faced in the work that I've done has been how you develop buy-in from the providers, the people actually providing the services. And one thing that I think I've learned is start with what they want, no matter how inane it is. Because starting where they go builds the trust that then they want to develop the things you want. I'd like to hear some of your experiences on. The other one is a question, another one is a question on personal buy-in, because I've been a patient of digital, and I found it very difficult to develop the personal routine to have the time to do the entries. And if I had that trouble, I can imagine others need help for it, and I at least worked my way through it. So those two, and then the third one is how you deal with provider overload of all the different alerts coming from different places.
Anyone want to take that?
Yeah, I can take it. So I'm going to answer your last question first, because I think it's the most important of provider buy-in. If you're creating a change management operation to, do a new decision support workflow for, prior auth, right? You shouldn't be overburdening the clinician in multiple statuses of documentation to achieve a goal. And that is the cornerstone of successful physician, but the same ICD-10 workflow to not overburden them is literally the key cornerstone. Second to that, as long as you're enabling them with what the clinician has been used to in their own care, will also get clinician buy-in. We heard it in the last presentation too about Dragon's ambient experience. The clinician wants to talk with the physician, with the patient, and have all the documentation work behind them. They shouldn't be spending an hour with the patient and 3 hours in documentation to achieve that kind of goal. Addressing physician burden, but doing that in a digital operation that's efficient within the workflow always aligns to physician adoption. And then third point is obviously if it means more money to the organization or more money into the doc's pocket, then that's wholeheartedly an accelerator for physician adoption, because obviously for every dollar that they put into workforce or FTE operations, they should be getting 3 to 10 back in actual quantifiable ROI. And we as an organization dealing with software applications should be able to position that appropriately.
So with that, thank you very much. Thanks to my fellow panelists. Hope you enjoyed this session. We are getting the hook, so thank you. You can always catch us over lunch or through the rest of the conference. Thank you very much.
Thank you. Thank you to our speakers for joining us for that panel. We're going to take 1 minute to get reset, and then we're going to start. In the meantime, I'm going to read appropriate doctor jokes while we prepare for the next session. Knock, knock. Who's there? Colin. Colin the doctor. He kept seeing spots. Thank you for stealing my punchline. No, I'm just kidding. I'm just messing with you. Okay, our next session is ready. I'm going to introduce everyone now. Extremely important. The extraordinary capabilities of AI in augmenting patient care, diagnostics, and treatment plans raise a pressing concern. How can we save AI in healthcare brings need for heightened data security standards? We'll delve into this pressing issue to provide answers. So without wasting, Kostas Fantis, CEO of Encode Health, Chris Narayan, Chairman and CEO of Medikarma Inc., Dr. Nathan Price, Chief Scientific Officer at Thorne Health Tech, Joe Otto, CIO, Board Member and Advisor of Red Eye Network Solutions, and Sujan Sanku, Chief Operating Officer of 99 Infosystems Inc. Please come to the stage.
Important for AI. When this panel of experts active presentation, I want to introduce himself and talk briefly about his current forays into artificial intelligence.
Can everybody hear me okay? Excellent. So the esteemed panelists here are going to talk about process, procedures, protections. What I'm going to focus is how do you and I see a product? When you use an iPhone, you don't see what's inside. You just see how it looks, how you use it. So to a patient, to a provider, or a payer, among others. There are pharmaceuticals and pharmacy chains, whatnot. But I'm going to talk about what the last panel touched. What is in it for me? Why should I pay you? How do I benefit? So with that, I'm going to start this with a demo. Some of you may have seen it. So I'm going to show you a product which I hope, as it's getting now deployed by some of the major payers and providers, that you're going to see more and more in 2023 and 2024. It is AI, but it's not like any other that you see, ChatGPT. This is an AI that talks to you, that has a conversation with you back and forth. It does things for you, scheduling your appointments and refill your prescription. And further, you can go back and look at exactly where you are in your life, what are your comorbidities. That's the most important thing. The key thing you ask a doctor when you get in trouble. Hey doc, what do I do next? So let me show you the product. Hey Jill, how am I doing today?
Hi Joe, how can I help you?
Elon Musk and Cybertruck demo. Hey Jill, how am I doing today?
Hi, welcome back. It looks like you're making great progress toward your health and wellness goals. Your health score went up by plus 25 points over the last week. Keep up the good work. Do you want to learn more?
Yes.
Your improvement in score is mainly driven by blood pressure reading, which decreased to 130/80ths of a millimeter of mercury. Your goal is to get to 120/80ths. Secondly, increased GFR score from 60 to 75. I got this information from your recent lab results. Your goal is to get to over 90. You are moving in the right direction. Keep up the good work.
What is GFR?
Sure, the glomerular filtration rate GFR is the rate at which blood is filtered by the kidneys. It is a measure of how well the kidneys are functioning and is used to diagnose and monitor kidney disease.
So, what do I do next?
Here are your recommendations.
So, what do I do next? So, what do I do next?
Your latest recommendation is as follows. Your blood pressure value has recently increased. You have hypertension. It's imperative to implement lifestyle changes to lower your risk of hypertension. Please discuss with your medical provider to help you ensure optimal control of your blood pressure, including lifestyle management, such as the dietary approaches to stop hypertension.
So, just one more thing to tell me what to do with my life, right? But there is an interference between the mic and the microphone of the phone. So, you're hearing some of this reflections. But the point is, we foresee a future where each one of us has a health assistant, a virtual health assistant that knows who you are, HIPAA compliant, knows your diseases, talks to you about how you're doing for the last week or yesterday, and from there, it goes on to converge and tell you what to do next. If we can have the next slide, please. So when you look at Medikarma, this is what you're going to see on the screen. The way this works. As you and I are talking, I create an avatar of you. With your consent or your doctor's consent, I go get your electronic medical records in 35 seconds or so. And I put around your body or your digital twin your health conditions in green, red, and orange, just like traffic lights, check engine light. It's going to give you some information like, what are the chances of you having a heart attack in the next 7.5 years? What are the chances of you getting a stroke in the next 5 years? The intent here is to tell you where you are in your health, show you the weakest link in your chain, and wake you up so that you can start thinking, what is in it for me? What is in it for you when you're 50 and above with a chronic condition? To avoid incarceration inside something called your body, disability, worsening. I'm going to go into what's in it for other segments in a minute. But as we show you your avatar and your conditions, we also take what you're doing today from your smart devices, how you're working out, how well you're eating, what is your stress, how is your mood. We get this information from smart devices, RPM devices, and Jill will be talking to you in the morning saying, I see you didn't sleep well. What's in your mind? What's going on with you? These subjective answers are all computed into a FICO-like score that you see on the left side of the screen. The score will go up or the score will go down. If you had 3 glasses of wine last night, score is going to go down. If you work out for an hour, score is going to go up. So we show you the score drivers, and when you click on any of the score drivers, Jill pops back and tells you what to do to fix it. So this is the implementation of the product. To quickly converge the what is in it for me, we started getting some of the major payers in this field coming to us. They asked us, can you prove your health score can correlate to claims data? And we very quickly converged in about 6 to 8 weeks. We proved Medikarma health score, over 65 million de-identified users, was able to correlate to the claims data by 90.6%. The moment we did this, we started seeing interest from insurance companies. So the proposition we give insurance company is, if your members use Medikarma, your cost of care is going down. The proposition we give the provider networks, if your patients use Medikarma, their behavior will change the more they talk to Jill. The behavior changes will drive the score up. As the score goes up, your cost of care, number of emergency visits, will go down. So each one, what is in it for me? That's how we put the company together, and we are now deploying the product.
Great. Thank you, Chris. Nathan, tell us your current position in the company you're with.
Yeah, so I just give a little bit about my background. So Nathan Price, I'm the Chief Science Officer for Thorne Health Tech, which is a public company that serves about 46,000 healthcare providers and about 5 million consumers. And in terms of my background on AI, so I'm trained as a computational biologist. So I was in academia for about 15 years as a professor. And in that time, I did a lot of work on multi-omic analysis of genomes and proteomes and metabolomes and microbiomes in clinical labs and wearable devices. And we took several thousand people through health programs using this kind of information and amassed one of the largest multi-omic data sets around health. This was done in collaboration with my partner, Lee Hood. We jointly ran something we called the Hood Price Integrated Lab for Systems Biomedicine. Lee, for those who don't know, is famous for inventing automated DNA sequencing and won the National Medal of Science for some of his earlier work. In terms of some of the things that we're doing in AI at Thorne, very interested, and I'll talk more about this later, in a concept called digital twins. I think I'll save that for a little bit later when we get into that topic in a little more detail. But that's an incredibly powerful way to monitor your health and look for improvements. We've done a lot on the analysis of from genomics and being able to show how it predicts the kind of things that you can change about your health and the kind of things that you'll struggle to change, such that you can provide personalized health plans for people. That's a big area of interest. And then the other thing that I'll say about that is we do provide testing coupled with AI to give people personalized recommendations derived from a lot of background health and molecular information. And then on another policy side, I just finished co-chairing a series of workshops for the National Academies of Sciences, Engineering, and Medicine. That was a joint between the State Department and several countries in Southeast Asia, looking at threats of AI and biodata. And that report, if anyone's interested in that, was released last week. And I'll turn the time over to you.
Joe, please.
Can you hear me?
Yep.
Yeah, okay. So Joe Odo, Chief Information Officer for the past 3 years in a healthcare company. I also, I'm on a few different advisory boards. Probably the relevant ones are cybersecurity, network cybersecurity advisory board, another company that does medical management with a lot of healthcare providers. And also then an AI analytics company that specializes in AI analytics as well as our.
Hand
And,
me the mic if you would.
thanks. And then the other side of it is I've been recognized for a few awards this year in particular. One was top 10 CIOs in healthcare. The other is on the technology side, top 50 in the US for technology professionals. As far as AI goes, currently what I'm seeing is a lot of regeneration, next gen of a lot of the chatbots that a lot of the healthcare companies have. So you can answer questions, healthcare questions, or you can answer where's your claims, those type of questions. So you're seeing that go to the AI side. I'd say over the next 2 to 3 years, what I'm seeing and working with different companies, one is access, so AI access. So I'm seeing a lot of passwordless credentialing. A lot of it is blockchain related, peer-to-peer, so you can really save what you have even to your Apple Wallet. And I'm working with a company that does it for credentialing for a university, large university in Arizona, that you can save your credentials, your degrees, that type of thing, and share it with who you want. And then also I see that in the healthcare side, they're trying to get in applications and will over the next couple of years with the individual sharing medical records as little or as much as you want with your healthcare providers. So that's kind of the direction access-wise. The second item would be safety. So it's a lot of wild, wild west right now in AI. And we're seeing a lot of safety come in, which is a great concern from a CIO perspective and a company perspective. They don't want to give up their IP. So you're seeing a lot of AI safety companies coming into the marketplace. One I'll mention we talked about was Anthropic, which is working with Google DeepMind, and heavy investment from Google, about $400 million in that company to develop kind of a steerable and reliable safety solution. It's a lot of the former founders of OpenAI and ChatGPT that are working on it, kind of broke off in a company. So we're seeing that on the safety side. And the last area I would say, and similar to what Chris had, was interactive AI solutions. So providing data from the outside. I see so your blood pressure, your genetics, different information about you, you provide to an application, maybe via your Apple phone or Google phone, and it will come back with recommendations on specific care provided. So those are some of the things I see going forward.
I'm going to keep my personal introduction brief. You could probably just find me on LinkedIn. Our medical solution, what we are working on, is quite different from what's out there in the market or what people are working on. Ours is more for first responders. So basically, I think the biggest issue we face in the medical industry right now is when you make a call, there's a delay between the ambulance arriving and the EMT or whoever is on it to perform any medical procedures. And then from there to get back to the hospital, most of the countries, the EMT can't actually do much. Maybe they can resuscitate you, do the CPR, maybe give blood, depending on the country, maybe adrenaline, also depending on the country. So our solution is basically like a virtual EMT. So whoever the first responder, whether it's like a bystander, like you or me, or whether it's a professional, it'll give you the advice you need to keep the person alive. Whether it's alcohol poisoning, whether it's giving stream, and it'll analyze what's happening, and it'll give you, hopefully, we're still working on it, adequate advice on what to do. So how many of you have actually had emergency training, like CPR or, obviously, right, health panel. So how many of you have actually performed in the public CPR or anything? Okay, so I actually had the sad opportunity to do this in Tokyo in February. There was a person who, I don't know what the case was. I think they just had too much alcohol. They're completely passed out. And there were no police around. It was like 2 a.m. I was also drinking, by the way, very, very honest. So there was no one else to obviously help this person. So I had to call the ambulance, get people involved, do the CPR. It was very high stress. And honestly, you can't do CPR for too long. Like the whole chest compressions is really hard. So I would have preferred if there were more people to help me and some guidelines. Obviously, I've done the training, but in practice, it's very different. I'm scared. Am I going to kill the person? Is he going to die? Though I tried to help, it's a very stressful situation. So our solution, hopefully, will guide you through, keep you calm, and pass the baton to whoever is more professional when they arrive. And in terms of AI, we'll come back to that later.
Thank you. Hello, Las Vegas.
All right, you're not from the States, are you?
No. Hi, my name's Dr. Kostas Pantis. I've studied medicine. I have a specialist interest in neurosurgery. I'm currently doing research with the University of Buckingham with a focus on the applications of artificial intelligence in neurosurgery. We're looking at how artificial intelligence is being applied to the use of biomarkers in primary neurosurgical tumors. And I'm the CEO of ENCODE Health. You would have heard from Dr. Carlon Fitzpatrick, my business associate, talk about ENCODE Health. I am the CEO of ENCODE Health, and we apply artificial intelligence to optimize medical inventory in hospitals, and we also provide different types of functionalities to ensure post-market surveillance once a product is inserted into a patient to ensure that that product is actually working the way it does. Happy to answer any further questions about what we do, but in summary, that is what we do.
So thank you very much. The one thing I will point out to the audience in hopes that will encourage you to ask questions is you have some of the most diverse voices of AI in healthcare that are out there. And so I would encourage you to ask those questions. Please, I don't think you're from the United States either.
How did you know? Yeah, we've got a reputation here, haven't we? But my question really, sorry for the chap sitting next to Cole, sorry, your name again?
Sujan.
Sujan. Your innovation sounds fantastic, and I mean, I've been a first responder in hospital, and you know, even with the appropriate training and been ATLS trained and trauma trained, it's quite intimidating. My question is an ethical one, really. So, where does the responsibility lie in the event that there's an adverse incident or a poor clinical outcome? So, from your point of view and your team, where's the responsibility?
At least in the United States, in most states, it's mostly state government, there are things called bystander laws, and as long as you're trying to help someone, usually you're in the green. I say usually. So you can still get sued. It's a very litigious country. So that's a totally different topic. I think that's beyond the scope of like a legal disclaimer on the app. What we want to do is reduce wait times and save the patient. So as we have an ethical responsibility to save someone. That's the health approach. And the legality of what happens after that, I know it's a huge issue, but I don't think we can stop it in a country like US. In other countries, besides the US, it's common law. If you're trying to save someone and you accidentally break their arm off or break their rib cage or whatever, you're completely in the good. Like I said, US is a bit tricky, but we are trying to lobby so that we can get more support from the general public. It is a system that kind of jumps on the 119 call, or in this country it would be 911.
911.
Yeah, Sorry, that's the Japanese emergency number, or 112, some countries in Europe and India included. So we do have the government services that are involved in the loop. So somebody in that loop would be taking responsibility. Hopefully not the developers, not the, the software developers, but that is something that I honestly don't know the answer to, and I think it's a very risky thing. But at the end of the day, all you want to do is save the person. So if you get sued saving someone, that's sad, but that does happen to even doctors performing at hospitals. I think, again, more so in the States, especially with malpractice and other things. I've never heard of this happening in Japan where I live. You do not sue the doctor, he's like God, because he, connects life. He gives you life in that way. So I think that's more of a cultural thing than a legal thing in my mind. Does anyone have like a different opinion?
Yeah. So I think in most states in the United States, those laws, while they may be referred to as bystander laws, are also called Good Samaritan laws. And so if you're acting in good faith, in the best interest of the patient, in an attempt to save their life, then legal protections do exist for you. Like he said, doesn't prevent you from being sued, but it does offer you protection from that as well. And I don't know if anybody else has experience with that at all, but I have had several colleagues that are, have been subject to lawsuits after trying to provide aid to patients who have been found not guilty, and the suits have been dismissed. So,
and would that extend to healthcare professionals as well?
Yeah.
Would that extend to healthcare professionals? I mean, there's a difference
Yes.
between
Yes.
a layman providing care and a healthcare professional
Correct. It
providing
does.
care based on an AI algorithm
Right.
in a hospital setting. Because the argument would be from my regulatory body, well, you have clinical judgment, you have training, and so it's difficult to hide behind the technology that you're using
Right.
to make that particular decision.
I think probably the more important question is at what level is the instruction being provided by the AI similar to what someone who is trained as a medical professional might provide in that circumstance. And I don't know what kind of data set you're using to try and create or recreate that environment.
This does take into account quite a few scenarios, at least that we could come up with. For example, you could have burns if you have jewelry, pretty common, I think, especially with AEDs. The other scenario is sexual harassment, especially if you need to maybe take off a lady's bra or open up the buttons, and there are other people who are just filming, who are basically not helping, but they're just there. So we have thought of all these scenarios, potential scenarios, in the public and in the professional, so like in a hospital. But usually if you're working in a professional capacity, so if you're doing it in a hospital, the hospital is a buffer for you. Unless you're completely doing it as like a non-duty doctor, which is, again, that means you're probably in public. So then the standard rules apply whether you're a doctor or not. So unless you've made like a grave mistake in the hospital setting, you should be protected by general law, as far as what we research. Like I said again, US is a bit more on the tricky side.
It is very tricky. Yeah. Does that answer your question, sir?
Yeah, to a certain extent, thank you. Yes.
Okay, sure, no problem. Any other questions? Please step to the mic if you have a question. Encourage you to do so.
Good morning, guys. My name is Kira Howard. I'm a patient experience consultant. So when I'm listening to all of this, I'm always thinking about the end user. I'm thinking about the faculty, the staff that actually have to use the technology that you guys are supplying. So from the top down, everybody's very excited. We have access to all this data. We can do this and this and that. But how do you guys get the buy-in, or how do you think you get the buy-in from the staff to actually learn how to use the application, be able to educate it, like the previous person that was up here was talking about educating the actual patient on how it's going to be used, how it can help, reduce turnaround times for you waiting for the nurse practitioner to call you back, or for the nurse to call you back. So what is the engagement factor for not only the patient, but the person that's in the office that would be essentially selling the product to the patient to get them to buy in to use it.
So that might be a good question for Chris, since he demonstrated an app that, you know, patients could potentially use. But you're right, there are challenges in teaching anyone how to use that kind of app appropriately.
So can you hear me okay?
I can, yes.
Very good. So when it comes to technology, we have many things we use in consumer electronics. Keep it simple, right? There's a word, he's saying it, not me. But I'll say the other word, something called idiot proofing. So when I invented smart TV, I told my team, don't look at 21-button remote. This is Joe's six-pack with a beer in his hand. Brain is not working, more than 5% capacity. Click, simple click. Put 4 things there that show streaming. Click one of them. Make it so simple. People are going to get, for lack of a better word, addicted to using it. Fall in love. So Steve Jobs says a couple of things. Insanely great product and making it with the end in mind, the user in mind. Going back to what Medikarma does, we have 4 stages of engagement with the patient. Somebody gives us a lot of patients, payer, provider, whatever it is. First step, get them to motivate, to enroll. So we put something called, what is in it for me? What are you going to gain? Second, once you enroll, onboarding them. You basically have 1 to 2 weeks to make them fall in love with the product. Once you onboard them, now come the next step 3 and 4. How do they use it? How do I nudge you? You step on a scale, I'm sending you a message. Congratulations, you lost half a pound. There is fire outside, I'm sending you a message. There's a smoke out there, be careful. It's called Jill touch points. So we give you many touch points to reach out and touch you. So you're continuously engaging. And the more you're going to engage with Jill, the more your behavior is likely going to change. And the more your behavior changes, 3 different segments get 3 different things. Patients feel healthier, payers get cost of care reduction, providers get their value-based care bonuses. So that's what we do. So we actually train not just the patients like this, we also train the caregivers on how to use this, how to talk to them.
I can see an insurance company really buying into that and saying, as one of our insureds, if you use this app and share your data with us, then we'll reduce your premium by X number of dollars in the next year.
Great point.
Definitely.
But there's a tricky answer there. Insurance companies are seen as people who want to take your money, and you can't be too careful in sharing your data, right? So with insurance companies, we do 2 things. 1, you give us the data of your members that you want us to work with. 2, we're not going to do any giving you data back. We're giving you what's called predictive analytics. How many of your patients are consuming the most amount of money on what diseases? We'll tell you what you should be doing to reduce your cost. Who should you be sending messages to better take care of themselves? So we have convinced the insurance company that they should pay the money for Medikarma subscription so all the members get free. So they pay a licensing fee, they pay a per patient per month, and if we do reduce the cost, we get 1 PM for every 1% cost reduction. Right? What is in it for them? Cost reduction. What do they pay us? Our recurring revenues.
And do you think in underserved communities, this would be something that could be pushed?
You're putting a series of great questions. So, yesterday there was a panel called Health Equity. You want to talk to people you're comfortable with. We provide you Jill in multiple ethnicities, multiple languages, and multiple conditions. There is a diabetic Jill, there is an obese Jill, there is a wellness Jill. So Jill finds out who you are. Then she transforms herself to be talking to you. That's how we are making people feel comfortable.
That sounds great. And just to, before we,
Yeah.
Does Jill talk in layman's terms, or does she talk like a doctor?
Jill has to be, keep it simple.
Okay.
Jill has to be conversational.
Okay.
We spend a lot of time training Jill, but it's Jill. You bring in a healthcare expert, wellness expert, he trains and he creates Jill to be like him.
But she doesn't use medical jargon. She does speak like how you and I would speak.
That's right.
Okay, that's awesome.
Costas, you had a comment?
Yeah, with reference to how we're using artificial intelligence and engaging some of the users, there's three things that I would like to say. One is making sure that the user interface and the user experience is of a very high standard. A lot of people don't really accept Tim Pot kind of products nowadays. It has to be of a standard that's something similar to Facebook interface, for example. So at Encode Health, we've brought in specific designers in healthcare to make sure that it is of a very high quality level. So that's one thing, to make sure that the design, the user experience is exactly what they would expect of a modern day app. The other thing that I would have to say is to do with trust, making sure that if somebody is going to engage with an application that is using artificial intelligence, there needs to be some kind of trust accountability. And we've looked at the European AI Act and looked at what transparency is required to make sure that what the output is trustworthy. So we've produced two types of links. We've created a link that is associated with the version of the algorithm itself. And we've also created a link associated with the data set that has been used to generate the output as well. And also with the regulations that that particular algorithm is compliant with. So user interface, trust, and also making sure that the product actually does what it's supposed to do. So for example, we use optical character recognition. It's a type of artificial intelligence that when you take a photograph, it recognizes the characters, the letters, the numbers that are in there. So when we're onboarding new products, or when one of our clinicians is onboarding a new product, they take a photo and it gets that information and puts it into our database in a very slick manner. So there's a kind of usability trust there as well. It does it when it says it's supposed to do it. So those are the three things that I would like to offer as how do we engage with our stakeholders. Making sure the interface is of a high standard, making sure the transparency and the trust is there, and then making sure generally that it does what it's supposed to do.
Does that answer your question?
It did. I just wanted.
Terrific.
One other thing. I'm pretty sure that you guys have probably come up against, just some negative feedback in terms of taking the human aspect out of it. And I just wanted to know, from all of you, what is your go-to to overcome selling AI versus the human interaction?
So I think the question is obviously people prefer talking to other people instead of apps. And for some people that creates a difficulty. And so the question becomes, how do you overcome the fact that you're telling your patients now you want them to talk to an app instead of a real person? Joe?
Yeah, so, part of the answer is humanizing it, so even, the Jills or the chatbot, but also you provide an out, because sometimes things get complex and they need more detail. So you have to be able to, hit O for operator and get to a person to maybe delve into it a little more fully. But I would say for cursory AI type information, like what's my claim, have they paid my claim, basic healthcare information, AI is consistent. That's one thing, and it gives the same policy to everybody. and can answer most of the questions. So that frees up a lot of the doctors, nurses, clinicians for other more detailed work.
Yeah, yep. Let's let Nathan comment, and then we'll let Chris comment.
Yeah, and so the one thing I'd add to that is just that AI can also make our interactions like human to human much better, right? Because if you think about the interaction that you have with your doctor now, it's very likely that he or she is looking at a screen, right, rather than at you, for example. And there's also a huge amount of time that doctors absolutely hate in terms of like transcribing all these notes at the end of the day. Most doctors, if they say, you know, it's the bane of their existence, right? They hate this more than pretty much anything. And when you put AI in there, all that transcription can now be done in an automated fashion. You can have an interface back and forth. And I agree also with the previous point that there's, you know, that sometimes you want to talk to a person, but you can spend hours with the AI getting detailed information and then only have to go back to the provider when there's, you know, a real issue. And the ability for us to also offer medical information at way less expensive, more available 24/7 all the time through AIs is massively better than without. So I think it's going to actually bring a lot of the humanity back into medicine.
Chris?
So we may be looking at the wrong problem here. We have a problem with health equity. You have a shortage of providers. You have burnt out providers. You have a system that's squeezing dollars out of everything they can for profitability. And then you have an increasing demand for services because people are getting more and more sick. So how do you chop off the demand and increase the supply? That's a question to ask first. And then you can say, when you do that, how do you make it as easy, as pleasant, as human as you can do? So let me answer both the questions. AI as conversation AI, as an actionable AI, is not going to replace doctors and clinical nurses. It's going to complement. It's going to provide additional ways of interacting and asking you questions that you don't need to go to your doctor to ask. That's what we're doing, right? But having said that, coming from the consumer technology, I totally agree. You need to make it as pleasant, as easy, as idiot-proof as it can be to communicate and converse with whatever form you're interacting.
3 seconds. Go ahead.
I was thinking more like 30 seconds. So there is something called sentiment analysis. Cisco is the leader. So it basically engages your facial expressions, your voice tones, and it will subjectively answer kindly, like a doctor in a good mood. On the other hand, sometimes a doctor, a human, can be having a bad day. So they might not be so interested in engaging. We are human, we are fallible. But the AI can be trained to be always a kind doctor. So I just wanted to leave you there. I know it's a complicated topic, but
Yeah, no, very. Next question, please.
Thank you. Just a thought. Well, I'll preface my question with a question.
Close to the mic, please.
Is that better?
That's better.
Much better.
Thank you.
Thank you. Who flew here? Okay, great. Anybody go to the grocery store since they've been here? Or maybe last week?
Yeah.
Okay. So what was your check-in experience like at the airport? Did you use a teller or like automated teller, or did you use a real person? Automated? I'm assuming you checked in online maybe?
Actually, I didn't check online, just went. I bought the ticket using an app, and then I went to Heathrow. They gave me a ticket there, and I walked through. Yeah.
So you're like a technology whiz, kind of in a way, yeah. And what about when you go to the grocery store? Do you use the automatic checkout, or do you go to the slow line?
Self-checkout.
You guys
Self-checkout.
Okay. So I've done a little preliminary experiment on who doesn't do the self-checkout and who doesn't do the automatic check-in, and it tends to be an overrepresentation of the aging population. So my question to you guys is, have you come across any genius ideas to ensure how the aging population doesn't get left behind in this technology revolution?
That's actually a great question. As someone who's in that population, you know, if I don't pay attention to how things are going and changing, I could very easily be lost. And, you know, my elderly parent has those challenges all the time. So it's a great question, and how do you overcome the fact that the majority of your users are going to be in that age range where they're comfortable with that technology?
Yeah.
What do you have to do in order to be able to overcome that age barrier?
Well, I actually helped to implement a technology at Guy's and St Thomas's in London, which was specific to this problem, but also to do with women's health as well. And we simply used the technology that they were used to, so telephone, but we adapted our back-end system. So when they would dial a specific number, we just told them, this is your specific number. This is the number that you have to dial in. We gave the same number to every single patient. When they dial in, it just brings up automatically in front of the doctor their specific records. Obviously, we do some kind of checks as well. What's your name, date of birth, your address, and then the doctor who's taking that call would simply continue with the consultation. Every consultation would be different. Most consultations last less than 15 minutes. And if there is a requirement to see face-to-face or do a specific kind of test, that's arranged by the back-end system. That the patients themselves, only if they wanted to, could log into their records, but they didn't need to. Everything was done on our side for them. Yeah, that helped reduce waiting times for gynecology from about 8 months to days, hours even in some cases.
Very interesting.
I have a remark on that too. If you look at the grocery chain,
Sorry.
The grocery chain example that you gave, who goes to self-checkout versus man checkout? People who have a lot of products, they want to go through scanning, right? They go to the man. People who are kind of older types that don't want to deal with self-checkout, right? There is a parallel here too. So when we did the deployment, we learned lessons. We found out in one of our deployment, people 75 or 80 and older didn't want to deal with our product. People who don't have smartphone can't deal with the product, right? So we found the sweet spot, 50 to 65 or 50 to 70, that had chronic conditions, adequately tech savvy using a smartphone. So you come across it like that. So we learned lessons, and we converged. There are two segments we look at: 50 and older with chronic conditions, 30 and older that wants to look good so they can join a dating site. So.
Last question.
Okay, Dr. Emily Van Dyke. So I have a US-centric question, but I'd be very interested to hear feedback from anyone. So a little more than a year after Roe v. Wade was overturned, just sort of on the idea of trust in women's health, I was particularly interested in a May 9th article from the Washington Post about how like Google searches will track visits to Planned Parenthood, for example. And so when you're dealing with young women who are trying to make sure they know the most about their health, and also doctors trying to serve them, how do you reassure people that passive data retention couldn't potentially lead them to prosecution when they're just trying to be healthy and fully use their AI? And
Critical key element of security in AI systems like this, and how do you ensure or guarantee to someone that
Start on that. So relative to security of the as far as policies, you can protect some of that information, not a lot of passwordless credential, and only share specific stations they're afraid of. Some of that is done.
You know, I think it's a great point, and it's along with HIPAA and the American CARES Act and so forth about what information can huge benefits side. And making, you know, bad uses of the a $5 million fine. And if you worry, I think the prosecution, I think it's want to run away from that as hard as they possibly could. But I do think it's well worth thinking about lobbying efforts and ways.
time. I'm going to leave you with one: responsibly use intelligence. So.
Excellent. Thank you so much to all of our panelists for their insights. Take two, there is still the conversations with your peers, the hashtag
One, two, yeah.
and we grew up strong. We were wanted all along, but I could fail. No fight left, or so it seems. I am a man whose dreams have all deserted. I've changed my face, I've changed my name, but no one wants you when 'cause you have, you're not beaten yet. Don't give up, I know you can make it good. Though I saw it all around, never thought that I could be affected. Thought that we'd be last to go. It is so strange the way things turn. Drove the night toward my home, the place that I was born, on the lakeside. As daylight broke, I saw the earth, the trees had burned down to the ground. Don't give up, you still have us. Don't give up, we don't need much of anything. Don't give up, 'cause somewhere there's a place where we belong. Rest your head, you worry too much. It's gonna be alright. When times get rough, you can fall back on us. Don't give up, please don't give up. Got to walk out of here. I can project my world at night to a place in the past we've been cast out of. Oh, now we're back in the fight. We're back on the train. Oh, back on the chain gang. Circumstance beyond our control. Oh, the phone, TV, and the news of the world got in the house like a pigeon from hell. Oh, through sand in our eyes and descended like flies. Put us back on the train. Back on the chain gang. The powers that be, they force us to live like we do. Bring me to my knees when I see what they've done to you. But I'll die as I stand here today, knowing that deep in my heart they'll fall to ruin one day for making us part. I found a picture of you. Ah, those were the happiest days of my life. Like a break in the battle was your part. Oh, in the wretched life of a lonely heart. Now we're back on the train. Back on the chain gang. since Daddy had to fly. Now that I know a place where we can go, still untouched by men. So watch the clouds roll back, the tall grass waves in the wind. And you can lay your head back on the ground and let your hair fall all around you. This is the end of the innocence. Spacious skies, now those skies are threatening. They're beating plowshares into swords for this tired old man that we elected king. Armchair warriors often fail, and we've been poisoned by these fairy tales. Lawyers clean up all details since Daddy had to lie. Wash away this sin. Sit and watch the clouds roll by, the tall grass waves in the wind. Stay your head back on the ground. Let your hair spill all around me. Offer up your best defense. This is the end. This is the end of the innocence.
Hey, hey. Check 1, 2. Hey, hey. Yep.
Almost ready. Awesome. Next, how many is it? We got a moderator on there? Yes. Is that you, sir? You?
Hey. Yep. Don't scare me. All right. So just talk, right?
No, this works too.
Hey, hey.
Hello? Minerva colada. Minerva colada. Chesto. That's cool. No pressure. Testing, testing, 1, 2, 3.
Okay, welcome back, everyone. I trust you had a delicious and enjoyable break, and I hope you enjoyed the food here. Big shout out to all the service staff here who work so hard to provide for everyone. Let's dive back in here at our convention. But before that, I would like to thank our sponsors, our gold sponsors, Nemours Children's Health and BrainTap Inc. Thank you for your seamless support. Now, as the prevalence of mental health issues intensifies globally, the necessity to address the scalability of mental health care has never been more vital. However, we're faced with the formidable challenge of expansion without the substantial assistance from the pharmaceutical industry. In this panel discussion on why scaling mental health care will be challenging without Big Pharma's help, our panelists will explore this complex landscape in depth. Now let's please welcome our moderator, Christina Debray, LMFT psychotherapist, consultant, and speaker, and panelists, Dr. Minerva Colada, Chief Medical Officer, Owner, and Administrator of Dianza Clinic, Imperial County, and Professor Dr. Robert H. Schistel, Owner, President, CEO, and CSO of Protective Skincare Inc., Microbiopharma Inc., Radmet Inc., and Immune Right Inc. Take it away.
Hello, everyone. My name is Christina Debray, licensed marriage and family therapist, and I'm looking forward to speaking on this panel as well as moderating. We're going to first start with introductions.
So my name is Robert H. Schistel, and I'm Professor Emeritus of Pathology, Environmental Health Sciences, and Radiation Oncology at UCLA and at 4 huge public universities in China. And I have 16 patents. And what I'm talking about today is my 16th patent and my 6th company. And the company is was not even listed on this because it's very new. The company is called Psycho-Good Inc. And I can talk about all of this, but in general, what I can do with all my stuff is to cure most, up till now, incurable, uncurable diseases. And you'll see what that means with mental health. Should I start with my? Okay, so what my chemical is doing, so to start off with, I had an NIH grant for $31 million, and it took me 10 years to develop it, all the preclinical stuff and everything, and since 22 weeks we're doing clinical trials with it. And this is my newest company and my newest trial. So what the chemical is doing, it gives you an energy boost. It increases your sleep quality, so you have to sleep less. It's more restful sleep. It gets rid of overreaction and aggression. It gets rid of addictions. Also, craving is gone. It increases your memory. People become smarter. And that's because good grades in university and in college are 4 to 5 times higher related to memory than to IQ. It cures anxiety and depression. And this is the fastest thing ever so far. A woman who was clinically depressed for 20 years, the psychologist didn't know what to do with her anymore, was cured in 1 week. And I have the crossover, the PHQ-9 form, which is a standard form for assessing anxiety and depression, was completely normal after 1 week. And after crossover, she took a daily journal, and every day she was better, and at the 9th day it was completely normal. During her interview, she cried 3 times in half an hour, and now she's crying once a week. And it also cures Alzheimer's. And what we are doing now is all the other mental diseases. I'm starting with autism at Rutgers, with ADHD, PTSD, and schizophrenia. I'm also starting with strokes at UCLA. We are also moving into the movement disorders, Parkinson's and Huntington's. So let's see how far we get. And this will be all in the international filing when I have to file the international patent, which is in about 9-10 months from now. And of course, if you have any questions, I can always talk about much longer about everything.
Right, I'm Minerva Pilata. I'm board certified family physician. I own and run a rural urgent care. I graduated from UCLA. I also happen to be the chief medical officer of Imperial County. I also happen to be an adjunct professor of medicine at UCSD. In the same time, I did actually manage a mental health facility, a locked facility for 25 years. And I did take care of them while they have their problems, and I do have first-hand treatment on their issues. I could see that now we have so much problems with mental health, and actually it's affecting everyone, everywhere. At the same time, hello. And at the same time, I would say, aside from my involvement with mental health, I have been on a lot of leadership with physicians throughout the San Diego area and Imperial County, and I could see mental health is not only affecting patients, but in general physicians, you know. There's in all sorts of layers that people are really affected. I have been involved in research recently with the University of Arkansas, and there is a research paper just being published at this point about what is causing mental trauma in our teenagers. And the study was held with several other physicians. It carried with autism and other functions. And the result of the studies is going to be published. There's many case studies actually is carried in the same token. And that's all about me. Thank you.
Okay, so now we're going to begin our 5 to 10 minute presentations. Then we will move on to moderator questions and then audience questions. So how I got started in mental health is I was born in 1986, and at 6 weeks of age, I was diagnosed with a catastrophic, progressive, and terminal medical condition called cystic fibrosis. I was then later diagnosed as a type 1 diabetic. I spent the first 5 years of my life living in hospitals, and at no point did anyone address my mental health. And even though I had social workers and therapists evaluate me, nobody ever mentioned anxiety, depression, or PTSD. So when I was in my 20s, I went to graduate school at Pepperdine University, and at a conference, I had a chance encounter with a woman named Francine Shapiro, who is now passed. And she was a woman who created a type of therapy called EMDR therapy. And after getting EMDR therapy, I realized that I had Hello, testing. Can I switch mics? Okay. I had, in fact, PTSD for over 20 years, and I was able to resolve that. And so I decided to specialize in that. And throughout specializing in that, I participated in 3 separate clinical trials as my disease was progressing to end stage. And after the 3rd clinical trial, my health stabilized. And that was about 12 months before COVID started. And also, about 3 months before that started, we had the Saga shooting up in the Santa Clarita Valley where I practice. And so there was just a complete inundation of traumatized children, teens, adults, parents, families that completely overwhelmed my practice. And many therapists moved out of state because they couldn't afford the cost of keeping their practice open. And the severity of trauma was so severe that the clients needed to pursue psychopharmacological intervention in addition to psychotherapy services in order to make progress. So there really is an absolute opportunity and necessity for pharmacological interventions as well as therapeutic interventions and other systemic approaches.
So I might have something for you. I had so far 4 diabetes patients, and they got rid of all their symptoms. And in 2 weeks, I'll know whether it actually stabilizes the blood sugar level. But now going back to, and cystic fibrosis, I don't know, we haven't had anybody, but it might also benefit if it has anything to do with autoimmune problems and inflammation. So going back to the mental health aspect, actually, 4 months ago, I received the Outstanding Leadership Award in Healthcare 2022. And yesterday, I received the Outstanding Visionary Award in Healthcare 2023, which is the next step. And tonight, I'll receive the Outstanding Leadership Award in Money 2023, because nobody else in the world makes more money long-term than my investors do. And now going back to mental health. So we are now starting. So what my chemical is doing, it induces 244 different proteins in our body. And there is lots of anti-inflammatory proteins and DNA repair proteins, but also 9 neuroprotective proteins. So it's the first time that we have a chemical that causes our neurons to be protected. Our neurons and our brain cells. And that's why it has all these psychological and psychiatric effects. Now, what it also seems to be doing, it seems to quiet down our autonomic nervous system. And that's actually our stress response. That's our flight and fight response, which we don't need nowadays anymore because there's no saber-toothed tiger running after us, and it just stresses us out. And all these, what it causes is also stress-related diseases. And these are all the things I can actually cure. So if you look up the autonomic nervous system, it's involved in all these things I can actually cure, and that includes depression. That also includes cancer and heart disease and intestinal diseases. So these are all other things I can cure with my other patents. But this also includes depression. And now I'm working on all the other mental diseases as well. So I have something that protects your brain cells. And it increases memory. It does all these things which I already told you about. And I'm really curious about the autistic children. And I also started with the PTSD Foundation here. And we are starting with all the other mental diseases. So, so if you have any questions about this, but maybe we can move on to you finally, and then we start with the questions.
So with my experience being actually the medical director for locked mental facility, I used to see those patients really overdosed with antipsychotic medications. And while I was also the hospitalist at the same time, I would take those medications and talk to the psychiatrist and tell him they are not guinea pigs and they need to give the medications in moderation. So we do have some challenging situations as a practicing physician. The problem is a lot of psychiatrists just go high dose, and that's the way they think that they are going to be able to maintain them. The problem is the legality of the system, is that they don't want those patients to be in trouble, but in the same time there is no support to them, whether it is family or surrounding. And that's a big challenge that we are not prepared. We lost our gap of communication in our family. Our family ties is basically the major problem. In my case study that I did in my research, I did study several teenagers and I did compare them to other places like Los Angeles or other places in China or India. And I just thought, why would the teenagers here or youngsters here are going into shootings while other places in India or China, they have less chances in life and less money available, but they don't go shooting in schools like what we are having. And so major part of the problem is the family ties, and that's number one issue. There are several also case studies have been done about schizophrenic patients, and we lead to just immediately dump them in a hospital. And there's many case studies, that one was done by Johns Hopkins University several years ago, talking about that the first hospitalization is basically from there downhill the patients would go. There are several other ways that to handle the situation, which is family support and to help the patient to be compliant to take the medication. I wouldn't say that not taking the medication is the right answer, but not to overdose the patient. So the best thing is just to encourage. Like, I do know several examples, like I do have even a nephew actually was diagnosed with schizophrenia, and he started Abilify, and he went and he made it to medical school and he finished, and with no problem. But there was a lot of family support. On the other hand, when there is no support, the whole situation would go the other way. I also say that the best thing is to start therapy early. And the problem with us nowadays is we think once you get to be labeled as mentally ill, this is like a stigma, it will take you for the rest of your life. People would rather to say, oh, their son have cancer, better than say he has mental illnesses. So I think it's a big part that we are not prepared to handle mental illness as a society. But I see in other areas, like I do a lot of missionary work in Africa and in Mexico, and I see that they are more prepared. They engulf their family problems more than what we do. And I think that's mainly most of my experiences at this point. Thank you.
So now we're going to start with the moderator questions. So the first question for us panelists is, how can we ensure that scaling mental health care does not compromise the quality and accessibility of services regardless of Big Pharma's involvement?
So I don't know what big pharma is. I call it smart pharma. I'm not that big. But, so I don't completely understand the question because we need medication to, even for all the other mental health services, it's better if the patients are on medication. So we need medication to actually prepare the patients, and then with all kinds of mental health services can improve their condition further. But the underlying thing in my mind is that we do need medication.
I agree that medication would help, but with moderation. I would say the problem I see in most of mental health is lack of sleep. A lot of PCPs and providers, they do refuse to give narcotics for the patients. And I really am in favor of giving some narcotics to the patients to calm them down. And that's the core of the problem, is lack of sleep. Anyone, if you notice, if you actually don't sleep for a night, you become like a zombie and an angry person. And there are many other medications also I kind of like crafted through the years to help my patients not to have to be narcotics, like trazodone is used a lot in the Veteran Society. There's some blood pressure medications, that vasopressin also is another medication with help. But I see that the start of medication is not a bad choice, but with moderation, not overdose the patient and not to cause them to be drooling on themselves and have no bowel control. Everything in moderation is required. Thank you.
So can I just respond to this? So this argument is due to the currently available medication. And I can tell you guys again what my chemical is doing. It increases your sleep quality. People have to sleep less. And that's one of the effects. Actually, it quiets everything down. It quiets your body down. And thereby, it cures all the other mental problems. So, again, it gives you an energy boost. It increases your sleep quality. It gets rid of aggression and addiction, and it cures Alzheimer's and depression. And we are now doing, it increases memory, people get smarter, and now we're doing all kinds of other things with it, all the other mental problems. So the current arguments which you find are related to the current methodology. And actually, medicine is not a science. Medicine is an art, and the art of treating patients with the currently available medication. And that will change as soon as new medications become available. Thank you.
To dovetail off that conversation, I think one of the challenges to consider is the quality of care of the medical doctor and the clinical finesse and the ability to find the right medications. I see this so often with the patients in my practice that they are misdiagnosed, that they're not given the right medications, they are over-medicated, they're coming in for symptoms secondary to medications that aren't the right fit for them. And so I think that, in this talking about accessibility of services and quality of services is critical. And there's really an opportunity now with telehealth, to be able to find quality physicians, to be able to provide services to people who are potentially in rural communities. Okay. The next question are, what are some innovative approaches or strategies that can be employed to scale mental health care effectively and efficiently?
So yes, to scale, scale up means treat more people, I guess. So we can currently produce 2,000 tons per year of my chemical. That's enough to treat 5.5 billion people. So that's the amount of scaling I can do. If I need to treat more, we are out of people in the world because we only have 7.5 billion people. So yes, that's the upscaling we can do.
I think the upscale would take the mental ill person and the people who are around them to kind of like cope with their illnesses, because sometimes the mental trauma is not the person only. The problem is, again, people to recognize the issue. Like my daughter was in the army, and I remember at the time of her going to Iraq, I liked so much the Veteran Association just come and tell me that you need to be seen too. I mean, I felt better to talk to someone, which I think therapy is number one before giving treatment. So I'm so much in favor of therapy as an approach before jumping into medication.
I also think it's important to address the barriers to treatment. If we are going to talk about scaling mental health care, there is a lot of stigma for different cultures, religions, genders, sexual orientation, and there's really an opportunity for pharmaceutical companies to help put out psychoeducation, fund social supports for mental health professionals to do the same. With technology, this is easy to create a TikTok channel or a YouTube channel where people can easily get the information, and to help people feel less afraid, to help connect people with resources, to help people find grants, to help people understand how to navigate insurance and coverage.
Sure. I think this stigma, it's not really present in the educated society. Most educated people know that mental problems exist and that there could be help for it. So the stigma might be in rural communities, and yes, I completely agree that the society needs more education, but not just on mental health, on any diseases, and that we need to just be more gentle with everything, with each other, with animals and everything, and to educate everything that it's fine to say that you have a problem. And that truth should be widely available to everybody in our society. And if people accept that, then this stigma will actually go away.
I do agree, is acceptance of the mental illness. We do accept other illnesses, but mental illness is very hard to accept. Kind of the society, in a way, does not want to kind of accept the disease as a disease, you know. They think of it as, oh, once a person is mentally impacted, that he's gone and he is not coming back. We don't have a lot of education, and I agree on that. And I think a big part of it is that, again, is our family ties are really kind of not as strong in supporting the presence of a mental illness. I see that in a lot of the patients that I have. I'll never forget a patient who actually was in the mental facility, and he was a CIA agent, and he was in a high top. One night he kind of got a little bit drunk, and he was caught, and afterwards he ended up in a mental facility. It took him 7 years to get out of there to prove that he is sane, but he became insane inside. You could imagine the situation. And this actually, I got so much interest in him because I felt that the man was a very intelligent man, but everybody thought that he was a little bit crazy. I think that his problem was alcohol and drinking, and once he got treated of that, eventually he was able to go back in his life.
The next question that we have is, what role can big pharma play in supporting the scaling of mental health care, and what potential challenges or ethical considerations may arise?
Again, I call it smart pharma. But so problems, I don't think there's any problem treating somebody with something that makes you feel better and that cures your problem. And ethical problems, I don't see any of that either. Let me tell you also what the effects actually on my cats, which is very interesting. They actually got rid of all their shyness. They don't hide underneath the bed and underneath the blanket anymore. They sleep 2 hours more per day. So it's interesting. People sleep less and need to sleep less, and cats sleep more. They actually, I mean, that's a completely different effect. They don't shed anymore. There's no hair on the floor, but that's one of my other companies. I call them lap cats because, like a lap dog, they just want to sit on my lap and being petted. Before, after 5 minutes or 2 minutes of petting, they always went and did something else, and now the only reason why they leave me is if I stop petting them. And they are much more accurate in their jumps. They always arrive where they want to be. They don't bump into things anymore, and they catch the toy every time they reach out their paw. And they became codependent, which is completely unusual for cats. This is usual for dogs. So when I put on my clothes to leave, to do something outside, they put their heads on my thighs and their paws, and they start meowing, which is completely unusual for cats. So they become much more domesticated, much more, much nicer to us. And I know some people don't like that with cats, but most people would actually like their cats to be sweeter and nicer. So it also should work with dogs, but they are much sweeter anyway. Anyway, so I don't see any ethical considerations to treat somebody which makes them feel better. And actually my patients are not the regular patients in the hospital. My patients so far are people who can make their own decisions about healthcare. These are university professors. I have a lot of lawyers. I have a lot of scientists and company owners. The wealthiest person has a company that's worth $50 million. And what they want to do, of course, is to sleep better, to not yell at their employees because that's bad for the business, to not get depressed once they have bad news, and to enjoy life more. So anyway, I don't see any problems or any ethical considerations.
So the same is pharma is really needed, and I think before the pharma, I would say that the therapy, the psychotherapy should take place. And I don't think any unethical situation here, but Only thing I see lately with the psychiatrist is the huge dosages that they put the patients on. I think in a way I wouldn't say it's unethical. The way I see it is their choices are limited because we're barely starting to know about mental health. So the problem is that they use a lot of injectables to make it easier because it's very hard to bring the mental ill person to take the pill on a daily basis. And that's mainly the core of the problem. So they end up giving those patients an injection every month. And once the injection basically starts with the patient, the value of the medication goes down a little bit during the month, then the symptoms come. Then they start to increase the dose. Then when increasing the dose, that the patient is basically dragged like a poor dog, and it have more side effects like extrapyramidal jerking and, all over twitching and memory loss and, become dysfunctional of a person. That's the way I see it. In a way, is kind of like unethical, but in the same time, the psychiatrists, again, have to practice in a way that the legal system, he doesn't want that person into trouble. That's the issue. Because if he does not overdose him to that point, that person is going to be in trouble. For sure, he will going to go somewhere, hit someone, become violent. That's why they end up having a big dose. And it becomes like a vicious cycle. But there are ways of handling the situation. I've seen a break in the middle, which is once the patient starts the medication, at least maybe the injection, excessive therapy should be starting. Once the excessive therapy starts, having those people into creative kind of activities, have them into doing functions with their life, instead of become dysfunctional and lose hope to be active in the society. As a matter of fact, I actually started a program myself to intellectually have teenagers being involved. And as the doctor mentioned, medicine is an art. I think that seeing many medical schools have put art as a study in their curriculum, I see here that we should have more art introduction in our society. So I'm getting those teenagers as younger to start into art sessions to make them divert their thoughts. And I frankly think that there are multiple ways that we could help kind of like the dysfunctional person to become functional. Thank you.
So actually I want to respond to this with over-medication and with loss of memory and all these things. So if you guys think that there are people on this podium which live in different worlds, this is true. And the thing is that I'm a scientist and I come up with new medication, and the other two people on the panels are medical professionals which treat patients with currently available medications, which does not include my medication yet. So what you see as a disadvantage of medication treatment of mental health is with current medications, which, yes, they cause a lot of side effects. But actually the side effects of mine is that you actually memorize things better, memory is increased, and that you sleep better, which is not so with current medications. And the other thing is over-medication. You cannot over-medicate with my chemical. Mice with 100-fold that dose are completely fine over 4 generations. If you take the whole bag at one time, nothing happens to you. So it's a very nice and gentle chemical, which doesn't have, nobody in my clinical trials has any negative side effects with it. And the current medication, yes, I realize it is the same thing we used for the mice, and we need to figure out for different diseases whether this is the optimal dose. But if you take more, it doesn't matter so much. Okay, thank you.
So I want to get an idea of, by a show of hands, of how many audience members have questions for the panel. So no questions.
Come on, guys, you must have some questions.
Okay, panelists, let's take an opportunity to share some final thoughts. I'll start. You know, one of the things that I think is important to consider in the discussion of utilizing pharmaceutical companies in addition to other treatments for mental health are the differing models of treatment. For example, the medical model versus a systems model. Part of the challenge I see is that, you know, if there's an overemphasis on the medical model, then, you know, we have concerns where we're creating state-dependent learning. People, you know, it's a Band-Aid over the wound type of a treatment, and people need to rely on those medications instead of addressing the underlying systemic problems that are potentially creating the problem to begin with.
Again, this is a difference between currently available methodology in mental health and new methods. Because first of all, there's no problem. There is no withdrawal effect if you discontinue my chemical. The only thing that can happen is that whatever problems you had before, especially if that's genetic, can reappear. If it's your experience, it might not reappear. Because if you are fine for a couple of months or a year, you might forget about negative experiences. What my chemical actually does, it chases away negative and depressive thoughts. So it makes your brain free for positive things and positive thoughts and positive memories. So I don't think there's any problem with either over-medication or with medication where there's other mental, whether exercises or brain exercises or memory exercises or whatever other people use. I think it's mutually supportive. And people with severe mental diseases do much better in their other brain exercises if they're medicated.
I would share the opinion if anyone gets challenged with mental illnesses, I would suggest family support and to reach out available society places that could help the person as soon as possible, and not to ignore the situation and not to be in denial because that's a big part of the problem. The second issue, aside from that, therapy. Therapy helps a lot. And therapy actually could be for all the family, that the person with the family and the loved ones around them. And I would say, don't be shy of a person taking a medication, and because we take medications for diabetes and high blood pressure. So why we are concerned about that, but it shouldn't be kind of overdosing the person. So again, I would say not to deny the situation, give the support, act on it as soon as possible, and see if there is medication needed There is no need to say, no, this person should not. Oh, how we have a family member who is sick with mental illness. So what? You have a family member who's sick with high blood pressure. What's the difference? You know, and that's basically my take at the end of the day. Thank you for your listening.
Any questions?
So I think it's interesting that you all come from two different worlds. And I'd be curious, so as I was listening, one of the things that occurred to me is, what if you could combine those worlds? Like, what if you could take the medication that doesn't have the side effects, gets rid of the depressive thoughts, but then use therapy to help people, excel, climb even higher, even faster, so that they're changing their lifestyle, changing their behaviors, changing their thinking patterns, but using a chemical that doesn't have the side effects and doesn't have those negative, the negative things associated. And I'm also curious then if that helps get rid of the stigma attached to mental health. Because if you're talking about mental health from a perspective of I'm lifting up versus I have this challenge, it shifts the whole conversation. So I'm curious if you guys see that as well, or if you're like, no, I'm way off track.
I absolutely see that, and I think that as improvements are made in, psychopharmacological interventions as well as therapeutic interventions, that overall that will help reduce the stigma, because, when we're giving somebody a medication that has severe side effects or doesn't work, or a therapy that's, incredibly distressing with minimal benefits, we're unintentionally gaslighting patients. And so working together as clinicians and pharmaceutical companies, there's really an opportunity to continue to fine-tune, improve, and reduce the stigma.
So I'm very happy that you asked that question, because I talked to you already for 2 hours yesterday, although today, and you already received all my messages. So you are actually a convert.
Oh, interesting. Yeah, I feel like I know it, but I know it better than.
Yes.
That was part of it. So, yeah, thank you.
Yes, and anybody else who actually is now starting to get interested in my things, I can send everybody information. I just need your business cards. I give you my business cards, and I'll send you information. Thank you.
I would just, what happened here is not Lucy. Yeah. So I would say, like I gave you the example of my nephew, that he has therapy and he has medication at the start of the illness, family support. He finished medical school. He's a psychiatrist now. So, like I said, you have examples in life that you could do, but recognizing the illness, number one, and then have therapy, family support, and then medication. There's nothing wrong with that. Thank you.
Thank you, everyone. Whoa. That concludes our presentation for today.
Thank you, panelists, for this insightful discourse. We're going to move on forward to our next panel. On to our next panel. In an era marked by rapid medical advancements, the journey of novel treatments from research labs to patient care is a pivotal topic. In our next session, a panel discussion on From Bench to Bedside, bringing new medical treatments to patients. Our experts will aim to explore and demystify the complex processes behind transforming medical innovations into real-world patient therapies. Let's join them in this vital dialogue as we venture through this intricate pathway of healthcare transformation. Please welcome our moderator and panelists respectively, Jeffrey Champagne, VP of Business Development at Inertia Product Development, Abida Batra, Founder and Chief Strategy Officer, Neuro42 Inc., Craig A. Parnell, Senior Director of Business Development at HealthLink Dimensions, Abdelrahman Zamzam, Data Scientist at Unity Health Toronto, and Dr. Eric Ebegbu, MD, FACG, CEO of Atlantic Medical Group. Thank you.
Thank you. Thank everyone for being. I want to thank our panelists for spending time with us today. To warm up conversation, can everyone? Seems to be cutting in and out. Get rid of this mic. I'm gonna stand up here. We're good. Keep those. There we go. All right. So good afternoon, everyone. Thank you for spending some time with us today. My name is Jeff Champagne. My background is in early and emerging disruptive technologies in the med tech space, and I've spent the last 15 years working with physician entrepreneurs to create first-of-a-kind medical devices. And I'm excited to share with you our panelists' experience today. We're going to talk a little bit about the process of how do we go from an unmet need to a patient actually using a technology, and what does that mean? Everything from the kind of design, the discovery, the development, the de-risking. I don't know why they always start with Ds, but the deployment and then the messaging that goes along with that. And so I'm really happy we've got a great panel today, and we're going to talk through those things and some of their experiences as they navigate this new product development process. Does this sound better? Is this too loud? Okay. So with that said, I'll introduce my panelists. You heard their kind of credentials, but Abida, Craig, Abdel, and Dr. Eric Ebegbu, thank you for being here. So let's start early in the process. You know, before we start developing a device and spend millions of dollars doing so and spend the time to go out there and collect checks from investors, there's a lot that has to go into the discovery process. And so typically there's some revelation, there's some, understanding of an unmet need. And from that unmet need, we might see a correlation, and that's where our data scientists come in. Abdel, can you introduce yourself and talk a little bit about what you do in the process of new developments?
Yeah, sure. Thank you. Hi, everyone. My name is Abdel. I'm a data scientist at Unity Health Toronto. I've been working with data for more than 10 years with a pharmaceutical studies background. And boy, do I love my data. You just give me data and I give you answers. So our group is focused mainly on two goals. Number one is improve accessibility to patients. And number two is cutting costs. In our projects, we focus on identifying blood biomarkers that can help predict future outcomes in patients. And these outcomes are mainly cardiovascular disease outcomes. So, for example, a patient may have a blood test, a simple blood test. And from this blood test, we can find the risk of this patient having an MI in the next 2 years, for example. We have a huge plasma biobank back in Canada. It's one of the biggest plasma biobanks in Canada. We have more than 4,000 samples, both blood and urine samples, because we also do urine analysis. And our main goal, as I said, is to build a model that can help improve patient outcomes and predict future outcomes for patients so we can overcome them at earlier stages.
Thank you, Abdel. So this is really a powerful thing. I spent a year as the general manager at Kohler Company. So Kohler is the kitchen and bathroom company. They wanted to own healthcare in the kitchen and bathroom, right? And so one of the exciting things about this industry is that a lot of serendipity occurs. And the fact that Abdel and I were put on a panel together, I don't think is by chance. The universe just said, these two people need to meet. And that happens a lot at these kind of conferences, right? So just by connecting the dots. So as you think about that, this blood biomarker that Abdel is working on, this discovery process, right, and labeling something that could predict MIs or heart attacks or congestive heart failure or strokes, I mean, that could be a really powerful tool. And what if you could detect that in a urine biomarker, the same biomarker as blood, but with a U in front of it, that could be a powerful thing. So you could use a toilet, for example, as a diagnostic tool to predict heart health. Wouldn't that be wonderful? So a lot of these kind of seemingly disparate things that we experience in healthcare, when you collect them as big data sets, you start to connect the dots. And I was really excited to hear about his discovery and this correlation, dealing with, cardiovascular health issues myself and having a family history. I want to know, right, what's the future hold for me? Can I do something today that'll help my kids have a better future and avoid the health history that my father or my grandfather had as a result of this familial disease? So these are the kind of conversations that spark some of these things that will lead to, if I know I'm going to make introductions for Abdel to investors, how these developments actually get pushed into the marketplace. A lot of it is serendipity, to be honest. And serendipitously, I was also connected to Abida Batra again this week. Abida and I have crossed paths several times before through her work at Automagnetics as CEO. She's a serial entrepreneur, a serial CEO, and is very accustomed to developing and launching products. And I'm going to let her talk a little bit about the two that she's working on today, both at Automagnetics and Neuro42. But again, they all come with, what is the problem we're trying to solve? What's the unmet need? How can we come up with solutions for that? So Abida, would you mind saying hello and talk a little bit about what you're working on?
Yeah, thank you so much for having me here. I think it's amazing that we are crossing paths again, maybe after a couple of years, right? It's been 3-4 years.
That's right.
But I think, so overall, my journey has been in healthcare all along. I've been in healthcare for as long as I can remember. It's been over 20 years now. I was born in a pharma family, but then again, I paved my own path with innovation and launch of new products all across the globe. So I've licensed a lot of technologies and launched a lot of products in developing nations as well as developed nations. But the two technologies that I'm here with, one is Automagnetics, where we are doing non-invasive drug delivery, and the other one is Neuro42, which is my recent startup. And we've raised over, I would say, 14 million within 1.5-2 years. And we are very close to commercialization in the 3rd year of the launch. We've developed a product which we licensed from Mass General Hospital. This is a portable MRI for real-time scanning of the brain, just to provide confirmation scans for tumor resection. We want to develop a very new version of the product that the world has never seen. So we are creating a product with the integrated use of MR, AI, and robotics. We have licensed the robotic technology from Johns Hopkins. We would be the first one and the only company to develop a product with the integrated version. But yeah, for the first diagnostic imager that we are developing, we'll commercialize that product next year.
Excellent. Thank you, Abida. So talking about, reducing the cost of healthcare, providing better access to patients that are looking for that technology that might not be able to get into a major metropolis or an urban center that has the resources or, but taking something that's portable, making it ambulatory, putting it in an accessible location. So I appreciate what you're doing there. We're going to talk a little bit more about that.
Thank you.
And innovation a lot of times starts on the front line, right? From our front of the line is the healthcare providers, the practitioners who are discovering those unmet needs. So we're here with Dr. Begbu today. Thanks for joining us. And Dr. Begbu is a gastroenterologist working on new technology. Love the shoes, by the way.
Thank you.
And if you could help us, Eric, understand a little bit about your background and what does it mean to kind of discover those unmet needs in your practice?
Yeah, indeed. Well, it's so great to be here. Thanks, everybody, for being here and being attentive. So, indeed, Jeff, thank you very much. So, indeed, I'm a gastroenterologist by training, and however, I've become what I call an endobariatric gastroenterologist. So, my focus of attention now is in helping the average person out there lose weight and get to a healthy weight, because obesity is a condition that many people regard as a moral failure or as a failure of character. They think, oh, when we see somebody who's obese, many times it's been said that these people appear to be invisible, if you will. But even if we were to acknowledge somebody who is obese, we tend to think of them first, oh, this is a moral character, or a failure of character on the part of the person. They don't have self-control, they don't have the will to go to the gym and to work out and things like that. But what we should understand, and what I want to pass across very, very clearly to everybody here today, is that obesity is actually a disease. It has a code in the disease code in the medical world that classifies it as a medical condition. So it's likewise, like I always say, if you and I were to meet somebody who's diabetic, chances we will make fun of them, right? If we were to meet somebody who's diagnosed with melanoma or who's been diagnosed with leukemia, we will make fun of them, right? Because we know they have a disease, correct?
Sure.
But we inadvertently, silently make fun of people who are obese, right? Because we think it's a social stigma. So in my practice, what we've seen, understanding that obesity is a disease that impacts everybody, really. So that definition begins at a BMI of over 30. So most people in America, we know now, close to 50% of Americans are either overweight or obese, and that rate is increasing. So we knew there was a gap in the solution space, because the solution for obesity was always join a gym, do what everybody does on January 1, and come February 1, they forget all about it, right? Or the other extreme was surgery, have life-altering surgeries like gastric bypass, which has saved a lot of lives, gastric sleeve surgery. But then there's this big gap between going to the gym and having surgery, where there was no solution for many years. And gladly now we do have these endobariatric procedures that I specialize in, where we're able to alter the gastric anatomy without surgery, accomplish the same with less risk to the patient, and patients are able to go home very, very quickly, and on the same day actually, and which is really exciting. So now we can actually help people get to a healthy weight, because what my dear friend here was referring to regarding MIs or heart disease that we can predict. We know one of the great predictors for heart disease is obesity. So it's right in our face, and yet we ignore it. We ignore it as a group of doctors and professionals, from diabetes to high blood pressure to heart attacks and things like that. But anyway, that's just a big nutshell of what we are doing in the obesity space.
Thank you, Dr. Begbu. Appreciate it. So later on in the process, once solutions have been created and once you found the unmet need and discover a way to solve it, right, now we need to get it out to the public that these things are available, that these technologies are available. And so I'm going to talk to Craig a little bit, but then also back to Dr. Begbu. How do we create awareness for these technologies as they come out? Craig, you talked a little bit about your background in the biotech space, but also, how does the adaptability of these indications and how these drugs in pharma are used affect those populations?
Yeah, well, Craig Parnell, I'm the
Senior Director of Business Development at HealthLink Dimensions. And we have the largest physician database in the nation. We do programmatic advertising as well as email marketing. But what we really do is sit down with pharmaceutical clients, hospital clients, and help them get the word out to their audience. That's what we do, and bottom line. I have 40 plus years in the pharmaceutical business and the advertising business. And it's very interesting. I was sharing this before. I actually launched Revlimid in multiple myeloma. And that was a top drug in 2006. That drug in the 1950s caused birth defects. And there was a scientist in the labs at Celgene that said, my God, this was causing birth defects. And now it's it's actually one of the best therapies in the world for multiple myeloma.
Yep.
So
Speaking to the mic, Craig. Just put the mic a little bit closer. Yeah, there you go. Sorry.
So it starts with the scientist. That's at the end of the day. And once they have that innovation and it goes through phase 3, then we get it out in the market, the word out to the physician, the patient. And there's a lot of technologies you're using today that excel that relationship between the patient and the physician, as well as, the pharmaceutical company getting the word out there.
That's right. So one of the things that I've used to frame these discussions and a lot of these technology developments is what we call the triple aim. The Affordable Care Act, as it was built, had this triple aim at its center, and the triple aim is really to lower the cost of healthcare, to increase the patient experience, and to address population outcomes. And so, all of these entrepreneurs and scientists and marketers or doctors are doing just that, right? They're trying to find better ways to reduce that cost to get a better outcome. And recently I joined a company in Toronto and have been involved with different healthcare initiatives in Canada over the years. But I always find it interesting north of the border, the mindset when it comes to healthcare is more of an all for one and kind of one for all. There is a common interest in lowering that cost of healthcare. In the U.S., it seems to be, how can we charge more, or how can I build a business around making money in solving problems? So there's a real difference there. And the countries are incentivizing the populations in similar ways too. I remember I worked as a judge for Genome Quebec. It was a genetics competition in Quebec region, and half of the score was on how group, not a specific disease state. How does this raise the bar for everybody? And I think if we want to really solve healthcare problems in this country, we need to have solutions that address those things at the base level as a foundation for success, as opposed to for profit. And once we start doing that, we're going to see actual outcomes improve. And the reason why I mention that is as Craig is mentioning, different ways that we can repurpose things, or we can find solutions and get them out to the people that are going to be using them as end state, or creating awareness and campaigns around disease states that are social stigmas that keep people isolated, right? But they really just need help. They need treatments, they need things that are going to get them back to living a healthy life. But I think the more that we can phrase things and create a common language around healthcare, the more we can develop products that are going to actually do just those things. Abida, as you look at population healthcare, right, and this portability and the ambulatory element of MRI, what motivates you to launch these products into the market?
I think we've been very fortunate that we are working in healthcare and we can make a difference in someone's life, right? When you create products, even if it's generic market, right? You provide the product at an affordable price. You provide it to masses that can impact the world. But when you get to innovation, you can actually change the dynamics of healthcare, right? No one ever thought that real-time diagnosis could be possible, outpatient procedures could be possible, but they are possible now.
Yep.
Things have changed, and more importantly, for Neuro 42, we are changing the landscape, because if you look at NeuroSuites, it costs around 10 million or more to develop one.
Yep.
But with the product that Neuro 42 is developing, you don't have to do that. These are products that are portable, that can be put in a clinician setting, do not require that extra shielding or physician to prepare a patient or physician to spend hours to prepare the room. It allows for the product to be there, in any office-based setting. And that's something that the world has never seen before, especially in brain, right? You talk about brain. A physician has to go for, or a physician does surgery for hours and hours.
Sure.
If he can provide real-time scan, create an impact so that those surgeries are correct and accurate and there are no mistakes made and there are no misdiagnoses that are happening, for that particular indication, that's a real impact.
Sure. So, for example, you had mentioned stroke as being one of the indications that could be looked at with this new ambulatory technology and getting to those stroke victims or those patients that are experiencing potential strokes, right? Every second is going to count.
See, time is brain.
Yep.
So the most important thing is, like, if you talk about neurological condition or stroke, every second counts, yes.
Yep.
So it is important.
And then the cost as well. So cost of a typical MRI setup in a hospital with its own wing that's dedicated and its own reinforced floors and everything else so you can house these massive magnets. What's the typical cost? I mean, it's up there.
It's out there. It's like $10 to $20 million. The experience is uncomfortable with the neuro imaging device that we are developing, which is portable to provide real-time diagnosis. That the cost is going to be around $600K, but the eventual product that we are developing that has the integrated version of AI, MRI, and robotics, the market analysis shows us that we can, the market is ready to pay for it, which is, I think, around 1.1 million or upwards of 1 million, which is still a small portion of what they're spending right now. So
That's right.
It's very cost effective.
So when you talk about access to care, I mean, those massive changes in the dynamics of the structure are going to make a big difference.
Exactly.
Thank you, Abida. Abdel, when you are working as a data scientist uncovering these new kind of correlations, what's your motivation? What gets you up in the morning? How do you think about developing new things?
Yeah. Well, first of all, like it's an amazing feeling when you be able to improve someone's life, even like by a small portion. It's an achievement for me just to be able to improve someone's life, or even warn him earlier that, okay, so you are at risk of developing a certain condition. And to be able to do this is what makes me motivated every day to work on my data, to be able to develop my models to be more accurate and more efficient.
So how long in the future? I mean, you're on the front edge of kind of a discovery, right? So how long could that take to actually get into the hands of someone that's gonna benefit from it?
Well, we've been working on several biomarkers, and I will mention an example. Like we're currently working on a biomarker called fatty acid binding protein 3, short FABP3. This biomarker, we have found that this biomarker is expressed in a certain concentration in the plasma of patients suffering from peripheral arterial disease. We have successfully identified cutoff points for this biomarker to diagnose a patient with PAD. Also, we have used this biomarker to predict future outcomes for patients with PAD, like requiring a vascular intervention, or even myocardial infarctions, strokes, and other cardiovascular diseases. And to answer your question, so it might take, like, we've been working on this for like 4 years now. We have found a lot of discoveries throughout our way, and I believe in the next like 2 or 3 years, we'll be able to effectively utilize this biomarker in the market as an effective biomarker that can predict cardiovascular diseases in patients with peripheral artery disease. Yeah.
Awesome, thanks. So 2 years. So how can we shorten that path, right? How can we make it easier? We just saw through the pandemic emergency use cases and the ability to kind of rapidly move things through pipelines that typically there's lots of roadblocks. Obviously, for safety and efficacy reasons, those roadblocks are in place. But how can we as an industry change the dynamics so that we can eliminate some of the bureaucracy or roadblocks that make it faster? Craig or Dr. Abegbu, any suggestions or comments?
Yeah, indeed. So I think that unfortunately the practice of medicine in 2023 and in recent years, we've all are now practicing what I call the medicine of catastrophe, right? We are in a catastrophic mode. We are trying to help people jump off a burning building. My dream, my vision is, how do we keep the daggone building from burning up in the first place? How can we stop the fire? How can we prevent the fire? Yeah. So my emphasis when I speak with patients and I help patients is I try to look at it from a preventative standpoint. And sometimes I think I'm working myself out of a job, but that's great. Because if everybody is healthy, guess what? If everybody is at a healthy weight, I believe, the incidence of diabetes and blood pressure and myocardial infarctions and strokes will be minimal. And this is not a fantasy. This has been documented in communities around the world where obesity is at an all-time low. The communities and countries that have lower obesity rates don't have these conversations we have in America. They just don't. They don't have to. Yeah. Because they are spending their time and the infrastructure building their community, building their people. People are living happier, longer, healthier. And here we are in America, and we are focused so much on equipping people with parachutes to jump off of a burning building. Mm. Let's stop the fire. Let's prevent the fire. That's my thing. I know, obviously, prevention is not pushed in American medicine because prevention does not put dollars in the pockets of companies that push medications and things like that. And nothing wrong with pharmaceuticals. I love pharmaceuticals. I use them. I prescribe them. I believe in them. But I think that the more we can get more people on the preventative side of life, the better we will be as a community, the better we'll be as a people, and the better our purpose on earth will have been fulfilled. For me, the drive is let's prevent. Let's prevent. And that's where we know now that obesity drives every condition my dear friends and panelists have mentioned this afternoon, and what everybody else at this conference talked about. The background of it all, the elephant in the room that is never addressed is the weight. It marvels me, right? Before I got into endobariatrics, and it was so difficult for me to address it because I felt they will think I'm judging them. They will think I'm looking down on them. In fact, we want you to acknowledge that there's a problem. Sure. And when we acknowledge that there is a problem, and the problem has a root, because the tree is diabetes, it's high blood pressure, it's your focus of pills in it. I wish we can address the tree. Sorry for the
No, I think your job is safe for now, but
I think we can excel that in a more efficient way. We can save a lot more lives, and that's going to save a lot of money too. There's a lot of money involved there. Sure. It takes bring that price point down, and that price point down, and that
to clear the pandemic.
Sure.
And we did it. Put the resources. I hope we don't need pandemic again, for all these things. But
yeah. And I do, to your point, Dr. Cancers and all these diseases that we're talking about, metabolic disorder, things that we put on all of it. I think that's one thing the FDA could do to improve healthcare overall, right, in this country. But until then, professional, there's definitely a way that we can help the nation to go through it. Because typically a lot of the people that I meet that develop new products are like, you're not going to believe the experience I just had. We can do better. I'm going to spend the rest of my life dedicated to making sure the next patient doesn't have to go through what I just went through. And one of the places where I see that really seriously of women in healthcare and the ability to find solutions, because I believe they have a similarly disequal experience in our healthcare system. So I spend my time as an investor. I spend my time working on vetting women's healthcare companies. I invest in women's healthcare companies because I believe in that equality. As someone with 4 sisters and a mother and a wife and a daughter, right, I want them to have a better experience in the future for what they have to go through. To my friends in that space as well, because I think that we can do better. So, yeah. Before we go any further, I just want to ask if there's any questions from the audience, if there's any comments or concerns, derogatory remarks, anything you'd like to throw at us. Go ahead.
Yes, this question is for Dr. Ibebu. Great presentation. I love everything about what those procedures are like, what type of procedures that you do, so that we could figure out how to recommend this to some people that really need it.
Sure. Did you plant her in the audience to ask these questions, Dr.
Exactly.
Beck? Okay, I'm sorry.
How could you tell, Jeff?
Excuse me. They came in together. No.
That's a great question. No. So endoscopic sleeve gastroplasty, gastric sleeve surgery, many of you have probably know about or know people who've had it, is performed laparoscopically. Endoscopic sleeve is performed endoscopically. So there is no outside incision, and because of that, we are able to keep the risk a lot less. So the risk for endoscopic sleeve is about 0.3%. When you compare that to surgery, surgery is in the 30% mark. That's a 100-fold reduction in risk. And to have a 100-fold reduction in risk and something that brings benefit and results is a no-brainer. So that's one of our main procedures. And of course, we also have a procedure we call the balloon procedures. Many of you may be familiar with balloon procedures, like the Obera balloon, for example, where we implant a saline-filled balloon in the stomach, and the balloon occupies space, leads to greater satiety. But we pair all these wonderful procedures with working with our dietitian group, with working with our behavioral therapy group, because this habit of overeating is many times driven by the stresses of life, right? So we saw what happened with COVID. We just talked about COVID. What's the one thing that COVID did to everybody? Everybody put on weight. I don't care who you are, right? We all did. And so with things like that, stress, which is part of life, somebody says if you don't have any stress, then you're not growing. So stress is a sign of growth. So, but with stress, some people will resort to overeating. And so behavioral therapy is big in what we do. And then, of course, we have a solution for people who've had gastric bypass or gastric sleeve and regained weight. And we have endoscopic solutions, which was never available until about 3 years ago. It's very exciting. We call it bariatric revision. So those are some of the things that we do in our practice that are just really life-altering for the better.
Sign me up. I'm ready. Another question. Thank you for the question.
Yeah, more of a comment than a question. Sure. I want to amplify your comments about the importance of women's health and what we are facing right now. The recent report from the Kaiser Family Foundation really shows that one of the negative outcomes that seems to have arisen from COVID and a lack of attention is a worsening of our women's outcomes. And I'm based in Texas, and we're 49th out of 51 jurisdictions in our approach to women's health. That is strongly driven by the politics of the state, an attitude which is hostile to women and women's health. And frankly, the only way that we're going to get change is different leadership. So that's...
Yeah, thank you.
Well said.
That's an important comment. And when we talk about healthcare as a right and not a privilege for those that can afford it, we're also talking about where do you live, right? What healthcare do you have access to? What are the policies that are being enacted? What are the predatory politics that are involved? And I certainly appreciate your comment. So this would be a federally protected right for women in healthcare in their choices, but also in the way that they're able to make decisions in their healthcare. Thank you for that comment. Any response from the panel?
Yeah, so 9 out of 10 of my patients are women. That's the truth.
Sure.
Now, is it because women are more obese than men? Maybe not, but women tend to care more than men.
Sure.
So yes, the emphasis on women is huge because they are oftentimes the decision makers, and many of the men.
Women are traditionally trained to take care of everyone in the family but themselves. So they to women's healthcare or even educating women to take care of themselves so they can take care of the family. That's very important. Right now, I know so many women who feel guilty taking care of their health just because they feel they'll lose out on the time, with the family or with their friends, and they don't feel good about it. I think that should change.
Yeah.
That should change, and I think.
So put pressure on these politicians, right? Because they get that. But other comments? Go ahead, Greg.
Yeah, this is, I started my career at Johnson & Johnson in women's health care. And at the time, we did a program called Straight Talk. This is back in the early 90s. And we went around to high schools talking to teenagers in inner cities and teenage women about oral contraceptives. And they don't have to be pregnant, and they can go on and get a college degree. And that's a very important message to get out there because if the education is there about women's health in diverse populations here in the States or wherever, we're going to have a healthier society. We're going to have a happier society. As you know, when we talk about purchasers of household goods, women, they spend the money. It's a fact. So we really have to look at the target. I was actually at a conference 2 years ago. We had a portable mammogram for women. That's so important, right? So you have a busy mom, maybe 2 kids, to be able to do that mammogram in a portable fashion, very important. So I think when we look at health technology, we've been talking about health technology, there's a lot to be done in the next 10 years.
Yep. Yeah, absolutely. Any other questions from the audience? Thank you, Greg. Go ahead.
Do you guys, it's for everybody, do you guys agree that type 2 diabetes is pandemic? If not, why not? And if it is, we have a solution.
Could you speak into, I'm sorry.
Okay.
Go ahead.
Do you guys agree that type 2 diabetes is a pandemic?
We think diabetes is a pandemic.
Yes.
Yeah, I do. I do think, it's obviously a growing condition. I think metabolic disorder in general is a growing condition.
And we have a solution, and where can we get the help to get the product in the market?
Love to learn about your solution. Yeah, I'd love to learn about it. But again, I think that diabetes as a pandemic is not just a disease. It's actually that we're being poisoned. so if you're eating a diet that's mainly made of wheat, corn, and sugar, and all of those things have poison in them and glyphosate and other things like that, then you're going to develop metabolic disorder, which is diabetes, right? Period. So until we get to the root cause of this, we can come up with all the devices, all the solutions, all the surgeries, but we're still not going to solve the problem.
We do have found the root cause. IAPD caused type 2 diabetes. Dr. Madhusudan Malo published this paper in BMJ. No one is talking about it.
Okay, Dr. Motherson, you said?
Dr. M.S. Malo.
M.S. Mull. Okay.
He was a postdoc in MIT. He was a Harvard assistant professor for 10 years, and he found it.
Awesome. Well, if you could connect with me afterwards, I'd love to learn more about that.
Of course, I will. Thank you.
Cool. Thank you for the comment. Appreciate it. Any other comments, questions, concerns? We've got 4 minutes left in this panel. Here we go.
I'll offer another comment on the women's health area. I spent 19 years at Parkland Hospital in Dallas, had the privilege there of working with Ken Levino and the editors of Williams' textbook. It's great to be a managed care director when instead of saying no to your OBs, you ask them for advice because they're the editors of the textbook.
Sure.
At any rate, we developed through the Parkland Center for Clinical Innovation, we've published this stuff, presented it at IHI. We developed a predictive model using the health plan's data that predicted preterm birth with 70 to 80% accuracy for women who were primips, first-time pregnancies. We were 50% accurate, and 50% may sound very good, but the rest of the literature is about 25%.
Wow.
So then we deployed it, and the way we deployed it was we had a number of practices that actually used the data, similar practices that didn't use it as a control group. And when we ran the model, we ran it against the control practices and against our predicted values in the practices or interventions. The results were similar. First 2 years, 25% reduction in preterm birth. So predictive modeling and the use of clinical data, and I would say that EHR data is good, but in most things, you also want to get your insurers and incorporate claims data, which is, we drove ours on claims data, so that way discuss it. Dr. David Nelson, who was our collaborator in developing the model, is now the head of maternal fetal medicine at UT Southwestern. So there's some real good expertise and some great outcomes on this. And Dr. Nelson is now doing fabulous work on his own in social determinants of health that he's recently published.
Awesome. Thank you for the comment. Yeah, when we raise the bar for maternal health and infant mortality rates go down, the cost of healthcare goes down, the bar raises for everybody. But thank you. 2 minutes. Any comments from the panel? Any last questions? All right. I think we covered a lot of ground. This is an eclectic group. I want to thank them for joining Dr. Erica Begbu, Abdel Zamzam, Craig Parnell, and Abita Batra. Thank you so much for being part of the panel and the discussion. Thank you. I hope this was helpful.
Thank you again to our panelists from the last session. That was truly informative, a really amazing session. Thank you for your insights. Our next session on the end of Roe versus Wade, health implications, navigating the complex landscape of women's health and legal rights, will explore the ripple effects on healthcare access and the potential consequences for women across the nation. So without any delay, let's call to the stage our moderator, Julie Harrigan, MD, founder and CMO of Physician EHR Solutions, LLC, and our panelists, Kayla Bryson, MS, owner and mental performance coach at KMB Sport, Performance LLC, Angela Dotson, president of Blake Brook Ventures, LLC, and Dr. Rebecca Johnson Osei, the CEO and licensed psychologist at Concierge Psychology. Hey, you know what? I think I'm going to take a minute and come get some coffee, too. You know what? Why don't we all just take it? No, I'm just kidding. I'm just kidding. Stay in your seats. It's fine. It's all good. Last but not least, here she comes, everyone. All right. Here she comes, Miss Health 2.0.
Good afternoon, everybody. I'm Dr. Julie Harrigan. I'm the founder and CMO of Physician EHR Solutions. The reason that I'm coming today to this panel is very early on in my career, I did maternal and child health for about 7 years. So delivered babies, did family planning, did everything from pap smears, colposcopies, and operative OB. So I'm very passionate about this topic. Before we get started, I'd really like to ask all of our audience and everybody on the panel as well, we've discussed this, is please, we're going to try to keep any political or religious bias out of this topic. It's a very sensitive subject to many and probably all of us, and to some degree. Some of us have had different experiences. So I'd like to see if we can keep this to a more scientific approach and keep some of those other controversies out of the subject. So without further ado, I will go ahead and let our panelists introduce themselves, and then we'll get started.
Hello, everyone. My name is Kayla Bryson. I'm an owner, mental performance coach with my own business, K&B Sport Performance. I offer mental wellness services and performance enhancement training to athletes at the youth and collegiate level. I got into this as a high school from an inner city and leading athletes and them advocating for themselves from a mental wellness standpoint is a very new and growing field. The Association for Applied Sports Psychology is our governing body, and they advocate from youth level to professional level, and being able to offer those services, you see more professional teams bring in mental wellness departments into their teams. And as well with my experience with foster youth, bringing that background into this conversation and being able to advocate for those individuals who do not have the resources available to them for reproductive health care.
Hi, everybody. My name is Angela Dotson. I am president of Blakebrook Ventures. I invest in small startup companies in the medical device space, but I'm also the COO of Alta Science Incorporated out of Dublin, Ireland, and we are bringing to market a world-class mechanical occlusion device for permanent contraception for women. And so I was very excited to be on this panel and to discuss this because especially with all the changes as we are seeing with Roe v. Wade and so many other things, the one area that we truly can agree on is that women have been left behind, and they truly deserve innovation in healthcare. They deserve funding to be put towards things that can give them better outcomes in their health. And so it's very exciting for me to be here today to discuss all the things that not only is Alta Science doing to help bring permanent contraception options to women across the globe, but also to advocate on behalf of women everywhere that the time is now for everybody to get on board and get behind supporting women and being able to really devote some innovation and understanding that women make up 51% of the population. We're not going anywhere, and we need everybody to support things that matter to us, especially with our healthcare. So, thank you.
I have my own.
You're very special. See, I have to share.
Hi, everybody. I am Dr. Rebecca Johnson-Osei. I am a clinical psychologist and CEO of Concierge Psychology. So I bring the mental health side, although I imagine there's actually going to be a lot of overlap between all of us. This is something that I think is really important because, of course, I see the effect of pregnancy on pregnant mothers as well as on their spouses, and we shouldn't leave them behind. And of course, being pregnant is basically torture for 9 months if we're being really real with ourselves, ladies, right? For most people, it's hard. It's really hard. And of course, anything that is going to affect rates of pregnancy and a woman's choice whether or not to be is going to be significant. And that is completely aside from your feelings about abortion, but the reality of what it's going to mean for women and for the children who may be carried. And I think that's important in the conversation, even as it applies to, for example, stopping those pregnancies from happening in the first place if we're not addressing them once they have. So I'm excited to be here and have this conversation.
Excellent. Thank you so much. So for myself, my approach to abortion and pro-choice is definitely, very, very medical, because I've seen the good, bad, and the ugly of both pregnancy and non-pregnancy contraception, trying to prevent pregnancies, and the consequences thereof. And women will go to extremes to prevent from pregnancy happening at times. Not only, it's not just about getting pregnant and having an abortion, but a lot of times the things that we do for contraception can be very harmful to our body. Things like operative sterilization, even going down to things as simple as birth control pills, which cause blood clots, IUDs, which can migrate. On a personal note, I was an IUD user. Mine migrated out of my uterus next to my uterine artery, and I had to have a hysterectomy to get rid of it. And there came with all kinds of perioperative risks and complications with that. And I'm a healthy, 44-year-old woman that, runs many marathons, so I'm not the larger majority of our population that's at my same age, which could have a lot of complications associated with that. So I'm going to delve a little bit more into that further on, but I'd like to hear, a bit more from our panelists about, their viewpoints and, why we're so passionate about these topics and why it's so important to bring awareness to our female population and our male population about, about this very controversial topic. So Kayla, I'm going to have you kick it off.
Yes, so my background is majority with youth level, and so individuals under the age of 30. Just looking at, starting with the youth level, like the education that we have for sex health, sex education, the community that I'm a part of, that I coach with, we see them exposed to sexual media just at younger ages, and being able to face the reality that we have younger individuals that are sexually active and maybe not necessarily having birth control be the first option for them, but navigating the education and them being smart about the choices that they're making. And as well, just underserved communities, minority population. We even see this with professional athletes. Mothers recently as Olympic track runners, Sonia Riches-Ross, Tori Bowie, who unfortunately passed away due to having complications while going into labor in her home by herself. Tennis star Serena Williams, she as well nearly died giving birth to her first child and is currently pregnant with her second. So hopefully she does not go through those complications that she endured again, but bringing to the forefront that it's not just wealthy or poor individuals, it's wealthy individuals as well that this is affecting. And understanding that we need to navigate other options besides birth control, advocating for if an abortion is the solution or the solution for somebody and it's what is going to keep them alive, then respecting that decision and understanding that that was needed for their health.
Thank you for that. So whenever I take a look at this, I mean, my views come from so many different perspectives, starting with just as a woman in general, but also a mother of a daughter that is, getting ready to be 3. And as I look into, her future, and, I see this and I think to myself, whenever you're talking about abortion and the whole Roe v. Wade, there's never going to be a consensus. You're never going to have 100% of everybody agreeing on this because it is such a personal topic. And it's not just the topic that's personal. When it comes to women's health, it is so personal. Everything about it is personal. Every woman experiences something different in their life. But the one thing that we all can agree on is that it's something that we all share. We all experience a menstrual cycle. We all experience, the pains that come along with women's reproductive. As a woman, we all share that. But our experiences with it are all different and they're all personal. And so you cannot, no matter where you feel on the matter from a political standpoint or a religious standpoint. You can't discount somebody else's feeling or emotion about these things. And so for me, what I want to be able to bring, and even if it's in the smallest capacity, is just what solutions can we attempt that can try to help everybody? Where can we find a common ground of meeting in the middle with this? Where are the places that we can agree that need to be focused on, that are true problems? And how can we come together and create a better opportunity for women so that their health is protected, that the future of generations, our children, our future children are protected? Because this topic is so much more than just a black and white topic. There's a whole lot of gray in there, a whole lot of gray that affects men, women, children, everybody. And so I think that that's, for me, that's where it begins. And, you know, where my heart is what can, I'm not going to be able to convince people, and I don't want to convince people to share my view. I want to respect everybody's view. But what can I do to help everybody find a common ground so that we can move forward and we can make it better for everybody? So that's kind of my position, and that's why I'm here, and that's what drives my passion. Sorry. Listen, I don't learn quickly.
I can always
Just
share
sorry.
this way too, you know. I really appreciated what you said about solutions, because I do think that's where we are right now, right? I mean, advocacy and such aside, this is post Roe v. Wade turned over. This is the reality we are living in, regardless of how you feel about it. And, you know, for me, being a woman and everything aside, from a therapist standpoint, you know, I find myself sitting here thinking, okay, I'm going to see these women. They're coming to me. I hope they're coming to me. Let's put it that way. Hopefully they're going to somebody. I'm going to see I don't work with kids, but I'm going to see those kids when they grow up. Because, like I said, this is going to have a mental health impact on people. And we can preach that you shouldn't be an adult having sex, I guess, but that's not an actual solution, right? When you pull Viagra from the shelves, maybe we can have a conversation. But until then, you know, if men can have fun without needing to make babies, then let's not preach at the women, okay? So this is going to happen, right? People are going to have sex. And contraception is problematic, and for a lot of reasons, right? I mean, you mentioned hormones. I can't tell you how many women, something about hitting 30. If anybody here is like about to hit 30, I see these women have been on the same pill for 10 years, and all of a sudden at 30, it's just like, they're like, I feel like I'm losing my mind. And what happens? They get taken off the pill they've been relying on this whole time. Condoms are great. Condoms break. Condoms are expensive. Back to how this hits certain groups. You know, do you have insurance? Because these other type things require insurance. So all that is to say, pregnancies happen. So now you have a woman who is pregnant and doesn't want to be. And we're asking her to, you know, not eat ham. And actually, I think you can have sushi now. But, you know, we have this laundry list of things you're not supposed to eat. You can't take Tylenol or Advil now, apparently. Now there's an association with autism. So you hurt too bad, you just get to be in pain. You're exhausted for 9 months. Well, that's too bad. You can only have 1 cup of coffee a day. They're not having this cup right here, right? There's a lot that goes into this. And in somebody who wants that baby, it's still hard to follow all of those requirements. So now imagine the mom who doesn't want this baby. And is she following them? Like, what is happening to this fetus during gestational period? And are they getting prenatal care? Are they even telling anybody? I'm sure you guys saw the article about the twins that were found in a trash can recently in maybe Oklahoma, which is super tragic, but those things are gonna happen. Some people are gonna carry to term and just say, I didn't want this kid. And it's horrible, but it goes back to solutions. So how do we help women and men? You know, there actually is a shot for guys, and I think a pill that makes it so you can't get women pregnant, but they can't get traction because nobody wants to take it. So that's a whole other conversation. But how do we get there so that people are supported in not getting pregnant in the first place? But if they are, I think we need to find a way to, in our current day, support those women, try and make it, I guess you could say, as easy as possible to be pregnant for that time period, be there for the babies after the fact. Because even if this baby is born and is adopted by like the best family in the whole world, if they haven't gotten prenatal care, if anybody here has ever visited like a third world country or just a poor area in general where there isn't prenatal care, it's very obvious. You have much higher rates of a lot of deficits, cognitive and physical, if those kids are not given up for adoption and they are raised by parents who don't want them. I don't think anybody in here needs me to really spell out for you the emotional trauma that's coming from that. And so I just think it's very important that we be very aware, because this is just the beginning of that, and we're going to see a lot of adults 20 years from now who are a result of this, and there are going to be repercussions that I think we need to be preparing for, while also hopefully thinking of ways to help minimize the number of people that are coming into the world essentially unwanted from the first day.
Yeah, so, so let's rewind. So we talk about pregnancy, as if it's an easy, as if it's an easy thing.
It's the flu for 9 months.
Yeah, it's the flu for 9 months, you get fat, and then you try to get skinny again. And no, I mean, the number of complications that are associated with any given pregnancy at any given time are fantastic. And when we're talking about a 23-year-old girl who, got pregnant, because they didn't use a condom, the condom broke, she forgot her pill, whatever, the scenario is, we think of, oh, healthy 23-year-old's going to have a baby. This is going to be great. We're bringing life into the world. Fantastic. What about the 45-year-old woman who is having menstrual irregularities because her ovaries are kind of sort of shot? She's already got 3 kids. They're either in college, out of diapers, in various stages of life. She's got diabetes. She's got hypertension. She has skin disorders. She has asthma. She's got post-COVID syndrome. All of these different things. Cardiac disease is not unheard of at all. Substance abuse. So, I mean, if you think of when we talk about crack babies, we're talking about babies who are born in active withdrawal from heroin. And when you talk about these pregnancies, it's great to idealistically, and I think, that's in the minds of the people who are making these decisions, idealistically, pregnancy is a beautiful thing that results in a beautiful being that's coming into this earth, and, and it's wanted and it's loved and and it has every chance to thrive. And, the sad reality of that is that in many cases, in most cases, in these cases of women who are seeking, to terminate their pregnancy, it's because of a very good reason, and so I think we have to question ourselves, who are appropriate to be pregnant in the first place, an oops pregnancy that you go, okay, well, it's no big deal, I'd love to have another baby, great. But an oops pregnancy when your last pregnancy was wrought with preeclampsia, seizures, blood clots, postpartum cardiomyopathy, liver failure, kidney failure, diabetes, gestational diabetes that resulted in permanent diabetes, other high blood pressure disorders, blood clots to the brain, complicated C-sections, crash C-sections, severe bleeding that causes your pituitary to completely implode, making sure that you're going to be on prednisone for the rest of your life and severely immunocompromised. I mean, these are the things that happen with everyday run-of-the-mill pregnancies. And then consider, well, I shouldn't be pregnant because I had these things in the past. And what that fear, and just imagine what that fear has got to instill in you as, as a patient, knowing that, oh my God, if I get pregnant again, I could die. Nobody cares. I don't have a choice. So I think that, from a medical standpoint, again, advocating for, not only women, because I'm obviously one, but, or maybe not so obviously, but I hope so. But, being that person, knowing about these complications and these bad medical things that can happen, that can ruin people's lives, and then not having a platform to advocate for them is, it's a difficult topic.
Yes, I'm glad that we brought up earlier with pregnancies that are unwanted, but women go through with giving birth, bringing up the foster care system and adoption. With the foster care system, it is unfortunate with the children that I work with that they come from homes that either drug use was present, abuse was present, or parents were just not fit to take care of them for whatever reason, that we all know that the foster care system is very broken. Many of these children do age out of the system, and then from there they still rely on services for them to transition into adulthood, sustain themselves financially. Education system as well, they do not have examples put forth in front of them to show them what is possible for themselves. And so many of them do rely on other circumstances to be able to live off of, whether that is drug use, gang affiliations. And many of these youth do not have the resources present. However, the agency I work with, we are there in-home stand-in parents for them. We are there to hopefully help them sustain a living. But if they're put in a situation to where other individuals in their life have a stronger influence over them, it's a broken system that does not cater to their needs and finding families for them. It is fortunate enough that some do reunify with their birth families, but that is not the case for a majority of the population. So being able to reevaluate what we're bringing from others and that support to say, if they realize that they may not be ready to become a parent, being able to combat situations where they can sustain healthy bodies, healthy mindset mentally, emotionally, and hopefully that's a discussion like this can be able to change the narrative around abortions and birth control.
Can I piggyback on that, actually? Just because I think you brought us to a good point. I used to do parenting capacity evaluations, so when somebody's children were taken away, they'd be sent to me to essentially evaluate them and say, essentially whether or not they seemed like they could be a safe parent and what they would need to support them in order to be able to provide a safe space for their children. I also worked in juvenile hall, not at the same time, but they kind of interestingly intersect. And I just think you bring up such a good point, and it kind of loops into what we were saying before, which is that support piece. If we're going to say all of these children must be brought to term, period, end of story, there has to be funding to support that then. Because whether or not these mothers should be supporting their children and being a good influence, et cetera, so forth and so on, doesn't mean they will or can, right? There's a can here. If you already have multiple kids and 3 jobs, I mean, how much supervision is this last kid really going to get, and is it realistic to expect that? And again, we can high horse on whether or not this person should have gotten pregnant, but now they have, and now there's a baby. So as a society, we need to figure out, and this, I know this becomes political again to a degree, but this goes into, you can't say all babies come to term, but we also are going to pull funding for support, for social services, for things like that. It's kind of a one or the other, or else, yes, the kids end up on the street. And guess what? I mean, really, what happens with any of us when we're like a teenager and left to our own devices? I mean, who in here was like, I was up to all the good, right? We're not. And yeah, and they seek out support, they seek out peers. Juvenile hall is statistically shown to actually make kids worse, not better. But we keep putting them in there, and then they get to meet other kids who are great examples. And I just think that was such an important point, because if we're going to have these babies born 6 months from now, 9 months from now, those kids are going to need those social supports from somewhere.
No, you're fine. And I completely agree on that. We kind of touched base on this yesterday and into last night. But it's when you're looking at the support system, and that's really what we have to do right now, is come up with solutions. And when you look at the solutions for these kids that are being born from parents or women that don't want any more kids, then you look at, okay, where are they going to go? And if the foster system is failing them, and then you look at the other option, which has bothered me greatly for a very long time, which is the adoption side of it, because it is so costly and almost impossible for somebody to adopt. And it's like, what options are you giving people? Like where are the solutions? Where are the solutions? You can't just make this a rash decision subject because it is in the moment, making you feel like you're getting brownie points with, certain people versus others, if you're not willing to take a step back and say, okay, well, you know what? We need to look at how we deal with adoption in this country, and we need to be able to make it so that the families that want children, maybe they can't have children, but they want children, they can be able to take those kids in and they can provide them the life and the support that they need. But we're not doing that. So that's an area that we have to focus on. The other area, and you talked on it yesterday, is, the education. We need to be educating. We need to be educating, the kids at a younger age about sex because, to your point too, it's happening. And as parents, listen, do you think that I want to really ever have to have the sex conversation with my daughter? I really want to believe.
It's gonna happen.
I want to believe. I want to believe that she is going to be the perfect little angel, and probably until she's going to be a virgin until the day that she gets married. I hope that happens. Probably not going to happen. So
I feel like we should ask the men what age they think girls get their period.
I mean, seriously.
Like 10, guys. 10.
That was
So,
my
so I mean, I
sex
think
ed
as
a question. It
parents,
was like a mess.
as parents, there comes the responsibility for us to have common sense and to take ownership of being a parent to our children, and knowing that our kids are going to mess up. They're going to do things that we probably don't want them to do, and we need to play devil's advocate and have a plan B for when they fail at plan A.
Like literally? A plan B? Literally? Like
Literally, I mean,
It's crazy idea.
I know. So there's so many conversations that surround this that really needs deep thinking. And to your point, Julie, when you talk about the older women, like you, I'm getting ready to be, I don't know if it's 43 or 44. I always forget.
I thought about lying about my age.
It's one
Did you just make us older?
It's one of the ages. Well, Julie's 44, so I'm right there with her. So, but I'm one of these women that I struggle with hormones. I had to do IVF for both my children. It was extremely difficult. It took a toll on my body. I do not do well with hormones. That is common amongst so many women. There's a lot of women that can't even take hormones, period.
And IVF is less expensive than adoption in the United States.
I mean, it's nuts. And so, when you take a look at that and you look at what are the options available for women like me, women that are in the prime of their life, they're career women, maybe they just don't want any more kids. Heck, maybe they just don't want kids at all, and that's okay too. What are the options for them? And it's sad to see that it's so limited. The only option for permanent contraception for women right now, truly, is tubal ligation, and that is
Hysterectomy.
Yeah, or take it completely out. I mean, that comes with anesthesia, OR. It's very expensive. You're out for days with work. We know that women are working more than ever before. They can't afford to be able to do that. That in itself really impacts, from a socioeconomic standpoint, all different people across the globe. And so, one of the things for a solution is innovation. And, I'm very proud of that because as COO of Alta Science, we are working on a contraception device for permanent contraception for women that's non-hormonal, doesn't require anesthesia. It's a minimally invasive in-office procedure to be covered by insurance, something that women can just go into their doctor's office and be able to, 30 minutes later come out and they have a permanent contraception option for them. And these are the types of things, when we talk about solutions, we need people to get behind. So what I say is to all you investors that's in here, come see me. Let's talk about how we get these things moving along for the women of the world. Because we need people to step up. We need innovators to step up. We need investors to step up. We need everybody to start stepping up and talking about all the different things that affects this important topic about bringing children into this world and the effects that it has on women's health in this world, because it affects us all in so many different ways, and there's so many different layers. And I just get very frustrated that it's being made to just be a black and white topic when it's anything but. Sorry.
Well, talking about resources, resources for healthcare in this country are, so disparate. You've got your good resources in your main cities, in your rural towns, in your border towns, in your, middle of Arkansas towns. You're going to have extremely, deficient resources for medical care. I mean, they can't get doctors out there. They're doing telemedicine visits with absolutely no doctor present just because nobody will physically be at these clinics, at these hospitals. And so what happens to prenatal care? So, in the state of Texas, and I just read this a couple days ago, I don't know if you guys saw this on the news, and I try not to watch the news too much because it's really depressing most of the time. And this was another, depressing statistic, but there were 10,000 extra deliveries in Texas alone since the abolishment of Roe versus Wade. So since the state changed their legislation, 10,000. So can you imagine all of the rural towns in the middle of Texas that are emergency access hospitals that are only run by CMS? They don't have any other regulatory bodies running the show. They have to only do telemedicine visits, and they don't actually have somebody to physically examine these patients, and what kind of care they're receiving for this pregnancy that they didn't want, or was maybe very inappropriate in the first place. We haven't even gone into the subject of rape and incest and all of these other things that clearly there's the I don't give a damn, policies about, and again, I'm not going to politicize this, but it's very interesting to see, the mental, physical health of what's going on behind the scenes. So, because this topic is so far beyond just pregnancy. Now, on the flip side, I also want to, kind of talk about the resources for women in those certain states that have abolished, these policies. And so again, try not to read the news, but I was bored, and I was actually boarding my flight here, reading this article about this 45-year-old career female. She was in Louisiana, and she did this very, she went kind of undercover to give this, testimony in this article that I read. But 45-year-old female in the state of Louisiana who accidentally got pregnant on contraception. So she was actively trying to prevent a pregnancy, and like everything else, fails. It's only 99.7% effective. Well, that 0.3 bloody ineffectiveness is pretty big when all of a sudden you're 5 weeks late, right? And so she had to. And the 4 surrounding states around her also have similar policies. So there was really nowhere for her to turn that she could just drive to and have her abortion. And so she ended up flying to Oregon, being there for several days for the counseling, for all of the things that that they do very appropriately in Planned Parenthood. I worked for Planned Parenthood very briefly, just because I really wanted to educate myself about what happens. I mean, you just go to the clinic and get an abortion. They're like, oh, here's your pill. Yeah, no, go bleed and be gone with you. No, it's a huge process, and they do a ton of counseling. They do a ton of measures to make sure that you're sure about your decision. And again, not always for the right reasons, not always for the wrong reasons, but for whatever reason. And so this gal flew over, took several days, and she had to take her final pill right before because she had to be back to work the next day, because she'd already taken multiple days off of work and she didn't have any PTO. She had to take her final pill as she was boarding the airplane for a 4.5-hour flight back to Louisiana, and bleeding heavily, cramping, bleeding, hurting, emotionally distraught, all the way back to her state, because had she taken that pill at any other point, it would have been illegal, and she would have been persecuted for it. And so, just to go and, understand, and she's one of the lucky ones who had the means to get on a plane and go do that and fly back, and, and had some reasonably good, health care along the way. But again, from a medical standpoint, what's going to happen when we go back to, the 1950s? And I'm sorry, and I know that this sounds very crude. Coat hanger abortions are not something in the past. Those are happening now. And they're happening at an alarming degree now that we don't have these policies in place to protect women and help them, again, maybe not do the right thing, maybe not do the wrong thing, just do their thing, but in a safe manner, and then have that health care, have that mental health support.
I think it'll be really interesting. That's like the least opinionated way I can put that, to see what maternal and fetal death rates are in a few years. Percentage-wise, right? Because of course they'll go up because the number of pregnancies go up, but you can always look at things proportional. And in theory, if it's just more healthy pregnancies, that wouldn't go up. But I do suspect for a lot of the reasons you listed, so some of them being pre-existing conditions, some of them being women maybe doing unsafe things to try to end the pregnancy, and some of them being what I spoke about, which is women just not getting care, even when it was available. So not even the places where you can't get it, but when it is available, but the women just either themselves, we like to think that everybody loves their baby, right? But there are some people who should not be parents, like period, that's it. And now imagine that person is pregnant. They are not going to do all the things you're supposed to do. And I think all those things combined, I think we're probably going to see some scary numbers, truth be told.
I agree. And, and mental health, is hereditary, right? Substance abuse as well. And, where do we draw the line at these mental health, physical, emotional, implications? Where are we going, and do we have the resources to do anything about it? That's the tough thing. I'm sorry.
Yeah, and one of the things that since I have been here at this conference and been getting ready to prepare to speak on this panel, it's been really refreshing to be able to know that it's possible to be able to have these type conversations, even if you are, coming from a different approach. For example, I'm pro-life. I'm pro-life. It's a personal decision. It's a personal decision, and I think that's something that everybody has to remember. It's a personal decision. Our goal is to be able to have these type of conversations and be common sense to understand that what is happening, this places such an impact on the mental health, on the youth, on the middle-aged woman. There's so many different facets of it, and so it's been very refreshing to me to be able to have these type of conversations with, people here, and I thank you all for that, to be able to sit down and really talk about, what needs to happen. These are the challenges that we're all facing as women, and throw you guys in here as well, because you're included in this. But it doesn't matter where you are, where you fit on the spectrum of pro-life, pro-choice, whatever. At the end of the day, we're all human beings, and so we need to make sure that we are supporting each other and we are finding the best solutions to everything. And one of the challenges, and when we talk about all the things that we need to think about how this impacts us, one of the things that we don't talk about often is childcare in this country and the lack thereof. Let me tell you something. I live in a very rural part of Southwest Virginia. The opioid use has ran rampant in my area. Now, I'm from there. I've grown up there. I love there. It's all the reasons why, I moved back there to raise a family. But it's changed. Society is changing. And the drug use has really become a problem, as such as it has in so many parts. And it's very hard to find childcare. And even, for me, I have one child. My first daughter, unfortunately, passed away unexpectedly shortly after birth. So I had two daughters, but I have one living daughter. But even with one daughter, For me, the challenge is that it has been many, many days whenever I haven't been able to find daycare for her because the wait list is so long, and I have literally had to take almost all of vacation time just to be home with her, to try to find somebody that could come in because my family lives over 2 hours away. They all work. It's not easy, and you can't just trust your kids with anybody because so many people are, you don't know if they're on drugs, you don't know if they're going to be taking care of your kids. It's an issue. It's an issue. There's so many parts to this of having to plan, and if these conversations and these decisions for women are going to be made, there's so many things that need to be addressed and needs to be talked about, and solutions being able to be provided of how it affects the household, how it affects their, how it affects them financially, their careers, and everything in between. So, just food for thought.
So I'm going to take women out of the occasion for just a minute, and I'm sorry, and I'll be super brief, Kayla. But on the note that you were saying about your baby girl that passed away, you know, let's take women out of this equation, and let's talk about the babies. Let's talk about heart conditions. I mean, we saw a little sweet baby boy yesterday. I'm one of the keynote speakers, and they were talking about this sweet little baby boy with a heart condition that had 3 open heart surgeries. Let's talk about, you know, actual chromosomal anomalies. You know, babies born with no brains that pass away right after surgery, you know, right after they're delivered. Let's talk about trisomy 18. Let's talk about Down syndrome. You know, those are very, and when people are like, well, you know, I'm not worried about, and this is a common thing that they say is, I'm not worried about having a baby with Down syndrome. I can take care of, I'll take care of them for the rest of their lives. But there's so many other genetic disorders. There's so many other birth anomalies. There's so many other things that these babies have to suffer that maybe wouldn't have to have gone through that. And whether their life is long and fulfilled or whether it's very short and, you know, and snuffs out within hours after birth, you know, let's talk about the babies too. I mean, our NICUs are full, our pediatric ICUs are full, you know, and they're full of kids with cystic fibrosis. I sat for 10 years, almost 10 years, on the panel of Make-A-Wish Foundation. So, you know, let's take this conversation away from the moms and away from the politics, and also think about those babies that, you know, maybe just needed a chance to be in heaven, you know, or wherever you'd prefer that they be. So, just sorry, from a medical standpoint, I think that that's something to really highlight.
No, thank you, Julie, for bringing that up. Among the experiences besides sports and foster youth, I as well have experience with being a behavioral aid for special needs students, and the toll that some of those experiences take on families is tremendous. Not only if this is their only child, but if they have additional children, the lifelong health issues that some of these children experience is very heartbreaking. I've dealt with Down syndrome, autism, cerebral palsy, not only factoring in the health side of it, but then the resources in schools that are going to be needed for them, with speech, OT, physical therapy, just some of these extra services that are needed for a child to thrive amongst the general population, as well as integrating them into the general population of their schools, whether that is the public or private level. And just understanding that genetics play into that when a mother is having a baby, and understanding that, is a parent willing to take on that challenge of understanding that, okay, when the parents are no longer around, if this child outlives them, who else is going to be there to take care of this person?
So we have 4 minutes left. I'm going to leave room for questions. And I just have one funny closing remark because we talked about it yesterday. You know, abstinence only doesn't work. Just saying. I'm going to leave it at that. What? I said abstinence only doesn't work. I'm just going to leave it at that.
Doesn't work. I actually, if I could take a second, I want to do a little thought exercise with all of you. That's why you guys to help me with this. Okay, can we, let's make sure everybody's awake, can we all at least agree that a child who is born but not wanted. So mom doesn't come around halfway through and is super excited. A child is born to a family that is not wanted is most likely not going to be loved and supervised the way we would ideally like. Can we agree on that as a room? Okay. So, unloved child. Anybody who works with children, what do unloved children do when they go out into the world? What do they seek out? It begins with an L. They seek out love, right? So, Susie, 10-year-old Susie, doesn't feel love from mommy, so she goes out seeking love, and she finds love in Johnny. And when Johnny says, I love you, Susie.
And her first menstrual period was at the age of 9.
Yeah, because this happens like a lot. I feel like many people don't know this. What does Susie say no? What do you guys think? Susie, who is seeking out love, is unloved at home, is not supervised, probably not being told by mommy what to be careful about, and here's Johnny. And Johnny loves her, but Johnny might not love her anymore if she doesn't have sex with him. What is she gonna do? She's gonna have sex with him, obviously. Come on, guys. So I just want to bring home this full circle. So, 10 years from today, there's gonna be Susies. And there's gonna be Johnnies too, who also are looking for love. I'm just, and just going back to resources, support, all of that, what are we going to do as a society to make sure that Susie doesn't fall in with Johnny, or that Susie has whatever resources Susie needs to make sure that Susie doesn't make Susie 2.0 10 years later.
And maybe Susie and Johnny have early HPV and have given it to each other and don't get really checked out, and she ends up with cervical cancer and he ends up with penile cancer. Lots of problems
Well,
there.
that might end the cycle, I guess, though. So
that's a long away cycle, but it does happen. So y'all, we've got 2 minutes left. I would like to leave room for questions. If there are no questions, then we can powwow a little bit more.
Only easy ones.
Yes, ma'am.
Thank you for the discussion that was able to take in all sides. And leaving out political and religious aspect, I am a nurse, and I want to ask the question in regards to let me just stop. Solution, I'm gonna start there. I agree with the solutions and think it's very much needed for areas of contraception to be addressed. I think that is something that needs to be more readily available and not with the side effects and harmfulness that women have to have by having all those options. I think that is something that needs to have more research, more tools available as a solution. As another solution, now that we're here, I agree, we need to have more mental health services available to service women that are going to go through the emotional challenges associated with having to have a pregnancy. At the same time, there has been, we've gone through seasons of, there has been grief, shame, guilt, and trauma tied to people having abortions that we did not service well.
Yes, ma'am. Mm-hmm.
And I just want to pause on that. We went through decades of not servicing those women at all. It was not even considered. And now the effects, decades later, of that trauma, that shame, that guilt, they've lived with, and we still didn't address with it. My question has to deal with what happens in the mind when we disconnect. If life is life, I'm just asking, if life is life, what happens in the mind if you have to disconnect from it to make a choice? And I'm asking that because I forgot your name.
Angie.
Angie made a statement. She said she had 2 daughters, and she grieved one daughter that didn't live long after birth. We now have in my state where there's perinatal, which covers after birth.
Mm-hmm.
Okay. that abortions can take place. What is the mental effect, if life is life, what is the mental effect of the trauma women have had to endure on both sides of the spectrum? Because trauma is trauma, and we've not put anything in place as trauma as a component of women's health and wellness, of treating trauma.
So I'd be interested to kind of dissect that a little bit. So the VA has, multiple systems in place to deal with soldiers with PTSD. And I can't quote the article, and I don't remember when it came out. Anecdotally, I remember reading, because I do read all the time, I just don't watch the news because it's depressing. But anecdotally, I saw an article years ago, and this was when I was in my maternal child health days, that said that the emotional equivalent of the trauma of a woman having an abortion was very similar there too, in the small amount of studies that they've done, to some soldiers that have come back, to policemen, firemen, and some soldiers that have come back from war, because ultimately they're doing away with a life. And so it's not just that you're getting rid of, something inside you, you're doing away with a life. And the trauma associated with understanding the implications of what you did and potentially how it was done, right? Because it's not pretty sometimes. Is very traumatizing, and it can leave very lasting effects, very similar there to those other professionals that are in very traumatic situations and jobs.
Yep. And thank you for that. But I can speak from my own personal experience here. My mindset has shifted so many times over the years in regards to, is abortion okay? Is it not okay? And like I said, I mean, I am pro-life. I'm pro-life, and I became pro-life after I had to do IVF for my girls, because I wanted to be pregnant so badly, and I had unexplained infertility and could not have kids, and it was something to be able to be a part of that and seeing it, from the time it was an 8-cell embryo through, and really understanding the whole scientific process, right? But at the same time, it also did not, it didn't make me lose the common sense piece about it, and especially after I lost my first daughter, because let me tell you something, the hardest decision for a parent is the decision to end life for your child. And the reality is, until your child is 18 years of age, if something were to happen to that child and they were to have to go on a ventilator and lo and behold, they become brain dead, you're going to have to make that decision. Do you pull life support from your child? You're going to have to discuss with your physician all of the options, all of the scenarios in which, if you leave them on life support, how long could they potentially, live, what kind of complications that they could have. And for my husband at the time and we had to make that decision 29 hours after our daughter was born unexpectedly. She was born with several complications from a labor complication, a delayed labor. And should she have lived, she was going to have severe cerebral palsy. And her organs started failing. She ended up having a seizure on the brain. And we had to make the decision, do you want to put her on life support? This is a child that we prayed for, we wanted more than anything in this world. And we still had to make that decision. And so I think about that often for women who become pregnant, and maybe they don't want the pregnancy, or maybe they do want the pregnancy, but they find out during their pregnancy that there is something so severely wrong with their child that they're not going to make it. Should they not be given the same option and discussion and respect that my husband and I had
once our Audrey was born? These are the questions that make me have what I call common sense, because they're real. These are real realities. Everybody's journey is different. And it's not easy. It is traumatic. And I can tell you that making the decision to end a child's life at any point, it is traumatic. It will haunt you. It will be with you for the rest of your life. And if you don't have it immediately, regret happens at some stage in life. And you better be prepared to have those conversations about it. So I appreciate and respect your question around that, because it's absolutely relevant, and it's absolutely why, you know, I'm so strong with this, of this not being a black and white topic, and it's not as easy as saying that all abortions should not happen or all abortions should happen. There's a lot to think about, and my experience alone is just one of those.
So everybody, thank you very much. Wonderful statements, questions. I appreciate our beautiful panelists.
Thank you.
And thank you for your time, everyone.
Wow, what a wonderful and insightful conversation. Thank you to our panelists for shedding light on this pivotal subject. We're going to move on forward. I'm going to introduce our next panel, and the subject of this panel will be at a juncture when self-care seems to bear the weight of our well-being, it's important to explore the untapped potential of community care. Moving towards our inspiring panel discussion on the topic, Beyond Self-Care, How Community Care Fuels Our Growth and Resilience, where the experts will illuminate the powerful role community care plays in promoting growth and resilience. We're ready to unpack the potential it holds in fortifying our collective well-being beyond individual endeavors. To take the discussion forward, please put your hands together for our moderator, Dr. Nusha Nuhi, PhD, clinical psychologist at Marina Health of California, and panelists, Christine M. Colburn, owner and licensed professional counselor of Beacon of Hope Counseling Services, LLC, Professor Dr. Charles Senesi, associate professor and medical doctor at Afro-European Medical and Research Network, Jessica Brazil, founder and CEO of Mindful Living Group, and Dr. Rebecca Johnson-Osei, CEO and licensed psychologist at Concierge Psychology. Thank you, and if I mispronounced your name, please share the correct pronunciation with the audience.
All our mics are on. Hello, everyone. Welcome to our panel, and thanks for joining us at the end of the day of day 2. It is wonderful to have everyone here. I'm honored with my esteemed colleagues here. We've had a wonderful time discussing this topic and really look forward to having this discussion with you all. I'm going to start out with brief introductions. My name is Nusha Nuhi. I'm a licensed psychologist from San Diego, California. I work primarily in health psychology and provide individual therapy services in outpatient setting and private practice. Then we'll have Charles go first.
Thank you very much. I'm very happy to be here. Thanks, Madam Moderator. I'm Associate Professor Dr. Charles Senesi. I'm a medical doctor and a researcher. I'm originally from Sierra Leone, but for the past 19 years, I'm based in Switzerland. And I'm very much passionate about developing the resilience of communities. And as a physician, I did some few studies to back up my ability to effectively deliver. So I have in addition to being a medical doctor, I have a master's degree in dermatology, and I did a PhD in international health research, in health sciences, focusing on international health research and education, and the PhD candidate in public health epidemiology. And I'm also the founder and president of the Afro-European Medical and Research Network, and I've been 30 years in healthcare delivery to low and middle income countries, especially hard to reach communities. And I'm very happy to be here on behalf of AMREN and the diaspora organizations in almost every continent around the globe. And we are very much focused on accessing health to communities that are very hard to access the health, both in high-income countries as well as low and middle-income countries, especially sub-Saharan Africa. So I'm happy to be here, and you hear more about our work. Thank you.
Thank you. And I have to follow that up, huh? Thanks. I'm Christine Colburn. I am a clinical, I'm clinical, right? A licensed professional counselor, a national certified counselor, and a certified clinical trauma professional. Oh, a lot of titles. I have a private practice in Mesa, Arizona. We focus mostly on the underserved, grossly underserved population of children ages 3 to 17, although we do work with all age groups for general mental health. With the children, it's trauma. We work with LGBT groups, trying to provide safe places for people to just be able to talk and come out. And if they don't have support, they can build their own community and support system for them. And then with the children, they're the seeds of our future. And if we can get them help now and give them the tools that I know back in my day I did not get, they're going to be way ahead of us and have a much brighter future having the coping skills they need just to get through day-to-day living. I mean, I believe we all have those within us already. We just all haven't been taught to use them.
Aloha, my name is Jessica Brazil. My aloha reveals to you that my career has primarily taken place in the state of Hawaii. I have been in the field of social work for over 20 years, working on a state level, a nonprofit level, an educational level, and in the last 15 years has been primarily in mental health. I began a multi-specialty private practice group made up of a variety of professionals, primarily in mental health, and we provide an integrative, holistic, and spiritual-based practice for serving statewide through 3 clinics and a statewide telehealth platform. So this topic is near and dear to my heart because our group actually formed through community building and through self-care support groups. So I'm honored to be here, and thank you so much.
We have so much in common on this panel. Okay, I won't totally repeat what I said earlier. I'm Dr. Rebecca Johnson Osei. I am a board-certified clinical psychologist, and I own Concierge Psychology, which I can say a little bit more about. So it is a private practice also. We mostly serve high-functioning adults. It is what we call sort of a luxury mental health practice. It's all private pay, which is a little bit different for being on a community panel, I realize. And we serve, I think we're up to 42 states at this point, but we have offices in LA and Atlanta. But just professionally myself, I've done a lot of work within community mental health historically, and I also think regardless of where we work, there's just so much overlap, right? The community is impacted by the individual and vice versa. And I think the healthier our communities are, the healthier our individuals are. So I think it's really important that we give appropriate attention to this topic.
Excellent. That's a perfect segue to our first question for our panel.
You're welcome.
Thank you. So, what does community care mean to you personally, and how does that align with your line of work? Charles, would you like to start from an international perspective?
Okay, thank you very much. Yeah, of course, I can give it a try. Community is very much dear to our hearts. By definition, could be a group of people sharing common characteristics, living together. And so having the community access the health they need is very crucial in the healthcare delivery, especially the communities, the end users that are way down the healthcare delivery chain. And that's what we at the Afro-European Medical and Research Network do. We leave our comfort zones. We go to the last communities in the healthcare delivery system in low and middle income countries. So at least we can stimulate that health-seeking behavior among them. We can optimize their health awareness so that they can become more resilient in their healthcare seeking behavior. And then we live with them, we actually try to help them as much as possible while we address their common ailments. And we don't only stop at that community level, we also go a bit further up in the community healthcare delivery system, maybe at the tertiary hospital or at the government level in the country specific. And we try to make sure that there are policies that align with efforts in actually making sure that people in the last end of this healthcare delivery chain receive the healthcare that they need. Professionally, as a physician, I'm a big fan of personalized medicine. I did my PhD dissertation on the tiny mutations in the enzymes that metabolize the medications in HIV/AIDS patients. So that's also how I went to the nitty-gritty. But I highly respect the need to work as a team. Indeed, as the African proverb goes, that if you want to go fast, you go alone. But if you want to go far, you go as a team, which is why the motto of our network is together we can make it happen. So whilst looking at healthcare delivery at that community level, we try to empower the government community of policymakers in the country specific where we work. And we don't only stop there, we work at the regional level, even with the WHO AFO, to make sure that the policies of the WHO, which is the custodian of the health of the world, flows right down to the country level. And then we come back to Geneva, to the WHO headquarters, where I at times work as a consultant for the WHO to make sure that the policies of the WHO actually fit into the needs of the healthcare delivery countries down to the last community level. And I go up to the level of the United Nations. The WHO is a sub-agency of the United Nations. We are United Nations accredited to make sure that the policies are well understood by the last man in the healthcare delivery system. So therefore, the community medicine, the community healthcare delivery does not only stop at what all of us are doing, but we should be able to use the bottom-up approach so that we appreciate, because at the United Nations, they depend a whole lot on what is fed from the local community in the how we call it, the bottom-up approach. So I'm very much a fan of that. And then in as much as I go down to the last healthcare delivery system, I also try to influence things from the global level. And so it's nice that for us to know that we are never small to make a change. Whatever little work you are doing has a ripple effect in supporting the WHO and the United Nations Sustainable Development Goals. Thank you.
Always hard to follow. Now I lost my train of thought.
I'm so glad you're next to him.
Yeah, thanks. You want to switch?
Here, I'll reemphasize the proverb that Charles shared. We were talking about this last night, and it's just so wonderfully and perfectly put with our discussion. So if you want to go fast, you go alone. If you want to go far, you go as a team. So we'll continue with that.
I'm going to adopt that. Is that okay? Okay, awesome. I'm like, I don't even know how to follow that. So mine's at a much smaller level than Charles. Thanks, Charles. I started out working with the Native American population, and I learned a whole new understanding of what resilience means. And for probably about 8 years, I worked with Gila River, Salt River, and Auction Native American reservations in Arizona. And actually, they show a lot of community care out there. And it's doing things without being asked and not expecting anything in return. And I would watch the communities just really come together for each other. Even after being out there for a while, they finally accepted me, and I went into their homes and schools and their works and to do therapy with them. And if they felt like I wasn't eating enough, here, you need to eat, you need to eat. And I was like, I'm not hungry. But it's, I guess that's where I learned a lot about community care and how beautiful it is. And I think if everybody just one act of kindness each day, how much different our world would be. Is that going to be something that can happen? I can only hope. And it's better than not having hope. But it's, I think it's always important to smile. I make eye contact with people, and I'm always looking. If they make eye contact, then I'll say hello or good afternoon. And I actually had a woman, I was running late for a meeting, and I ran into McDonald's to use the restroom. And of course, I'm one of those, if you use the restroom, you gotta buy something. Coming out, she stopped me, because on my way in, I had said, oh, good afternoon, and kept rushing by. And on my way back, she stopped me and she said, "You saw me." And I said, "Well, of course I did." And she's like, "No, you don't understand. I'm homeless." And she's like, "I was sitting here contemplating suicide because people walk by me, they won't look at me, and if they do, they look down at me like they're better than me." And I felt invisible mostly. It's just, "But you looked at me, you smiled, and you said good afternoon like I was a person." And I said, "Darling," I said, "you are a person, and you do matter." I said, "You're here for a reason, but you have to know that." And she's like, "I'm gonna change my life. I'm gonna get better. I'm not gonna, I know I'm not invisible now." And it was just one of those moments. It took 2 seconds, walking by, smiled, made eye contact, and said, "Good afternoon." And then for her to tell me that, I was just like, oh my gosh. And so now it's really something I do every day, because we really don't know the stories behind those smiles we see every day by people. Like I work with children primarily, and they're like, "Oh, this kid is blah, 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 blah." Well, you know, children don't act out, just act out. People don't just act out to act out. There's something they're not able to regulate within themselves, and they don't know what to call it or how to describe it or how to share it because they haven't been taught to use those tools. So anyway, it's those simple acts of kindness. If we all could just do that, even to ourselves. I mean, when's the last time anybody's looked in the mirror directly in the eyes of yourself and said, "Hey, I like you"? Most people can't. It's so uncomfortable. But if it's uncomfortable, there must be something you're not liking coming back at you, and you can change that. Our minds are so powerful, and it's, I don't know, pretty great. But I teach a lot of clients, I encompass the families, and I teach them all how to communicate and learn how to hear each other and understand, like, the children aren't you. Don't say, "As a child, I did this," because they're not you. They're an individual. They're not their brother. They're not their sister. They're an individual, and each child, each person, you have to adapt to the way they learn or hear or take in information or teach information. And it's just human kindness, really.
Well, that was beautiful. Thank you. I feel so inspired hearing that story. Thank you. It like touched my heart, which really brings us back to, from my view, community care is all about building healthy communities, and that starts with our view of how we view other people and our value for collectivism over individualism. So from my perspective and in living in Hawaii, where we still have a strong indigenous cultural value that is weaved into our community and culture, this value of hanai, of ohana, of hula. This concept is called imua. With paddling canoe, one of the biggest values with community is everybody is paddling together. And it's not just that we're paddling together, we're actually paddling at the same pace. And when we're paddling at the same pace and everybody is doing their best in their role, it's a very light flow. The boat actually feels really light and you can go really far. It's pretty amazing. So when it comes to community care and building community in my own business and in my own practice, the focus is very much on how do we build strengths and how do we position people within our group in their roles of strength so that we can all paddle with a little more grace and ease, not necessarily harder, just smarter, and we can have that lightness that comes from being in community with one another. The nuclear family isn't able to do it all. Our political system can't do it all. And we see this container that has all these cracks in it and all this energy, this money, this attention that we're putting into a system that has a lot of cracks and crevices. And from my perspective, community care, we could reference a lot from indigenous cultures that allow us to fill in those cracks and those crevices a little bit more through these tribal or hanai, which is similar concept to adoption, extending our resourcing out when we are full and overflowing, that we allow our concept of family and community to stretch out a little bit farther. And that can happen in the workplace, family, nonprofit, state. There's just so many ways that that can be expressed.
Just to add to that real quick, because in the Japanese culture, any like bowls that break, they'll take gold to fill it and refill it, and it's actually stronger than it was before it broke.
Oh, that's beautiful. So we have so much we can learn from some of these traditions. And that's one of the things I love about multiculturalism and diversity, and having that in our different environments, that we can learn from each other in ways like that.
They're pretty good, huh? You guys are great. I'm like, Ohana means family. Lilo and Stitch. This is how you know I have children. But like, I cried at that scene. So it's picking up on some of what you guys said. Recently, I occasionally, the news occasionally hits me up and says, hey, why are people shooting each other? Why is this happening? And you've probably all noticed that there seems to be more reports of violence happening in general. And we all know some of that is media skew and access, but there does actually seem to be some uptick. And I think it goes all the way back to the community support piece, right? Regardless of what may have initially led to having a huge number of people in their 30s and 40s who don't know how to emotionally process, which is interesting from a mental health perspective, but it's where we are. And that community support piece. How do we support people, like the person in the restaurant? How do we help each other to be better, to cope? How do we notice when somebody else is falling apart and fill them in with the gold? Make them bigger, stronger together. I think as a society here in the US, we do have very much still a bootstrap mentality. If something is wrong, you fix it. And if you can't fix it, well, you suck. Pretty much. And that's been really hard. And I do think we're finally kind of coming around and realizing maybe that hasn't been the best thing for our entire society. It's sort of all the way back to that first quote, doing something alone may get you there quickly, but you get there better when you help each other. And I think it's so important to know that. Even when I worked with kids, or if anybody's worked with addicts, I don't know if any of you guys work with addicts, we know one of the number one predictors of relapse is going back to the community you started in. And this goes back to anything we can do to make those communities stronger so that it's not the communities that are bringing people down.
That's beautifully put, all of you. Wonderful job. I really love how we just keep centering around how much it's so important and how important it is to really come back and use our area, use our community, which isn't just your family. It starts in your household, starts in your block, your street, your city, your county, your country, continent, etc. So really like how you guys all brought that together, which lines up for our next question for the panel. What changes or updates would you like to see in the growth of your community and related healthcare system or systems? So where can we grow? Where can we thrive?
So solutions.
Thank you, Jessica, for going first.
Yes, I'll volunteer. The most immediate solution that comes to mind to me is a restructuring of how we fund community care access. So being in private practice, there was such a desire to be able to serve our community with a little more freedom. I think a lot of us move into private practice in order to have that creative freedom. But the reimbursement rates to go into people's homes, into their environments, is just not there. There's not compensation for drive time to and from. Reimbursement rates sometimes are more difficult to receive when you change the location of service. Sometimes malpractice insurance doesn't cover you going into those environments. So going into people's communities, we learn a lot about their culture, their background, what type of resources they have available. We get a really good sense, diagnostically, just maybe what their needs are. Get a bigger picture perspective. So that'd be number one. Increase reimbursement rates, yes. Or state or federal funding that can actually go into these smaller businesses. Maybe that's idealistic, but that's one thing I would love to see. I'd also love to see us having more opportunities for education that would teach us ways to bring this Indigenous culture back into the workplace, back into families. I went to this tribal affiliation workshop one time. That was amazing. And one of the takeaways from it was we got into small groups, and it was pretty spontaneous, where we kind of went up to each other. And we were invited, make a commitment to at least 3 people from this conference that you're going to be in the same tribe as each other, and that you're going to be in touch with each other at least once a week for a year. I made some of the most lifelong new Ohana or Hanai family from that conference that today have been my natural mentors that are not related to me. And it actually helped me start my business because I was able to lean on some of their wisdom. It exposed me to an enormous amount of information and resourcing that I would not have been able to get from my nuclear family or anybody that was in my support system. And we learned some tools on just how to form those commitments with each other so that we could actually, in modern day, right here, right today, make a connection with another individual or a few other individuals where we could be a resource to each other. And it was a win because these individuals actually happened to be aging, and I was able to have some exchange in that relationship of offering, support, like delivering some crutches or, something that was a real practical need that I was more physically able to do. And it was absolutely beautiful, and I would love to see that type of model and teaching and learning opportunities happen in our world, because I think it would help our culture and our workplace and our family life and environment in enormous ways.
Okay. Yes, that. So I'm trying to figure out my and. I think back to the access piece. So we know reimbursement is a huge issue in general. A lot of us who go into private practice are private pay related to that. And there's a lot of guilt within our field, I think. Hello? Okay. For being private pay, because most people go into this field because they want to help, right? So you want to help, and in graduate school, most of us essentially have to, and hopefully very willingly, work with underserved populations. So then you leave and you realize that you have this choice between being this amazing individual who doesn't ever buy a home or anything yourself, or changing your rate plan, and that could be like a really, in general, we aren't all conditioned to feel good about that choice. So I think that in of itself, I think so just access in general, and so some of it's how we pay people, some of it's just making it easier for people to get that access, because the type of mental health help we need varies, and I think it's okay that there's reimbursement differences depending on what's being offered, essentially, but there's not enough of us, I think, despite the fact that we have this wonderful group up here. But I also think there's just the stigma piece. And again, things are getting better, but even when the care is there, do people feel comfortable accessing that care? Do they feel comfortable saying, hey, I think honestly, even saying I need help in and of itself is problematic. I think everybody could use a therapist. Is there anybody in here who doesn't enjoy venting to their friend every once in a while? Does anybody in here maybe complain about work a little too often to their spouse? And they're like, please stop doing that, right? Even the help thing implies there's something wrong. And it's back to the health community piece. The healthier we are as individuals, the healthier our community is. You don't need to wait until you feel broken. And I think things are improving. I talk to these 25-year-olds, and they're just full of insight. It's absolutely amazing. It's fantastic. But I think it's important we keep those conversations going, that in school, and some schools have started working in some mental health learning components. And I've also seen some people pushing back on that. But I think it's really important that we have that language as early as humanly possible, so that people know everybody struggles, everybody has hard days, everybody has stress, everybody has anxiety. Everybody has periods in their life when they feel depressed, and that's actually normal. And addressing it is how we stay healthy as an individual and as a community, not suppressing it or essentially making it really hard for people to access, either literally or just from a psychological standpoint, because we can't bring ourselves to do so.
I absolutely agree with you. I'll touch on that for just one second with the community component and integrating the discussion into the academic setting, especially at a young age, because I think a lot of youth, more so now, are starting to understand that your emotions, your brain are also a part of your physical health. These things are all included, they're all in one. And so I love how you guys touched on that. And then family of origin versus family of choice. You created a family of choice that you've really learned to depend on and work with and thrive with, and that's a beautiful thing. Go ahead.
Yeah, well, in terms of how best we serve the communities and what are the challenges, as a physician, it begins with the realization that every patient is unique. And then also every community is unique. And there's no way you can have the all-fit-all on communities. So for effective and sustainable communities healthcare delivery, it starts with assessing what does the community need. You have to involve them from the start of what you are planning to bring into that community, which means they have to be participatory in the decisions. They have to have that sense of ownership of the initiative you are trying to bring. And with that, once you effectively engage them, like we do with the mobile clinics, before ever we go down to the community, we have to do a bit of sit down together, plan with them to see what we are bringing so that they understand what we are coming to bring, and they buy into it. They have that sense of ownership in terms of the resources we are bringing. And what are the resources that we need? Resources means material, financial, and human resources. And once you have that sense of ownership from the community in terms of the healthcare delivery services you bring, it augurs for a lot more for sustainability. It augurs for them to accept it because I work in almost all countries in sub-Saharan Africa and also in Europe with lots of migrant populations. And every population is unique. And once we identify that from the onset, our initiative will be well-grounded, be it a community of diabetic from different cultural backgrounds. You have to harness that cultural differences. And with that, your initiative will be much more well-grounded. And even when you give information to them, it is normally said that information well adapted and culturally acceptable is very inspiring. If you transform that into knowledge, it's one of the greatest forces for change, behavioral changes. So you have to accept the cultural background. Somebody mentioned this as well, as Jessica said, in context of healthcare delivery, especially at the community level. So you have to tap into that. And with that, you can have a lot of sustainability in what you do. And this is one of the greatest strengths of my network, engaging with the community, be it the community of the service providers, community of doctors, providing the services, nurses, and everybody in terms of opinion leaders, etc. It's very essential to connect with the community so that your initiatives could be sustainable and acceptable.
And I followed you again. I know in our practice, everything is a we, us, ours. I always tell clients, I'm honored to be taking this walk with you, this journey, but it is your journey. As providers, we try to help illuminate the road and maybe move a couple things out of the way, but ultimately the journey is theirs. The lessons are in the challenge and teaching them they are strong enough, they can do it. And once they finally feel that experience, they just come to life. It's amazing. I know in our community, or in our practice, it was designed to look upper scaled, but we work with any population. It doesn't matter, where you come from, where you've been. I've worked with gang members. I've worked with murderers. This is where I was more in community care. But even now, I work with our state government access, and I don't care. I just don't care if they have insurance, don't have insurance. I do have some cash pay. But I think it doesn't matter what your socioeconomics is. Every single person deserves to have top quality care. I know I talked with Charles about they have Doctors Without Borders, but how come we don't have Mental Health Without Borders? Because I would love just to travel and help people and teach them. Everybody, we know what we're not good at, so I'm very strength-based, and I'm not going to tell a client or validate, oh yeah, it's not a great area for you. I don't. Everybody's great at something, and we grow and we build off of that strength. I even do a pro bono for caretakers, because a lot of times they can't afford the care because everything's going into taking care of whether it's a parent or a child, and they need, of all people, they need to have that support because they feel alone. They don't have money to take care of themselves or do self-care. And so that's our way of trying to give back to our community and offer that help. And usually it's 6 months to a year, depending on the client. Some pick up real fast, and they're like, okay, thank you. I'm going to leave that space for somebody else now, which is a beautiful thing to see somebody not be selfish and offer that up. But anyway, I don't know, hopefully, Charles, maybe we need to talk.
I think you just came up for an idea for the group, Therapists Without Borders. If anyone wants to run with it, come see Christine.
The Red Cross has a disaster mental health unit you can join potentially.
I want to be a Therapist Without Borders.
Okay.
I support it.
It's less borders, yeah. They're actually pretty amazing. I looked into that one too. So as we describe our communities we work with, the work that we do, and how much you guys are all obviously givers to the community and the work that you do, how do you practice self-care? What does that look like for you? Because as providers, we give, and we need to take care of ourselves as well. So what does that balance look like? And what does that look like also in your workplace or your organization? How do you help your fellow colleagues or providers or clinicians, doctors, manage that and practice that? And we're going to start with you, Christine.
Thanks.
You're welcome.
In the practice, the last 2 weeks of the year, every single year, whether it's admin, clinical, doesn't matter, we shut down for the last 2 weeks every year because I want staff to shut off, like click off of work. And it takes about a week to do that anyway, but I want them to be with their family, their friends. Mental health it's a tough field, and it's easy. It has a pretty high burnout rate too if you're not taking care of yourself. And I'm going to own this. I think community care is so much easier than self-care. But I know I was really good at it, but I also realized as you grow and you change as an individual, your self-care needs are going to also change. And so I'm in the process. I am working on this. I don't work overnights anymore and ridiculous hours. I'm trying to be mindful of that. But it comes back to that saying, like the oxygen mask, pretty much you got to put it on before you can help others. If I'm burnt out, I can't lead by example. I'm always one, practice what you preach. There is no growth in comfort. And that's how I ended up here doing all those things for staff. But it's, so that for me is important, but family is very important. I don't have a lot of family, but what I do have is so very important. And this moment, we don't get back. So whether we take for granted a lot of, next week, or I'll do this tomorrow, but we don't have that guarantee. And I learned at a very young age, my mother died a week before my birthday, and it is instilled in me, like, okay, I told her I was gonna come next weekend, and I didn't because she wasn't there anymore. So it's the whole don't go to bed mad, don't, those type of things, don't put everything off until tomorrow because you know what, we might not have that. So part of my self-care is like sitting in silence and thinking about what am I grateful. Every morning I wake up and I say, hey, beautiful girl, today's gonna be great. We're gonna do awesome. We're gonna do the best that we can be today. And at night, I try to reflect on my day because I'm human and I've had to learn to accept that I don't handle everything properly, but I learn to reflect on it, grow from it, and move forward with the lessons learned. And I've learned to leave the baggage behind because we're not meant to carry that. And I try to teach this to clients. So it's like telling clients, I'm not gonna tell them something that I'm not gonna try myself or haven't done or haven't seen work. But I'm also very organic. Our conversations are very organic. I do trauma therapy and there's like, wow, I never left trauma therapy laughing. But it's trying to teach them that to be kind to ourselves is a self-care for me, and learning that it's okay to not know everything, even though I usually get, well, you said, oh, you're right. I'm like, really? But it's just learning to be kind to ourselves. I know we just ran a series, a campaign called Love Yourself, and there was I think 4 or 5 different pieces to it. But so we got a lot of good feedback on that. So teaching self-care, I get self-care I love to see people smile, just simple little things.
Thank you.
Well, I very much support what you said.
Hard to follow.
And yeah, building upon that, I think with colleagues, we should be supportive to one another. It's very important. Our work should complement the work of others. It's nice to have a healthy competition. And I normally say, people don't create competition. You should not fear one, but you should be supportive to one another. And if you go to institutions or countries or the UN, the WHO, acknowledge them that they are the custodian. If a country is the Minister of Health, they are the custodian of the health of that country. You are there to complement your effort. If you have organizations, you are working in the same field, the real winners are the end users, the patients. Have a healthy competition, but be supportive to one another. Because if you synergize your efforts, you can maximize your output. So it's always nice to be supportive, and I do it more in our network. If I have organizations, You can become individual membership or organizational member of my network, and I support you to the best of my ability. And I use my United Nations status also in Geneva. Every year I bring organizations from all over the globe so that we can sit together. I call it Experience Sharing Forum. So we can share our knowledge, we can build upon our successes, and share the challenges people had so that somebody doesn't need to walk through that difficult path again. Because at the end of the day, it's the end user that are the real winners. So that's why I said working as a team, supporting one another is very crucial. And have a healthy competition will always be supportive. At the end of the day, go in for the grants. When you win the grants, you do your work, you do your study, share the results with others so that at least they can build upon what you've done. And with that, the world can be a better place. That's why in our network, we say together we can make it happen. Nobody's got a magic bullet to solve all the problems of the coal and low and middle income countries. We all share the same identity, which is why we take up the challenge to help. Thank you.
Okay, beautiful, so inspiring. Caring for the self. So we're not just human doers, we're actually human beings first. So when I think of self-care, I've built much of my world around this shift because this world that we live in requires a lot of doing, and that can be very exhausting. So taking those moments to just notice the self and what the needs are. For me, it's a daily practice of some sort, whatever the need is, just like food and oxygen and rest is doing something that is nourishing to the self at a core level, the mind, body, spirit, like connecting to that deeper layer, that core. And I've built my whole life around this. I get to go to work now with an entire team where in the interview process, that's a conversation we have. How do you take care of yourself? Because nobody else can do it for you, but you. And you have a value for mindful living, paying attention to the present moment, suspending for a moment, just simply practicing accepting. And that becomes a common bond. And so when we see somebody who's really stressed or overwhelmed or going through a really difficult life event, we're not just pushing them to plow through those experiences. We're actually inviting a pause for a moment to come up with some ideas or give that some space and time to just be human. And it's been kind of amazing that it's actually propelled a lot more productivity and on the back end by pausing on the front end. We start our meetings with some type of mindfulness-based practice, and it's 5, 10, 15 minutes out of our 45-minute time together, but we're all synced up. When our minds are scattered or in multiple directions, it can be really difficult to have a meeting where you actually are taking a team somewhere, but when you're all kind of synchronized through a breathing technique or some type of shared focus or intention, it's pretty powerful. So that's what self-care means to me, and that's how I've incorporated it into my entire life, including the people I get to go to work with every day.
I love that. I love the team meeting, beginning, getting all sunk up. I love that so much. So for me, it's my nails. It's like literal. My self-care is quite literal at this point in my life. And trying to remember. So the nice thing about things like this is you notice when you don't do it because they grow out. So and in all seriousness, I'm a big fan of what I consider positive self-sabotage, which is essentially when you set yourself up to not be able to fail. So, some practices like mindful meditation is extremely effective and it's wonderful, but if you don't have, let's say, somewhere you're checking it off, which most people don't, it might be easy to skip it today, I'm tired, and then I skip it tomorrow, and now it's been 2 weeks since I did it. So for me, I do have little things like my nails. So anybody who gets their nails done, they quite literally grow out, they chip, they can hurt. You're kind of forced to be now I have to go sit somewhere and just sit there. And I can't really do anything. And actually the one I picked has no reception coincidentally. So I can't even really do work on my phone, which is something I'm guilty of. And I talk to my clients about this too, because sometimes, and the only reason I agree with everything they said, I'm just not reiterating it because you guys did a really good job. So this is a yes and. But I have clients where I'm sometimes self-care is you don't look like you've had a haircut in 1,000 years. Sometimes the superficial stuff matters because that's also back to looking in the mirror, right? It's do I look in the mirror and like myself? And of course, your appearance shouldn't be why you like yourself, but we all grew up in the same world and we all have those same biases, and it does. So, doing those things that literally make you feel good matter too. And I think that's that whole person approach, which I think all of us, yes, therapists are like the worst. Doctors are too. Doctors are like terrible patients, right? But remembering that is important. When it comes to how I do it in my practice, sort of similar to you in the interview process, it's part of it. Less of a conversation, which probably has a lot to do with my A-type personality. I actually mandate like a lunch break after 3 clients. So like 3, you have, well 4, it can be 4, but after that you have to. Part of this is because in reality, if I see 6 people in a row, and I'm sure you guys run into this, I swear clients all have a text chain and they're like, hey, let's have a crisis all at the same time. And if you've had like 3 or 4 people in a row who are all in crisis, it's exhausting for you as a therapist. You're holding that space. So I tell them, hey, even if you don't think you need it, because therapists are terrible at self-care, so they never think they need a break, even if you don't, you have to. You have to. And we actually space out our sessions. We have a 15-minute break in between. Some of that is to allow room for when you have that client that needs the extra 10 minutes, so we're not having to say I have to stop. But some of it, I tell my therapist, you should be able to get a cup of coffee, go pee. Like, these are basic life needs that a lot of times we forget to stop and make time for, and then you're kind of always racing the clock just to take care of your basic needs. So within our group, and I am a big believer, one of you said it, about the whole, if we take care of ourselves, we take better care of our clients. I really think we have a high rate of burnout, and without fail, that is going to impact how we care for each other as well. The end.
That was so amazing. You guys are just great. You touch on like every point I could possibly think of, and I just love how wonderful you collaborate on this. We have about 5 minutes on our little timer here, so we wanted to leave some extra time for any questions from the group. We'd love to hear a wonderful, concise question that can be answered. So if anyone has anything they'd like to share, we would be happy to have you up to the microphone in the center and just tap, tap to make sure it works.
Right. Hello? Hey.
Perfect.
So
Hello.
thank you so much for an amazing talk. Honestly, it's phenomenal because I think this is one of these aspects that we just do not talk enough about or have much of a focus on in the day-to-day. My question to you guys is, this is the common question out there, which is, we know social media has a lot of negative effects on patients, people, and well-being. I'm going to ask a different form of that. What do you think are the positives in relation to social media and what we consume? Not just the negatives of it. We're fairly, and I think acutely aware of the problems that it brings up. But what are some of the positives that you may see in relation to using
Animal friend videos. Dogs and ducklings? Yep. No, seriously though. I mean, I know you're already going to say what I'm going to say, so I'm going to give it to you. But no, well, so I think we can choose to try and make the algorithm work for us, and have those positive exposures. For me, it might be ducks and puppies, but also, there's so many therapists and life coaches out there putting positive things out on social media. And so I think we can seek those things out, and sort of, it goes back to what we expose ourselves to. In the last panel, our moderator was talking about how she doesn't want to watch the news because it's so negative. And so similarly, what do you open on your phone? I mean, how many of us go to the bathroom and we just peek at our phone and then like 20 minutes later, our family's like, yeah, right? Right? And if you have fallen into the negative feed, I mean, that can really have an impact on you. Just the same as even like the music you choose to listen to can have this effect. I mean, everything in our environment ultimately impacts, even just subconsciously, kind of our baseline at that moment. So I definitely think it can be used for good, so to speak. Unfortunately, you probably have to be very, very, very tactical, because, in case anybody's missed this in some of the recent news and everything, the algorithms are designed to feed you things that you react to emotionally, and your strongest emotional reactions are usually negative. So we tend to stay on negative content longer. We could psychoanalyze the heck out of that one, but it just is a fact. So there might be 10 videos, and if only one of them's negative, that might seem like a good ratio, but if you spend more time on that negative one, guess what you're gonna get more of? So again, it's, curating our own content as much as possible, maybe like specifically following people and trying to only look at the things you follow and not just what it recommends, things like that.
I agree with you, being mindful of what we're listening to, what we're putting into our brains every day, what we're reading, hearing, everything. Go ahead.
I just wanted to piggyback on that again, using the algorithms to your own favor by what you give your attention to, and that does take discipline. So because I noticed that in my own life, I started this 100 Mindful Day challenge and wrote like 100 days of content of daily inspirations and put that out there as a free gift to the world for those who are trying to retrain their mindset to focus differently on what content they are giving their attention to. So thanks for bringing that up.
Is your username for them to follow?
It is at 100 Mindful Days Project, Instagram, on Facebook. Yeah, Jessica Brazil. And if you just go to one of those and you can DM me and I can add you to, it's a free daily inspiration email series right now. I'm working on turning it into other methods, but we do have to be intentional with what we are we're feeding our minds with as much as what we're ingesting physically in our bodies. And social media is actually, we can use that to our advantage if we use the algorithms right. We just have to retrain how much attention we're giving to that different content. So thanks for bringing that up.
At concierge psychologist. And I don't have any other cool thing to add to that. Except for me.
I would say, actually, I use it to my advantage, because I don't watch news or TV or anything just because of all the negative, but I do, LinkedIn is actually my go-to, and I'm always looking for positive, strength-based, and I use these things and I'll save them, and I'll have clients come in, we'll have a session, and they'll be on, I'm like, oh, hold on, and I'll send it to them, like, see, look, it's on LinkedIn, it must be true. But it's learning, the mind is so powerful. It believes what we tell it. And what most people don't understand is that the brain doesn't understand don't. So if there is your favorite food sitting right there, and I say, don't eat that, what do you see in your mind?
Eat that.
Exactly. So I tell people, okay, when they come in like, oh, I want to lose weight, and I'm not going to eat this, and I'm not going to eat that, and it's all sugar stuff, cupcakes, and I'm like, what are you craving right now? Like, everything I just said. I'm like, okay, so let's manipulate the brain. And of course I get checked like, oh, that's rewiring. I'm like, let's just call it what it is. We're manipulating it, okay? So it's like, I'm going to eat lean foods or whatever, the vegetables and all this great stuff, and they actually start craving that. And I actually learned, I used to crave, when I'd crave sugar, I love chocolate, or I used to, and I think, oh, I want to have some chocolate. But I learned that if I eat strawberries, organic ones, because those are really good, and I was never an organic person until this, or kiwi, it actually makes that craving go away. And now I don't crave chocolate, and I'm kind of bummed.
I never want to undo that.
What, right?
No.
Well, I look at it, I'm like, yeah, I don't want that. I'll eat a kiwi or something, But it's amazing if you learn how your brain works, because everybody's different. If you learn how to work it and manipulate it to do like reverse psychology on your own brain, it's pretty great. Yeah. But it's so it's a great question.
Last words.
Yeah, well, I think most of what I want to say has been said. But it's a very good question you pose. At times, that's the greatest challenge of the social media and even the Google, or the information, the negativity. And even as colleague physicians, when patients come to you, they've read all the negative things on the internet and they throw it at you. But it's your ability to actually dissect and tear apart, take it apart bit by bit, so that at the end of the day, the reality will hit them if you have the chance. That's it. But it's something we have to live with, and it's the positive side of it. Unfortunately, these other negative confounding factors we have to factor into our life and see. We had a conversation last night about kids and the thing they read on the internet, etc. And it's your ability as a parent to actually see, or as a physician, as the opinion leader in the community, to see how you can dissect this information and try to, like during the COVID-19, and there were so many theories there. In Switzerland, we had to get together the migrant community to have an open discussion, because these are the opinion leaders who are taking this information back to the other communities so that we have information sharing even about COVID-19. and what was on the media, there were so many wrong things that even as a scientist or physician, you feel frustrated that people can put up such things. But it is the world we live in, so you have to take a lot of patience to dissect and take them apart so that the reality will hit the person, rather than don't be confrontational, don't say don't do it, but rather than let's look at this information and see what's the merit about it. You may be right, you can start with that, and then slowly you dissect it to make sure that at the end of the day they see, okay, it's all false. Sorry, that's Java, it's all fake. Okay, thank you.
Thank you guys so much. That was such a wonderful discussion. Thank you for the great question.
Thank you to our panelists and to our moderator for a wonderful and exceptional, insightful panel. Now the moment you've all been waiting for. It's time to move on to the awards ceremony for the evening. But first, it's time to acknowledge the extraordinary efforts and achievements of transformative figures in the healthcare sector. It's my privilege to invite Drew Detzler, CMO of Demand Jump, to join us on stage to appreciate our sponsors with a certificate, Nemours Children's Health, BrainTap Inc., and Trigen Health. Accepting the award for the gold sponsor will be Carrie Officer, who you saw in a speech here earlier today. Carrie, are you in the building? All right, come on up.
Chairman.
Is Drew Detzler in the building? Drew, are you here? Awesome. Thank you. Thank you to Nemours Children's Health and to Carrie. Thank you so much. Accepting the award for the silver sponsor is Dr. Patrick K. Porter, founder and inventor of BrainTap Incorporated. Come on down, Dr. Patrick. Is Dr. Patrick Porter in the building? That's okay. We will accept this award on his behalf. Thank you so much. And our final sponsor is our bronze sponsor, Trigen Health. Is there a representative from Trigen here at the moment? That's okay too. We'll go ahead and accept this award on their behalf. A warm round of applause out to all of our donors. Thank you so much for making this event possible and for providing a wonderful atmosphere. Excellent. So, let's go ahead and start with the award ceremony. We will be presenting the award here on stage. Just a quick reminder, we're going to hold for just one moment. I'd like to go over the procedure for accepting your awards. Please come to the stage. It's incredibly important. Do not climb on the front. It is a safety hazard. Please use stairs to the left and to the right of the stage. When you come up, you'll accept your award, you'll pose for a picture, and then you'll be offered a few minutes, a minute and a half, a quick acceptance speech, and we'll move on to the next award. We'll start in just a few moments, and sit back and relax. Okay, we've had a slight change of plan. We're going to have a new presentee of the awards. Please welcome to the stage, Colleen Greco. Thanks for joining us, Colleen, and being a wonderful sport. Awesome. So, starting with our first honoree of the evening, this person is the president and founder of Blakebrook Ventures, LLC, and is a seasoned professional in the medical device industry with over 20 years of experience. Please welcome to the stage, Angela Doteson. Is Angela in the building? Angela, are you here? All right, we'll be accepting this award on your behalf. Thank you, Angela. On to our next awardee. This person is the CEO and founder of Becca Gordon Consulting Services, specializing in strategic optimization, commercialization, and revenue growth for digital health and femtech startups. Please welcome to the stage, Becca Gordon. Congratulations, Becca. Thank you. The next awardee is the Chief Experience Officer at Stress Free Initiative, where he combines his expertise as a physician, nurse, and life coach to revolutionize healthcare. Welcome to the stage, Conrad Aquino, MD. Thank you, Doctor. Just a quick reminder, you do get a small acceptance speech if you so wish. We have the microphone right behind our presenter.
And it's on.
Our next awardee is the founder and CEO of POC Thriving, specializing in mental health and diversity. With 14 years of clinical training, Dr. Coleman prioritizes the well-being of BIPOC individuals, professionals, and supports companies with inclusivity and mental health initiatives. Welcome to the stage, Dr. Christine Coleman.
Good evening. I will just take 1 minute, I promise. Thank you to all at the Health 2.0 conference for this incredible honor. For over 15 years, I've been committed to ensuring that equitable measures for mental health continue to positively affect communities across cultures, genders, and socioeconomic statuses. Thank you to all in this room for joining me in that effort. By honing in on marginalized communities that are most deeply impacted by systemic oppression, we can truly impact change on a collective level to ensure everyone has the access that they deserve. Thank you again for this immense honor.
Thank you, Doctor. Our next recipient is the CEO of Atlantic Medical Group, serving as an endobariatric gastroenterologist in Kinston, Jacksonville, and Charlotte, North Carolina. Please welcome to the stage, Dr. Eric Ebegdu.
Thank you so much for the organizers of the Calvary Conference and my colleagues and everyone that's here represented. My son has told me 15 times in a row to make sure to tell you he's my inspiration, so he is my inspiration. Well, indeed, we have been in the great state of North Carolina for the last 18 years, and it's just been a thrill to be able to serve the community and the United States as a whole, and now presenting and being able to provide innovative options that are non-surgical for weight loss is really what we do, and we are so excited to be part of what you're doing here, and I wish you all the best. Thank you.
Excellent, thank you. Our next awardee is a physician at Dr. Evka LLC and founder of ConvoMind.com. With a background rooted in humble beginnings, she embodies resilience and academic excellence, earning full scholarships for her dual medical and MPH degrees. Welcome to the stage, Dr. Evka Sesnik.
Okay, so I have all of your attention, which is wonderful. And as long as I hold the mic, you can't leave the room. This is wonderful. Just joking. So I want to thank everyone in the audience for you, because you're all amazing people. And as I'm getting to know you, I'm just wowed by everyone that's here. And I'm thinking about what I would like to depart to. And first of all, I just want to say, and I know some of you are from different countries, so I speak multiple languages. Gracias, thank you, Kusanam, Jakiem, Jackie. And I'm trying to think about a quote that really inspired me in my life, because to get to the point where I wrote books about pediatric feeding challenges, babies with colic, food allergies, and the list goes on, required a lot of difficulty in my life. And those really down moments, because when you rise from them, you get to a better place, even if those down moments are hard. And I'm thinking about what I want to share with you, and I hope that you have lots of happy moments in your life. I also hope that you have some moments of difficulty, because those will teach you gratitude and they'll propel you to a further level. Spread your messages, even if nobody's watching, even if you're just sharing them with yourself, because by spreading your messages and sharing them in your communities, other people will start to agree with you, and they'll start to think, you know what, I think the same thing too. And little by little, a community will surround you, and that community will grow, and before you know it, you will live a life of impact. And so I know many of you are living lives of impact, and I cannot wait to see the trajectories that your lives will continue to unfold. Thank you.
Thank you, Doctor. Well spoken. The next recipient is the Associate Medical Director and Assistant Professor of Internal Medicine and Care Medical Family Practice at Yale University. Please welcome to the stage Dr. Osama Kandalaz.
So much, just Health 2.0 for organizing this fantastic conference, and it's been a genuine pleasure. Contributed into the discussion and really contributed to the medical space and just information space that exists here. I would like to take the very quick opportunity to thank my beautiful fiance Jessica, who's sitting up there in the front row with the phone. Hello. And definitely my family back home in Jordan, who's just offered so much support throughout this entire journey. Really, the main driver for all of this has been a commitment to quality and making sure that our patients, the people that work with our patients, and the communities, organizations, institutions that work with us through that are taken care of in the best way possible. So this award is a reminder on a daily basis that that commitment to quality never ends, and that we should just keep striving for it as well. So that's a daily reminder for me that that mission isn't over. Thank you.
Excellent, wonderful speech, wonderful speech. Our next recipient is a professor and consultant at Neurodiversity of Northeast LLC, where she focuses on advancing the lives of individuals with developmental disabilities. Please welcome to the stage Dr. Pranali Hoyle.
Everybody I've met so far, and I continue to be in awe of this performance. Especially want to thank my children who are here and my husband, who are just always my biggest supporters everywhere we go. And yeah, our clan just follows everywhere we go. So thank you, everybody, and I'm looking forward to the rest of the day and tomorrow. Take care.
Excellent, congratulations. This next recipient is an esteemed leader, corporate board member, and chief information officer based in Scottsdale, Arizona. With decades of experience in leadership roles within multinational corporations, he consistently delivers results. Welcome to the stage, Joe Otto.
First, I want to thank for the honor. Appreciate the award, but really, it's a recognition of teams that you've had before as a leader. And so, I like to give more than receive. So, I'm going to give some leadership tips. But first, I want to congratulate Osama and Jessica on their, upcoming wedding, and enjoy Dubai. So, anybody? So, leadership tip. I've done a couple leadership conferences and spoken at them. What I find for leadership is set strong direction as a leader, and then get out of the way, monitor, but get out of the way and empower your team to really perform. That's one tip. The other is always look for the best team and develop the best team you can. Quick set of hands. How many of you know who Bill Belichick is and Nick Saban from football? So the coach of the Alabama team and New England Patriots. Do you know they coached together at Cleveland and got fired, right? And Nick Saban actually said it was the worst 4 years of his life. So, and then they went on later and had great teams, very high-performing teams, won a lot of championships. Why? Because they had a good team. And at Cleveland, they didn't. So that's really, a leadership tip that you don't think about. Develop your team. Keep developing your team. Improve your team. It's all about the team, the team, the team. Thank you.
Thank you. Our next recipient is a physician, speaker, author, and educator at International Medical Consultants Incorporated. His accomplishments include the best-selling book, Hope and Healing, A Case for Cannabis, and prestigious awards such as Physician of the Year. Please welcome to the stage, Joseph Rosado, MD.
Okay, this one I dedicate to my father, who committed suicide when I was 11 years old, but taught me an incredible work ethic and to try twice as hard as everybody else. So, Dad, for you, thank you. And thank you, everyone.
Thank you for sharing, Joseph. This next recipient is the proud owner of Pour Into You Mental Health and Wellness PLLC, providing psychotherapy in Houston, Texas. Please welcome to the stage, Kanisha Brown.
Hello, everyone. So, the mission of my private practice is to essentially normalize the health needs of us all. And when I say us all, I'm including myself, every other healthcare professional out there. I'm hoping that as much as we work and devote ourselves to ensure that our patients are feeling seen, that we're also providing those opportunities for ourselves. And so I'll leave you with this. It is my belief as well that if trauma and pain can pass through generations, then so can healing. So thank you all. It's been a blast.
Well said, Kanisha. Our next recipient is the chairman and CEO of Medikarma Incorporated. He is a seasoned tech entrepreneur known for his remarkable leadership in building successful organizations. Welcome back to the stage, Chris Narayan.
Thank you.
Thank you. Our next awardee is the CEO and founder of LRS Wellness, a visionary leader dedicated to the growth and development of her organization. Please welcome to the stage, Minu Basi.
Thank you so much for this opportunity, Health 2.0. Most importantly, I want to thank you, my husband, my strength, my pillar, my love, my babe. Thank you for being there. And my 3 beautiful daughters, Serena, Noreen, and Nemours. Thank you for being my strength. And most importantly, to my parents for raising such an amazing kid. So that's about it. Thank you, everyone. Remember, LRS's mission is to revolutionize wellness by empowering others. That's empowering each one of you to be you and to be the CEO of your own life. Thank you.
Amazing indeed. Our next recipient is the president and managing partner at GFR 90. Leads the commercialization of a wearable artificial kidney revolutionizing dialysis treatment. His dedication to advancing healthcare extends beyond his professional life, finding joy in family and life on a horse farm. Welcome to the stage, Norman Tiffin.
That award only has one name on it, but you don't bring a wearable artificial kidney to the market with one person. It's a team effort, not the least of which is let me thank you for the experience and the joy and the patience you bring to this project. He reminds us often that the group before us, if you were at that lecture, said several times there's an African proverb that says if you want to go fast, go alone. If you want to go far, go with others. And that's what we're doing. So thank you for this honor. We appreciate it.
Excellent. Thank you, Norman. Our next recipient is an executive leader with 30-plus years of experience in healthcare, tech, and academic medicine, and they currently hold numerous roles, including the John S. Dunn Presidential Distinguished Chair at Houston Methodist Hospital. Please welcome back to the stage, Professor Stephen T. Wong.
Thank you for the recognitions and really. I want to make a comment. Is I don't think it's a personal success. One success always a team, as someone said before. I'm very fortunate in my career. I've been working with very good teams at Harvard Medical School, at Brigham Women's Hospital, at UCSF, and now at Houston Methodist Hospital, Philips Healthcare also. And every one of them give me a lot of inspiration. about how we can contribute to a bigger self. And healthcare is the area that a lot of technologists, a lot of physicians, a lot of caregivers can really make an impact. Never regret this careers. Thank you very much.
Thank you. Our next recipient is the president of the PTSD Foundation of America, a passionate mental health advocate empowering veterans, first responders, and caregivers. Please welcome to the stage Ryan Rogers.
First, I want to thank my Lord and Savior Jesus Christ, because without him and his intervention in my life, I would not be where I'm at today. But there's more importantly two individuals in this room that I really want to thank. One is my wife, sitting in the back recording, and the other one is Ron, because without Ron's bold reaching out to me, I would not be in this position that I'm in right now. And I tell you, like, ultimately, our goal with this foundation is to empower veterans so that they have something else other than the alternative, which is killing themselves, giving them hope and healing and providing them a way out. And that's really what I hope to garner from this, is that empower veterans to make other choices other than killing themselves.
Excellent, thank you. Very noble. Our next recipient is a partner at the National Life Sciences and Healthcare Consulting in Delaware, Canada. Please welcome to the stage Shanil Ibrahim.
I'd like to share the same sentiment and thank the organizers for not only this award, but also bringing a lot of diverse leaders together in a fantastic conference. So I joined healthcare about 20 years ago, and I have had the privilege of serving this industry in a variety of roles. My role currently as a partner and life sciences and healthcare leader at Deloitte, as a clinical epidemiologist, and as a researcher. And for me, healthcare is a lot about service, so leadership for me is about how we serve the communities as well. So one of the things that, for me it's a huge honor is having met a lot of different leaders here. It's a huge honor for me to share this award with a diverse array of leaders from public sector, private sector, to government as well. So thank you, and looking forward to the rest of the conference.
Thank you. Our next recipient is an award-winning author, global speaker, and licensed clinical social worker with over 20 years of experience. Please welcome to the stage, Charisse Nance.
Coming all the way from Pittsburgh to receive this honor for the work that I'm doing in the profession. And I want to thank my team at Hand in Hand Counseling Services, who are back at home, so that I can be here to accept this award. And my company, Vitamin C Healing. I'm not selling vitamins, I get asked that all the time. It's metaphoric for healing of the whole person, mentally, emotionally, physically, psychologically, with a focus on healthcare professionals who struggle with compassion fatigue and burnout, inspired by my husband, Bill, who's taking pictures of me right now. And throughout my time in the healthcare profession, I'm sure many of you can agree, I've experienced compassion fatigue and burnout. It wasn't talked about when I was in school, and I was inspired to create an organization to support healthcare and mental health professionals and social workers who struggle with compassion fatigue and burnout. So this award is also dedicated to all of my colleagues who work tirelessly, who work selflessly, just to make sure that so many are taken care of, and also to address the systemic problem of compassion fatigue and burnout within organizations. Thank you.
Thank you. Our next recipient is a certified recreational therapist and health coach specializing in healthcare administration in the federal sector. Please welcome to the stage, Taylor Hooker.
Like others have said, I'll just quickly say that this award is built on the backs of giants, leaders, and VAs that are privileged in my career serving in the federal sector and serving veterans. And I encourage everyone here to take a deep stock at your own life, your leisure patterns, what you value, and help center that at the core of your life. You'll find lots of meaning, and I agree with my colleague here. We have lots to do to prevent PTSD and the suicide of our veterans. So if we can all rally together, I know that we'll create the world that we want to see. Thank you to our conference organizers, thank you to everybody here, and congratulations to my fellow winners. Thanks so much.
Thank you. Our next recipient is the president of the W Squared Group. He was named one of the top 100 healthcare leaders in 2018 and 2019, and one of the top 100 healthcare visionaries in 2020 and 2021. Welcome to the stage, Winston Wong.
Actually asked to go and give a 10-minute presentation, but I'll pass. Anyway, I would like to go in 2.0 for this information. I've been in the industry for almost 40 years. First as a general clinician, and then focus on pharmacology, and now I'm working something completely different. And I can tell you, I have seen change in the industry. I think the key to a leader is to be able to recognize and anticipate change and to stay ahead of that change. And this award, it confirms that that recognition is real, that recognition is there. And so I am motivated to keep on forging forward to the future. I hope I come back next year.
We hope you come back next year as well. Our next recipient is the founder and CEO of SparkTech International Limited, a serial entrepreneur spearheading multiple high-tech business ventures in Europe and China. Welcome to the stage, Yuting Shao.
So thank you for having me, and it's my great honor to receive this leadership award. I have spent the last 10 years in sales and manufacturing for pharmaceutical equipment, especially in the field of aseptic filling, inspection, and packaging solutions for pharma companies. I'm very grateful to have the chance actually to connect with global clients and serve them, ranging from India, China, Middle East, Europe to North American markets. I would like to thank you for all the team support along the way, and especially a special thank you to my mom. She's also here watching me now. I think please continue to focus and progress. We're gonna create a better future together for the healthcare sector and a wider society. Thank you, everyone.
Awesome, thank you. Our next award goes to BrainTap Inc. which is a revolutionary brain fitness company that uses light, sound, and vibration to provide an all-in-one solution for better sleep, reduced stress, and clearer thinking. On the behalf of this organization, Reggie-Ann Sidrol is going to receive the reward. Please come to the stage. Reggie-Ann, are you here? We will be accepting the award on their behalf. Thank you so much. Now our next recipient has an incredible name, and I apologize in advance if I mispronounce it. You're welcome to correct the pronunciation when you come on stage. They are the founder of Maximum Net Ltd, bringing over 20 years of experience in working with people with disabilities. Please welcome to the stage, Aitin Ben Itzhak Kuch. Are you here, Mr. Kuch? He is not. I will accept this award on his behalf. Thank you. I guess I did pronounce it right. All right. Our next recipient, you saw her here earlier today. She's the founder of LIT Wellness Solutions and is a passionate certified integrated mental health professional and registered dietitian nutritionist. Welcome to the stage, Tanya Jolliffe.
Depth to different conversations, and I have learned a great deal from each of you. I seek to bring healthy, happy, whole people to the workplace, helping, especially in the transportation industry, truck drivers, helping them to live healthy, happy, whole lives, because those are safer people out on the road, and also helping people move away from diet culture to embrace a culture of wellness. So I thank you for all that we're doing together for health and well-being, and moving from just physical well-being to embrace the whole person.
Excellent, thank you. Our next recipient is an innovative visionary vice president at Episcopal Health Services. Please welcome to the stage, Rosemary Bonilla. Rosemary, are you here? Okay, we will accept this award on your behalf. Thank you, Rosemary. Now, our second to last recipient is a seasoned SaaS IT strategy advisor, angel investor, and a board member. Please welcome to the stage, Ro Pathik.
Hope everyone's enjoying the conference. Thank you, first and foremost, to all the staff here at Internet 2.0, Health 2.0. Mom, in the background, thank you. I don't have this officially on the record, but I assume when I was born that asked for a warranty or refund policy for the doctor. And you told him basically shut up. So thank you for that. So it's been a long journey. Thank you for my partner, Matthew Maddox, President of Global Data Services. Without you, some of the accomplishments related to Oracle, as well as SaaS delivery, would not be possible without the efforts of your team. Finally, I'd like to thank the gentleman back there with the inspirational story. For Elevation Capital, one of our CPG companies is VivaZen. It's Feel Good Relief as one of the sponsors here. I'd rather, after I'm going to do something unorthodox. After hearing this gentleman's story back here, I'd like to go inspirational with this. And so Zen was founded by our founder and visionary, Steve Curtis. At the age of 19, Steve took a credit card for $500, raised by a low-income single mother, and turned it into $500 million. And so, at the age of 24, he was diagnosed with leukemia. He hired a bunch of MDs, Eastern medical practitioners across the world, and developed his own proprietary blend of different herbs and plants, and successfully beat cancer, and similarly climbed Mount Everest at the same time. If you're looking for an alternative boost, energy focus, reviews Zen throughout. I'd just like to say for the record, if you are pregnant or maybe soon, please exercise caution and visit our website. Thank you so much for all the esteemed colleagues. I hope you enjoy the conference and safe travels to everybody.
Excellent. Thank you, Ro. Now, our final recipient of the afternoon. They're the creator of Trace Together, which bridges the worlds of technology, public policy, and business. As a policymaker at Singapore's Ministry of Communications and Information, he was instrumental in driving the digital transformation of key economic sectors. As part of Singapore's Smart Nation vision, welcome to the stage, Jason Bay.
Trace Together is a project that my dad personally is leading the we launched in March of 2020 and then 8 weeks later, in the first 24 hours of it, in the first 6 months, it was 70% that to say that it will save thousands of lives. This technology is actually original everyday technology. It may happen, but we do not. We still want to do such a lot. I think that it will be sure.
Excellent. Thank you. Let's give a warm round of applause to all of our distinguished honorees who deserve our heartfelt congratulations. With the conclusion of another successful day at the Health 2.0 conference, we express our deepest gratitude to our gold sponsor, Nemours Children's Health, and silver sponsor, BrainTap Inc. Your invaluable support has been instrumental in the triumph of this event. And now let's gear up for our networking session, and we'll seize this golden opportunity to make meaningful connections, establish mentorships, and expand our professional networks. Don't forget to explore the exhibit booths and glean insights from our industry leaders. And here's to a delightful evening. We'll see you out there.